Hmm? Now let's start with the next topic, bachcho, and that is gastric cancer. Now, if I talk about gastric cancer, beta, okay, we know that as I told you, except oral cavity, esophagus, and the anal canal, beta, where we have squamous cell carcinoma more commonly. Apart from that, every other part of GIT will have adenocarcinoma itself. So please remember, beta, the stomach which is there, okay, it is going to have an adenocarcinoma. Important is if they ask you what is the most common site overall for a gastric adenocarcinoma. So याद रखना, the most common type, most common site overall, beta, for a gastric adenocarcinoma has to be the antrum of the stomach. Okay, so the most common site which is there overall has to be the antrum of the stomach. That means the distal part of the stomach. Whereas if they ask you, beta, that what is the most common site in the Western world, so the most common site in the Western world for a gastric adenocarcinoma would be the proximal part of the stomach, beta. That is the cardia, right? So please remember, in the Western world, beta, it is basically the proximal part of the stomach or the cardia, basically. Okay. Now, important is if they ask you what are going to be the risk factors for a gastric cancer. So as I told you, sarcari risk factors, that is nothing else but smoking and alcohol will always be there. Apart from that, beta, the other risk factors will be the patient having Helicobacter pylori infection. Beta, H. pylori is an important risk factor. I've told you a pre-malignant condition that we have discussed earlier, known as Menetrier disease. Beta, next adenomatous polyps. Beta, right? A patient who is having a gene mutation which is called as the APC. What is APC? Adenomatous polyposis coli gene mutation that causes FAP, right? The familial adenomatous polyposis syndrome. In that patient, beta, if there are multiple adenomatous polyps, even in the stomach, the patient may have cancer. Next, cases of gastritis, beta. Gastric cancer have shown more commonly association with blood group A, beta. Yes, so blood group A patients would be at a higher risk. Apart from that, smoked and preservative rich food, beta, that I've told you in esophageal cancer also, that the smoked food or the preservative rich food is going to be an important risk factor. Okay, and these preservative rich food, why it is considered as a risk factor, beta, I've told you because it has nitrosamines in it, which is a carcinogen. And beta, please remember, as this preservative rich food or the smoked food is going to be the main risk, as it is going to be important risk factor, beta, so therefore the incidence of gastric cancer will be more commonly seen in which country of the world? Due to that, beta, please remember, it is more commonly seen in the Japanese population, beta. It is more commonly seen in Japan, basically, right? That reason is definitely they actually store the food or they preserve the food for a longer duration of time, beta. Their food is mostly fermented, and that's the reason a lot of preservatives are added in their food, beta. The incidence of gastric cancer was very, very high in the Japanese population. First thing. Second important, the previous year question of your exam, and that was the incidence of which cancer has come down after the advent of refrigerator. Answer is gastric cancer, beta. Logic being, once the refrigerator came into the picture, beta, obviously we started using less preservatives in the food, because now to preserve or to store the food, beta, we were having refrigerator, right? That is important. So after the advent, beta, or after the refrigerator came into picture, the incidence of gastric cancer has decreased or increased. After that, the incidence of gastric cancer has decreased because we have started using less amount of preservatives in the food now. Okay, that is important. Another previous year question, and that was, beta, that gastric carcinoma which is there, definitely it is considered as the most common cause of what? So actually the question was vice versa, and that was FMG, previous FMG question, that which is the most common cause of gastric outlet obstruction, beta. याद रखना, overall the most common cause of gastric outlet obstruction will be a gastric cancer itself. If they ask you in a neonate, then your answer has to be CHPS. A lot of people directly marked it as neonate in CHPS, but no, please remember that. Okay, the gastric carcinoma which is there, it is actually going to be the most common cause of gastric outlet obstruction. It is going to be the most common cause of gastric outlet obstruction. Clear about? These are the points to be remembered, beta. Now, if they ask you what are the important gene mutations to cause a gastric cancer, So please remember, multiple gene mutations are responsible for causing a gastric cancer, beta. If I talk about the most important ones, so the first gene mutation that you need to remember, beta, is going to be the P53. As I told you, P53 is common in in multiple cancers of your body, beta. So P53 gene mutation is going to be the one. Second is going to be the APC that I told you, beta. And the third and the most important one, beta, which is actually associated with especially gastric cancer more commonly, and it is also going to have poor prognosis, beta. That gene mutation you have to remember is known as E-cadherin. I told you, beta, that E-cadherin gene mutation which is there, it is also associated with anybody. E-cadherin gene mutation, beta, we know it is also associated with, beta, the invasive lobular carcinoma of breast. Okay, that is important. That, as I've told you, it is also associated with gastric cancer. Now, the first classification that we need to know, beta, in pathology, you might have discussed about this classification about the gastric cancer, and that classification is nothing else but the Borman's classification, beta. Okay, so if I talk about the Borman's classification, basically Borman's pathological classification of gastric cancer, which is there. According to that, beta, the gastric cancer is actually classified into four types. According to this Borman's classification, gastric cancer is usually classified into four types, beta. The first type, which is that the type 1. Okay, the type 1 mein beta, you can see the cancer is actually growing outwards from the wall, beta. And when the cancer is growing outwards from the wall, exophytic growth, basically just like a polyp, beta. Okay, therefore it is called as a polypoidal tumor. So for class 1, which is there, beta, it is nothing as beta polypoidal tumor. Next, class 2 mein what happens, beta, you can see Borman's grade 2 mein now the cancer will start actually growing inside the wall. Okay, that means ulceration will start happening. So grade 2 mein beta, as the cancer starts growing in the wall, there will be a ulcerated tumor. Grade 3 mein beta, in Borman's grade 3, definitely, or Borman's type 3, beta, here you are able to see that now the cancer has started spreading inside the wall, beta. It has spread inside the muscles. Okay, it has started spreading inside the muscles, beta, and this is called as a fungating tumor, beta. And in Borman's grade 4 mein beta, there is a complete infiltration of the cancer into the wall. Can you see? It has also reached up to the serosa as well, beta. So mucosa, submucosa, muscularis, serosa, everything has been involved, beta. So yaad rakhna, in Borman's type 4, basically there is an infiltrating tumor which infiltrates throughout the stomach wall. And as the cancer infiltrates throughout the stomach wall, beta, that's the reason when you see the stomach wall now, it is going to become much thicker, beta. Right? The stomach wall of this patient will be very thick. And we know, beta, this kind of a stomach wall, basically, this kind of a wall, beta, it is similar to what? It is basically similar, beta, to the bottle that we used to have, beta, to carry water, basically. Older days में बेटा there used to be leather bottle for carrying water. ठीक है, पानी कैरी करने के लिए leather की bottle होती थी. That used to have a very thick wall. Just like that we have this, beta. That's the reason the grade 4 Borman's, which is there. The grade 4 Borman's is either called as a Linitis plastica, beta. Either you call it as Linitis plastica or we call it as the leather bottle stomach, beta. याद रखना ये बात, the grade 4 Borman's, which is there, either we call it as Linitis plastica due to thickening or the leather bottle stomach. Do remember this was a question basically. Okay, Linitis plastica, leather bottle stomach is which grade of Borman's classification? Answer was grade 4. Hopefully that's clear to all of you. Now, next important bit if I talk about is going to be nothing else but the another classification, beta, which classifies the gastric cancer as early and advanced. Reason, beta, because with the help of this classification we are actually going to treat the gastric cancer. Okay, the next classification, beta, if I say early gastric cancer, now early gastric cancer means what? Definitely the invasion which is there or the involvement which is there, beta, it is superficial. That means in early gastric cancer, beta, the cancer is only involving the inner layers, that is the mucosa and the submucosa. Okay, so when the cancer involves only the mucosa and submucosa with or without lymph nodes, beta, okay, that is what is called as an early gastric cancer, which is, and here majority of the patients are going to be asymptomatic, beta. Okay, that is important because the cancer is in the very early stages. Second is an advanced gastric cancer, beta. Advanced gastric cancer, that means the cancer has gone deep inside the wall now. And here advanced gastric cancer mein beta, now the cancer is involving even the muscle layer. So when mucosa, submucosa, muscle layer, everything is involved, beta, with or without the lymph nodes. That is what is called as the advanced gastric cancer. And in advanced gastric cancer, beta, yes, majority of the patients now will be symptomatic, beta. That has to be remembered. Okay. Now, if I talk about beta, the next classification for the gastric cancer, and that classification of the gastric cancer which is there, which it is nothing else but Lawrence classification. Now, if I talk about the Lawrence classification of gastric cancer, it usually classifies the gastric cancer into two types beta. The first one is called as the intestinal variety or the classical variety beta. The first one is the intestinal or the classical variety. Second is the diffuse or atypical variety. Second कौन सी है? The diffuse or the atypical variety is the second one. Now, important is beta if I talk about the basic differences between both the types beta. Let's start the differences. The first one beta is the age group. So याद रखना that intestine of the classical variety which is there beta, it is more common in the elderly patients beta. It is more common in the elderly patient. Usually which decade? It is more common in the 5th or 7th decade of life beta. It is more common in the 5th to 7th decade of life. On the other hand beta, please remember diffuse or the atypical variety is more common in younger patients. ठीक है? So we know na classical variety में all the classical symptoms will be seen. See, we know that gastric adenocarcinoma is more commonly seen in elderly patient. So here also it is more common in elderly. This is the atypical variety. Atypical matlab different from the classical one. So here it is more commonly seen in the younger patient. That is third to fourth decade of life beta. That is important. Second important feature that you need to remember beta, and that is sex. So please remember beta, in which sex basically the intestinal variety will be more common beta. याद रखना the intestinal variety which is there beta, it is usually more common in males as compared to females which it is more common in males as compared to females. On the other hand, the diffuse or the atypical variety, the diffuse or the atypical variety will be more common in females beta as compared to males. Next important, if they ask you which is the most common site, I've told you what is the classical site of the gastric cancer. Usually it is the antrum of the stomach, right? So in classical variety, okay, it is the distal part of the stomach beta, that is the antrum, which is going to be involved more commonly. Whereas in the diffuse or the atypical variety beta, it is the proximal part of the stomach beta, which is usually involved. No issues with this. Next important are the risk factors beta. So please remember bache, that your intestine of the classical variety is more commonly associated with environmental risk factors. Okay, all that smoking, alcohol, or definitely your preservative rich food. So all these environmental risk factors which are there, those are more common with the classical variety. Whereas the familial risk factors, that is gene mutations, genetics. Okay, so familial risk factors are more common with the diffuse variety. Next important, if they ask you beta histopathological examination पे क्या दिखेगा? Now why the classical variety is called as intestinal variety? Because on the biopsy or histopath beta, we are able to see intestine like features, and what is that? Gland formation will be seen beta. Yes, if you take a biopsy, definitely in a classical variety you will be able to see gland formation basically, and glands are usually seen in the intestine, right? Next important beta, if I talk about the diffuse or the atypical variety beta, a very classical feature is seen, and what is that? Here you will be able to see the malignant cells beta, with the nucleus of the cell almost pushed towards the periphery. Looks like what beta? Looks like a signet ring basically. So याद रखना signet ring cells, if they ask you on the gastric adenocarcinoma, याद रखना it is seen in the which variety? So signet ring cells are a classical feature of the diffuse variety beta. This is an important feature to be remembered. Next important, if I talk about bache, is going to be the spread. So याद रखना definitely the intestinal of the classical variety which is there. The intestinal of the classical variety usually spreads by the hematogenous route. Usually spreads via the hematogenous route beta. On the other hand, the diffuse or the atypical variety which is there beta, it either spreads by the lymphatic route more commonly, it either spreads by the lymphatic route beta or the transcoelomic route. Transcoelomic, that means via the cavities directly, okay, through the cavities, peritoneum se pleural, peritoneum se pelvis, like that. ठीक है? So either via lymphatic route or the transcoelomic route beta. Next important is the gene mutation. So याद रखना, the gene mutation in the intestinal of the classical variety is the APC gene mutation. The APC gene mutation is seen in the classical variety, but E-cadherin gene mutation is associated with the diffuse or the atypical variety. E-cadherin is associated with diffuse or atypical variety. याद रखना, with all these itself beta, you can definitely tell that the diffuse or the atypical variety which is there beta is actually going to have a poor prognosis. The diffuse or the atypical variety which is there beta usually has a poor prognosis or a poor outcome. Clear about that is important. Done with all of this. So do remember beta, diffuse में दो चीजें बहुत important है. First is definitely the signet ring cells on histopath. Second is the E-cadherin gene mutation that you have to remember at any case. Sorry. Now, what are going with sorry. What are going to be the clinical features of the patient? Which let's talk about them. If I talk about the clinical features, my patient is obviously going to have abdominal pain. Abdominal pain is a very common presenting complaint of the patient, beta. Apart from that, as there is a mass, beta, as there is a cancer arising from the stomach, so patient is going to come to me with a lump or a mass in the epigastrium, beta. So patient is going to have an epigastric lump, bache. Along with that, my patient will have all the signs of dyspepsia, beta, that is nausea, vomiting, indigestion, okay, reflux, bloating, all of these features of dyspepsia will be there. Next, the patient will have a postprandial fullness. Reason, beta, here obviously, bache, in the stomach, okay, there is a mass which is there. And if there's a mass in the stomach, obviously the capacity of the stomach is going to decrease. So even if you eat one roti, beta, you are immediately going to feel full, basically. So that is called as a postprandial fullness. Apart from that, the patient will have loss of appetite, beta, called as anorexia. Okay, and the patient will have weight loss. We know, beta, as the patient's appetite reduces over here, and there is a malignancy also. So patient has a very significant weight loss in cases of gastric adenocarcinoma. The patient will have cachexia, beta. I've told you the maximum weight loss is usually seen in esophageal and gastric cancer in a patient. Next, upper GI bleeding, beta. Because it is a malignancy, so new blood vessels will grow in the mass, and those new blood vessels, beta, they will be fragile. They will easily rupture, causing upper GI bleeding, that is hematemesis. Now, if they ask you about metastasis, beta, very important point to be remembered. Okay. So please remember gastric adenocarcinoma, which is there, beta. It usually metastasizes to multiple sites, beta. Okay, it metastasizes to multiple sites. Let's talk about them. So if they ask you, beta, that which is the most common site for distant metastasis in a gastric adenocarcinoma, तो याद रखना है बेटा, the most common site for distant metastasis in a gastric adenocarcinoma has to be the liver, beta. The most common site for distant metastasis. I told you for all GIT cancers, the most common site for distant metastasis is your bichara liver itself, beta. Now, if they ask you what are the other sites of metastasis, bache, if they ask you definitely what are the other sites of metastasis. Now, first of all, beta, if I talk about the periumbilical metastasis, beta, तो पेरियम्बलाइकल मेटास्टासिस की बात करेंगे तो इन द पेरियम्बलाइकल रीजन, बेटा, द मेटास्टासिस विल बी इन दिस काइंड ऑफ अ मैनर, बेटा. दिस इज द पेरियम्बलाइकल मेटास्टासिस. Here you are able to see these nodules, beta, and these nodules which are there, they are classically called as the sister Mary Joseph nodules. This has been a previous year question. This is what is classically called as the sister Mary Joseph nodules, beta. Okay, so do remember that. Next important beta, if I talk about the second one, that is left supraclavicular lymph node. So if there is metastasis to the left supraclavicular lymph node, beta, here you are able to see that in the left supraclavicular lymph node, basically, beta, we are having metastasis in the patient. Okay, and this left supraclavicular lymph node metastasis which is there, it is nothing else but called as the Virchow's node, beta. Okay, this left supraclavicular lymph node which is enlarged now, it is known as the Virchow's node, or we can even call it as which sign, bache? We can even call it as the Troisier sign. We can even call it as the Troisier sign. Either you can call it as the Virchow's node, beta, or you can call it as the Troisier sign. Next important, if they ask you, beta, bilateral ovarian metastasis, तो याद रखना bilateral ovarian metastasis if I talk about. Okay, so bilateral ovarian metastasis में बेटा याद रखना, I hope all of you are quite aware. So the patient comes to me with a bilateral ovarian mass, and when we take a histopath or a biopsy of that bilateral ovarian mass, beta, okay, in that bilateral ovarian mass you are able to see these kind of cells, beta. Now what are these cells? Basically you can see, beta, these are the cells with the nucleus that is pushed towards the periphery. So definitely, can we call them as signet ring cells? Yes. So please remember, if signet ring cells will be seen on ovarian mass, beta, then definitely it is not a primary ovarian cancer. It is actually a metastasis from the gastric adenocarcinoma. And this you might have studied in gynecology, beta. It's classically called as the Krukenberg's tumor, beta. So bilateral ovarian metastasis from a gastric adenocarcinoma showing a signet ring appearance, beta, in the ovaries is known as a Krukenberg tumor, bache. Clear about? Next important, if I talk about, bache, is the multiple seborrheic keratosis. The another picture which is there, beta, this one over here is what is suggestive of a multiple seborrheic keratosis. This is actually a marker of the cancer or marker of a malignancy. On the back of the patient, you will be able to see seborrheic keratosis, beta, and this multiple seborrheic keratosis on the back of the patient in a case of gastric adenocarcinoma, beta, is called as a lesser Trellat sign, beta. It's classically called as the lesser Trellat sign. याद रखना, in gastric cancers or in GI malignancies, beta, We are also able to see that blackish velvety appearance of skin known as acanthosis nigricans. That is also a marker of malignancy beta. Okay. Next important here beta, you will be able to see the patient is having a left axillary lymph node metastasis. Now left axillary lymph node metastasis is known as the Irish node beta. Left axillary lymph node metastasis will be called as Irish node. And lastly, there can also be metastasis in the pouch of Douglas in females or rectovesical pouch in males beta. ठीक है, rectovesical pouch in males. So pouch of Douglas in females beta or rectovesical pouch in males, and this is classically called as Blummer shelf beta. That will be classically called as the Blummer shelf. So can you see definitely that the gastric adenocarcinoma can metastasize at so many sites beta, and almost all every site is going to have a special name. The first three that I've told you, the system Mary Joseph nodules, Virchow's node known as Troisier sign, and Krukenberg tumor, are very important and have been asked in your examinations earlier. So do remember them अच्छे से. Great, all of you. Done with this. Now let's move further. If I talk about what is the investigation of choice in a patient of a gastric cancer beta, please do remember that in a patient of a gastric cancer, definitely, okay, what is the feature that will be able to see? Investigation of choice, which is there beta, it has to be an upper GI endoscopy plus biopsy. Investigation of choice, I have told you beta, this all the statements which are there will be almost similar to a esophageal cancer. Okay, all the diagnosis part will be same to the esophageal cancer. So यहाँ पे upper GI endoscopy plus biopsy should be the investigation of choice beta, first thing. Second, what is the investigation of choice for T and N staging? I told you beta, for tumor and nodal staging, okay, the investigation of choice is important. They have asked this earlier. क्या करते हैं अपन? We actually pass a ultrasound probe up to the patient's stomach beta, and then that ultrasound which is there, it actually studies the wall and the surrounding areas. So it is nothing else but an endoscopic ultrasound. So endoscopic ultrasound is going to be used beta for the T and N, that is tumor and the nodal staging in a patient of gastric adenocarcinoma beta. Next important, if they ask you what is the investigation of choice for TNM staging, what is TNM? That is tumor, nodal and distant metastasis beta. अगर overall staging करनी है, so overall staging के लिए the investigation of choice we know beta has to be a PET CT, right? So distant metastasis के लिए we have to do a PET scan, and for the local tumor we can go for the CT scan. So together PET CT will be the best investigation to do a overall staging of the gastric cancer. Now let's talk about the management beta. If I talk about management in patients of gastric cancer, which is okay, first of all, if it is a case of an early gastric cancer, I have told you beta, if it is an early gastric cancer, what we can do, can we go inside the stomach? That means can we go for an endoscopy? And after doing endoscopy beta, can I just do an endoscopic mucosal resection? Why? Because in early gastric cancer beta, the involvement is only up to the mucosa and submucosa. So can we just do a resection definitely with some normal margins with the help of an endoscopy itself? Yes. So early gastric cancer mein beta, the management which is there is nothing else but an endoscopic mucosal resection. You don't have to remove the stomach in this condition. Okay. The management which is there for early gastric cancer has to be an endoscopic mucosal resection. Next important beta, if I talk about, is the advanced gastric cancer. If I talk about the advanced gastric cancer bache, so please remember that advanced gastric cancer mein what we have to do, advanced gastric cancer mein the involvement of muscles is also seen beta, and that's the reason here we have to go for a gastrectomy surgery. Now we have to remove the stomach beta, and as we have to do a gastrectomy beta, now either we will go for a partial gastrectomy or we could go for a total gastrectomy also. That depends basically on the site of involvement beta, kahan pe cancer hai. How much should be the margins? याद रखना बेटा, the proximal margin in a case of gastrectomy beta, the proximal margins in a gastrectomy should be 5 centimeter, and the distal margin in the gastrectomy surgery should always be the pylorus beta. ठीक है, distal margin जो होता है, it should always be the pylorus. Okay, why? What is the reason? We'll talk about it. Now first of all beta, if I talk about, if the cancer is in the distal part of the stomach, ठीक है, so we know na more common site is basically the distal part of the stomach, the antrum. Okay, so if the cancer is in the antrum of the stomach, for example, distal part of stomach, what can we do beta? Can we definitely just resect the antrum of the stomach? Yes, we can just remove the antrum of the stomach beta. That will be called as a partial gastrectomy. And once we have done a partial gastrectomy beta, after that whatever is the stomach remaining behind beta, whatever is the stomach remaining behind, to that definitely beta we can do a anastomosis now. ठीक है. So what we have done, we have removed only the distal part of the stomach, okay, and that is called as a distal gastrectomy or a partial gastrectomy beta. But after that, now whatever is the stomach left behind, we can connect that stomach directly to the duodenum beta. That will be called as a gastroduodenal anastomosis, or we can call it as a gastroduodenostomy. But if the gap is too much between them, then we know duodenum cannot be pulled. So then we have to pull up the jejunum and connect it over there beta. And then we can go for a gastrojejunostomy or a gastrojejunal anastomosis. Clear hai baat? So please remember bache, if the cancer is in the distal stomach, we go for a partial or a total gastrectomy. We go for a partial gastrectomy beta. याद रखना, we have to go for a partial gastrectomy. Next important beta, after doing a partial gastrectomy, then what we do with, we have to go it for which anastomosis beta, either a gastroduodenostomy or a gastrojejunostomy. I am just writing GD stomy or GJ stomy. That is gastroduodenostomy or a gastrojejunostomy beta. Okay, so if the cancer is in the distal part of stomach, we go for a proximal gastrectomy with a gastroduodenal or a gastrojejunostomy beta, whatever is possible. Next, if the cancer is in the proximal part of the stomach beta, now important is beta, okay, so please remember that, yes, end to end would be done beta in gastroduodenostomy, but end to end agar nahi possible hai, so then you have to pull up the jejunum and you have to go for an end to side anastomosis. Gastrojejunostomy cannot be end to end. Gastrojejunostomy कर ही इसलिए रहे because the difference between caliber is too much and we have to do a end to side anastomosis. ठीक है, so that is important. No issues with this. Now if the cancer is in the proximal part of the stomach beta, please remember, if the cancer is in the proximal part of stomach, what is going to be the problem now? Understand. If the cancer is in this part of the stomach beta, can I just remove the proximal part of stomach? No. Reason beta, if I remove the proximal part of stomach only, what is going to be the problem? Now please tell me beta, how can you connect a so narrow esophagus beta? How can you connect basically this esophagus to this broad stomach now? Is it possible that you can go for an end-to-end anastomosis of the esophagus and the stomach? No, you neither can pull the stomach to perform an end-to-side anastomosis, right? So that's the reason beta, in proximal stomach cancer, it is never possible bache to perform any kind of a partial gastrectomy. In this we have to perform always a total gastrectomy, and total gastrectomy, that means we have to remove the pylorus also. So obviously, can I say that whether you do a distal gastrectomy, that is a partial one, or you do a total gastrectomy, the distal margin is always the pylorus. Got your answer now? ठीक है, so यहाँ पे बेटा we do a total gastrectomy when the cancer is in the proximal part of the stomach, and after doing the total gastrectomy beta, obviously I cannot pull the duodenum over here. Reason, duodenum is fixed, I close it over there itself. Then whom I am going to pull up it or pull over here beta? Obviously beta, I am actually going to pull the jejunum over here, and we are going to connect the jejunum to the esophagus beta. Sorry, end to end we can do. If it is possible, we can go for an end-to-end anastomosis. If it's not possible beta, then we can go for a end to side anastomosis. But we have to do a esophagojejunostomy. Clear hai baat? So yaad rakhna, if they ask you that when the cancer is in the proximal part of stomach bache, so what we have to do? We have to go for a total gastrectomy. Okay, we have to go for a total gastrectomy over here. And after going for a total gastrectomy, now what has to be done? Which anastomosis has to be done? We have to go for a esophagojejunostomy beta. EJ stomy is a esophagojejunostomy. Clear to all of you now? Next important, if they say beta that if the patient is having a advanced gastric cancer, if the patient is having a advanced gastric cancer beta, so obviously we know we have to give chemotherapy also, because in chemotherapy is usually given whenever the lymph nodes are positive beta. Okay, whenever the lymph nodes are positive. Now important is which is the chemotherapy that we give, the same one beta, that is cisplatin and 5-fluorouracil. Okay, it is the cisplatin and the 5-fluorouracil beta, that is the chemotherapy regime that we use in cases of gastric cancer also. Now if they ask you beta, if I have to do a lymph node dissection, we know now that if the patient is having a gastric cancer, basically I've told you the management is gastrectomy plus minus lymph node dissection. That means you have to do a removal of the stomach with or without lymph node dissection. But if you remove the lymph nodes beta, how many lymph nodes will be removed? That is important feature. Okay, if they ask you how many lymph nodes are to be removed, तो याद रखना है बेटा, you can write over here that the lymph nodes that are to be removed, minimum कितने होंगे? Maximum lymph nodes I've told you are removed basically in a patient of gastric cancer only. The minimum 16 lymph nodes are removed beta. याद रखना minimum 16 lymph nodes are removed when we have to do a lymph node dissection basically. तो याद रखना whenever you have to do a lymph node dissection तो याद रखो minimum 16 lymph nodes are removed in a patient of gastric cancer. Clear to all of you? Next important, radiotherapy is also given beta. We know that radiotherapy is always given beta to prevent the recurrence, and we have to give radiotherapy in a patient of gastric cancer beta at the gastric bed. I hope all of you are quite aware the organs forming the gastric bed. So at the level of the gastric bed beta, you have to give the radiotherapy. Now if they ask you beta that which is going to be the most important prognostic factor, as I told you beta, what is the most important thing in gastric or GIT cancers? It is definitely beta the depth of invasion, how deep the cancer is, right? Because that decides the staging now. So if they ask you that which is the most important prognostic factor in a gastric cancer beta, the answer has to be depth of invasion. The most important prognostic factor in a gastric cancer, if they ask, the answer has to be depth of invasion. No issues with this, anybody? So do remember that. Now if I talk about beta, that is the another stomach tumor beta, and that tumor is known as GIST beta. What is GIST basically? It is the gastrointestinal stromal tumor beta. Okay. The next tumor which I am going to talk about is nothing else but a GIST beta. That is a gastrointestinal stromal tumor. So if I talk about GIST or a gastrointestinal stromal tumor, which you have to remember that this tumor which is there, it does not arise from the epithelium like gastric adenocarcinoma which was there. It was arising from the columnar epithelium of the stomach now. So GIST which is there beta, by the name it is evident, stromal tumor, and stroma is what? Connective tissue or the mesenchyme beta. So GIST basically is not an epithelial tumor, it is a mesenchymal tumor. Rather, I would say GIST is the most common mesenchymal tumor of the GIT beta. That has to be remembered. So please remember that GIST which is there, as I've told you, it is going to be the most common mesenchymal tumor of GIT. It is the most common mesenchymal tumor of GIT beta. Yes, in GIT matlab it can occur in the intestine also, it can occur in the stomach also beta. Yeah, more common site is going to be the stomach. If they say it arises from which cells, so I hope all of you are quite aware it arises from the pacemaker cells of GIT. And I hope all of you are quite aware which are the pacemaker cells of GIT beta. So yaad rakhna, the pacemaker cells of GIT are going to be the interstitial cells of, they are going to be the interstitial cells of Kahal beta. Kahal bolo, Kajal bolo, whatever you want to call it, but just remember that. Okay. So the interstitial cells of Kahal which are there beta, definitely those are going to be the most common site. Okay, interstitial cells of Kahal which are there, those are going to be the most common site definitely for the GIST to begin. याद रखना important question. Next important, as I told you, it can occur anywhere in the GIT. Na? It can occur in the stomach also and the intestine also. But more commonly, it is going to occur inside the stomach of the patient. More commonly, it will occur in the stomach. If they ask you which is the most common gene mutation, this you might have studied in pathology beta, that the most common gene mutation in a patient of GIST which is there is going to be the c-KIT gene beta. The most common gene mutation that you are able to see definitely in a patient of GIST has to be the c-KIT gene. Okay, do remember the c-KIT gene. Now, if I talk about another important question of pathology, and that is tumor markers beta. So, yaad rakhna, the tumor markers which are positive for a GIST beta. The tumor markers which are going to be positive for a GIST. So, if they ask you beta that which is the most specific tumor marker, which is the most specific tumor marker or the best tumor marker beta, then your answer has to be dog1. Okay, if they ask you which is the best tumor marker or the most specific tumor marker, then your answer has to be dog1 beta. Whereas if they ask you which is the most sensitive or the most common tumor marker beta, the most sensitive or the most common tumor marker has to be CD117. The most common or the most sensitive tumor marker has to be CD117 beta. Clear about? Do not make a mistake over here, which is, so the most specific or the best tumor marker is dog1. The most sensitive or the most common tumor marker is CD117, and the gene mutation has to be c-KIT. Now important is beta, if they ask you that the GIST which is there, it is actually a part of which triad beta. Yaad rakhna, the GIST which is there, it can occur as a part of the Carney's triad beta. It can actually occur as a part of the Carney's triad. And what are the three features in Carney's triad? Carnage triad में बेटा the patient is going to have a gastric gist. Yes, there will be a gastrointestinal stromal tumor in the stomach. Second, the patient will have multiple paraganglionomas beta. Patient will have multiple paraganglionomas, and the patient will have a pulmonary chondroma beta. The patient will have a pulmonary chondroma. These three features, if they are present in a patient beta, that is what is classically known as the Carney's triad. Now, if they ask you beta, what is going to be the route of spread? So, yaad rakhna, we know that all your epithelial malignancies beta, they commonly spread via the lymphatic route, and all your mesenchymal malignancies or all your mesenchymal tumors beta, they commonly spread via the hematogenous route or the blood route beta. So does the gist. Gist also more commonly spreads beta via the hematogenous route, and when it spreads via the hematogenous route beta, then the most common site of spread, if they ask you, answer is again the liver beta. So whether it is a epithelial tumor or it is a mesenchymal tumor, does not matter beta. Liver is the only site where they are going to metastasize. Okay. Now if they ask you what is the clinical features, and this is important beta, reason is definitely they have asked in a previous year examination that what is the most common clinical presentation in a patient of GIST. So a lot of people mark it as pain and lump. No beta, pain and lump could be the common presentations for a gastric adenocarcinoma, not for a case of GIST. अब GIST में एक special feature है बेटा, what, that this tumor which is there बेटा, the GIST which is there, it usually does not grow outside from the wall. Yes, it actually grows inside the wall बेटा, ये wall के अंदर grow होता है. It does not grow outside. Normally gastric cancer ऐसे grow होता है ना. Here it grows inside the wall beta, and therefore it also has a risk of perforation as well. Okay, but the gist which is there beta, we have to remember that it is actually a mesenchymal tumor. Mesenchymal tumor मतलब connective tissue tumor, and we know that even blood vessels are a mesenchyme only na. Blood vessels are also a mesenchymal tissue. Therefore beta, in this tumor there will be a lot of blood vessels beta, and as there will be a lot of new blood vessels beta, here these fragile blood vessels will rupture and they may cause a bleeding. So therefore, the most common clinical presentation in a patient of GIST which is there beta is going to be an upper GI hemorrhage or upper GI bleeding, right? So yaad rakhna, the most common clinical presentation in a patient of GIST beta is going to be an upper GI hemorrhage or upper GI bleeding. Okay? So upper GI hemorrhage or bleeding beta is going to be the most common clinical presentation in the person. Apart from that beta, obviously the patient may have other features like the patient may also have a mass inside the stomach. At times it would be feel late होता है बेटा, वो mass हो सकता है but it is actually a late presenting symptom. Next, the patient may have pain also, and as I told you, the patient may have a high risk of perforation because the tumor grows in the wall this time. Now important is if they ask you what is the investigation of choice, बोलो जल्दी. It is a tumor, so what should be the investigation of choice? Anybody? Let me know in the chat box जल्दी से. What is the investigation of choice in a patient of a GIST basically? What do you think? So please remember beta that the investigation of choice in this patient has to be a CECT abdomen. Okay, the investigation of choice in this patient has to be a CECT abdomen beta. Why not a upper GI endoscopy and biopsy? Reason beta, biopsy is actually not recommended in this patient because it is a vascular tumor, and if in a vascular tumor if you take a biopsy beta, the patient will have bleeding. Okay, the patient will have maximum bleeding beta. That's the reason definitely biopsy is not recommended. याद रखना, the investigation of choice is CECT abdomen. Biopsy is not recommended beta. Okay, biopsy is usually not recommended in the patient to be done because that can cause bleeding further. No issues with this. Next important beta, if they ask you what is the mainstay of management, so yaad rakhna, just mein beta, the mainstay of management which is there, it is nothing else but surgery itself. That's the reason we are studying it over here. So please remember beta, the management of GIST is nothing else but a surgical resection of the tumor with some normal margins beta. We have to do a surgical resection of tumor beta with a 2 centimeter normal margins. 1 to 2 centimeters it is taken, but maximum is 2 centimeter. So surgical resection with 2 centimeters of normal margins has to be taken beta. No issues with this, but this is usually done for a benign GIST beta. Yes, please remember majority of the GIST which are there, almost 80-90% GIST are going to be benign in nature only beta. But yes, there are certain cases which can be malignant, and if it is a case of a malignant GIST which or a metastatic cyst. When it is a malignant cyst or a metastatic cyst which has already spread out of the liver beta, then obviously we know malignant or metastatic cyst mein beta, doing a surgery is not useful. So here we try to manage the patient beta without a surgery, okay, and that is usually done with the help of a drug. Now understand, the c-kit gene mutation which has happened now, due to that beta there was activation of a tyrosine kinase enzyme which is actually going to cause proliferation. So what we will do, we can give tyrosine kinase inhibitors in the patient. I hope all of you are quite aware. The tyrosine kinase inhibitors which are used for the treatment of cancers beta. The drug of choice over here is going to be which drug, anybody? It is going to be a drug known as imatinib beta. I hope all of you are quite aware. Imatinib is also a drug of choice for CML, chronic myeloid leukemia. ठीक है, याद रखना ये बात. Now, imatinib is the first generation tyrosine kinase inhibitor. If the patient who is there, beta, is resistant to imatinib, if the patient who is there, bache, is resistant to imatinib, then the second generation tyrosine kinase inhibitor like sunitinib can be given. The second generation tyrosine kinase inhibitor like sunitinib can also be used. Clear about that has to be remembered, beta. So do remember that this is the classical findings in a patient of GIST, beta. Okay, so this is all about GIST that you need to remember. Let's talk about the next one, beta. That is the third tumor in the stomach, and that is nothing else but a gastric lymphoma, beta. Now, when I talk about a gastric lymphoma, okay, when I talk about a gastric lymphoma, very few points to be remembered. First thing, beta, we know that lymphoma is actually a malignancy, beta, though it seems like a benign tumor. Okay, so it is a malignancy. We know there are two types of lymphoma, Hodgkin's and non-Hodgkin's. And I've yesterday itself told you in thyroid, beta, that whenever a tumor occurs outside the lymph nodes, beta, okay, extranodal sites, it is always a non-Hodgkin's lymphoma. Okay, the non-Hodgkin's lymphoma will be there in the stomach. And yesterday itself I told you that which is the most common type of non-Hodgkin's lymphoma in any other organ. The most common type of non-Hodgkin's lymphoma, whether they ask you CNS, stomach, thyroid, anything, beta, the most common type of non-Hodgkin's lymphoma has to be answered as DLBCL, beta. What was DLBCL? Yesterday I've written that is diffuse large B cell lymphoma, beta, right? It is nothing else but a diffuse large B cell lymphoma. It is actually the most common type of non-Hodgkin's lymphoma, beta, which will be seen in the patient. Okay, so that has to be remembered. Next important, beta, if I ask you that which is the most common extranodal site, beta, तो याद रखना है the most common extranodal site, that is outside the lymph nodes, which is the most common extranodal site for the lymphoma where you are studying, that is nothing else but stomach, beta. So outside the lymph node, if they ask you that non-Hodgkin's lymphoma occur more commonly in which site, answer has to be stomach, beta. Yes, it is more even common than thyroid. If they ask you, beta, what will be the symptom? As it is a tumor growing inside the stomach, beta, the patient will present to you with an epigastric lump. The patient is going to have an epigastric lump over here. Apart from that, beta, the patient is going to have upper GI hemorrhage here also. And along with that, we have always discussed, beta, that non-Hodgkin lymphomas usually present with category B symptoms, beta. Category B symptoms are the ones which are very similar to tuberculosis, beta. That is, the patient will have weight loss, the patient is going to have night sweats, and there will be a low-grade fever. Okay? These are the features in category B symptoms. Investigation of choice, if they ask you, beta, yaad rakhna hai baat. Here, definitely, it is not a mesenchymal tumor. So that is the reason you can easily go, beta, for upper GI endoscopy plus biopsy. So the investigation of choice over here has to be an upper GI endoscopy plus biopsy to be done. Now, along with that, definitely, beta, if they ask you, what is the treatment in the patient? Yaad rakhna, beta, the treatment in this patient is nothing else but chemotherapy, because I've told you majority of the lymphomas are chemosensitive, beta. They respond well to chemotherapy. So here also, beta, we should go for a chemotherapy in the patient. Okay, and chemotherapy in a patient of non-Hodgkin's lymphoma is given via which regime? I told you it is given via the R-CHOP regime, beta. R-CHOP में क्या आता है? R for rituximab, C for cyclophosphamide, H for hydroxydonomycin, O for oncovin, and P for prednisolone. Followed by that, beta, here you have to go for what? Followed by that, beta, for the residual tumor. If after chemotherapy, beta, if the lymphoma which is there is not completely gone, then definitely we have to go for a surgical resection of the tumor after that. Okay, we have to go for a surgical resection of the tumor. That has to be remembered. No issues with this, anybody? Okay, so that is important to be remembered. Now, next important, beta, if I talk about basically what is the next condition, and that next condition which is there, beta, it is nothing else but a gastric volvulus beta. Okay, the next condition which is there, it is nothing else but a gastric volvulus. Now what do I mean by volvulus? एक बार याद रख लेना, what is volvulus? Volvulus is nothing else but twisting of a organ or mal rotation of a organ बेटा. हाँ, अगर एक organ जो है वो अगर twist हो जाता है बेटा, उसको बोला जाता है volvulus. ठीक है? So please remember बेटा, in the GIT volvulus can be seen at multiple sites. The most common site of volvulus is usually the sigmoid colon beta, but we are also able to see beta very commonly volvulus in the patient's stomach as well. Now if I talk about beta the gastric volvulus now, okay, if I talk about the gastric volvulus, do remember that gastric volvulus mein what happens, the patient is going to have malrotation of the stomach. The patient will have twisting or malrotation of the stomach beta. Now that twisting can be of two types beta. Either the stomach is rotating around its own axis beta, okay, so that is called as a vertical volvulus, definitely, right? So here what happens, this is the stomach and here the stomach rotates around its own axis beta, that is called as a organoaxial volvulus beta. This is known as a organoaxial because it is rotating around its own axis beta. Or the second one beta, when the stomach is going to rotate basically around the mesenteric axis beta. Okay, when the stomach rotates around the mesenteric axis. What do I mean by this? That means here definitely there will be a horizontal volvulus beta. Here there will be a horizontal volvulus basically. Okay, the first one was vertical volvulus, the second one is a horizontal volvulus beta. That is important to be remembered. And when definitely there will be a volvulus in the stomach, I hope all of you are quite aware. If there is a volvulus in the stomach beta, obviously what is going to happen, that the stomach wall which is there beta, it will get compressed, and if the stomach wall is compressed, even the blood vessels inside the stomach wall will be compressed beta, and that's the reason definitely the stomach the part of the stomach which has undergone twisting beta, the part of the stomach which has undergone twisting, as you can see, it is not receiving any blood supply, and as it is not receiving any blood supply beta, therefore it has immediately started undergoing necrosis beta, right? This here what are we what are you be able to see beta? Here definitely there is necrosis which has started, right? That is important. So please remember beta, when the stomach undergoes a twisting, the blood vessels are compressed and therefore the twisted part of the stomach will not receive enough blood supply, which can lead to ischemic necrosis at that site immediately. Clinical feature beta, in a patient of gastric volvulus, the clinical features are remembered with the name of a triad beta, and that triad is classically called as the Borchardt triad beta. Borchardt triad which is there, definitely it is the classical one. Okay, so Borchardt triad definitely beta, it is nothing else but the classical triad to be remembered in a patient of a gastric volvulus. Now what is the Borchardt triad beta? That has to be remembered. First is, as the stomach undergoes a twisting over here, as the stomach has undergone a twisting over here beta, the patient is going to have an upper abdominal pain beta. The patient who is there is going to have a upper abdominal pain or an epigastric pain beta, right? Second important, as the stomach is twisted, the food is not able to pass further. That's the reason there is regurgitation causing retching or vomiting of food beta. The patient is going to have retching or vomiting beta. And lastly, third, if the stomach is twisted beta, will you be able to pass a nasogastric tube beta? No, the nasogastric tube will not go into the patient's stomach beta, and that's the reason the third one is inability to pass the rise tube or the nasogastric tube beta. Okay, so that is important. So the three features which are seen in patient of gastric volvulus is upper abdominal or an epigastric pain, retching or vomiting episodes continuously, and inability to pass the nasogastric or the rise tube. This is classically known as the Borchardt triad. Next important, if they ask you beta, what is the investigation of choice? I have to see beta that which part of the stomach has twisted and whether the stomach is actually receiving the blood supply or not, and whether the stomach has undergone necrosis or not. So yaad rakhna beta, the investigation of choice has to be a CECT abdomen. I have to go for an CECT abdomen beta, which will tell me about all these details that I've just now discussed. Okay, so CECT abdomen has to be the investigation of choice over here to be done. Now if they ask you what should be the management, obviously beta, if the stomach has already been necrosed, if the stomach is already necrosed, then can I keep that necrosed stomach? No, obviously we have to go for a gastrectomy. If the stomach has already been necrosed beta, then we have to go for a gastrectomy, depending on the involvement, whether I have to go for a partial gastrectomy or a total gastrectomy, and then which anastomosis has to be done. That will be completely decided based on the findings, definitely when you open the patient and when you see definitely how much part is necros. Based on that we are going to decide what we have to do. Okay, next important beta is, if the stomach is not necros, that means the patient has come to us early beta, and therefore here the necrosis has not begun yet. If the necrosis has not started yet beta, can I save the stomach? Yes, obviously. So here the stomach has twisted. Now, what we can do? We can actually bring the stomach beta back into the normal position. As we are able to bring the patient, but sorry, the stomach once back into the normal position beta, this is called as derotation. Okay. So to bring the stomach back into the normal position beta will be called as derotation. And after that, you have to fix the stomach with the help of sutures beta. And fixation is known as pexy. So that will be called as gastropexy. Why gastropexy? So that the beta the patient does not have a volvulus again. The recurrence could be avoided. So if the stomach is not necrosed beta, we have to go for a derotation and gastropexy. Okay. If the stomach is not necrosed, we have to go for a derotation and a gastropexy. Clear to all of you now? That has to be remembered. Chalo. Done with this. Next important beta if I talk about. Okay, next important if I talk about beta is nothing else but the bezors basically. Okay, next important if I talk about is the bezors. Now what are bezors basically beta? See, important is if some stuff which is there beta, it is collected inside the stomach itself. Okay, it is not able to pass further. Okay, and that leads to that accumulation beta. So due to that accumulation of some substances in the stomach, the structure which is formed is known as a bezor. Okay, so what is bezor basically? Bezor is nothing else but beta collection of some substances inside the stomach. Okay, and why there is collection of substances inside the stomach? Because beta the substances are not able to pass further and there is gastric stasis. So due to gastric stasis beta, there is collection of these substances in the stomach. The first one that we are able to see beta is known as a trichobezor. The first one which is there beta is nothing else but the trichobezor. Now if I talk about tricho beta, what is tricho? Tricho means hair. So trichobezor which is there beta, it is nothing else but collection of hair beta. Okay, trichobezor which is there beta, it is nothing else but collection of hair. Next important if I talk about trichobezor is seen in which patients beta. We know that obviously not a normal person is obviously not going to eat up hair beta. So it is usually seen in females beta who are actually suffering from a psychiatric disorder. And in that psychiatric disorder beta, you might have studied this female has an irresistible urge beta or as an impulse to pull out her own hair beta. Okay, and that condition is known as trichotillomania. And after pulling out her own hair beta, she eats those hairs. That is called as trichophagia. So due to that beta, the patient is actually going to have what you have to perform. Laparoscopic beta, laparoscopic could be done. There is no issue in that, but usually we go for an open one because we are not sure about the extent. That's the reason. Trichobezor, which is there beta, please remember that. Trichobezor, which is there definitely. Here there is collection of hair and it is usually seen beta in young psychiatric females. Okay? It is usually seen in a young psychiatric females beta. And these females who are there, they are usually suffering from a condition beta that where they are having an irresistible desire to pluck out or to pull out their own hair, and that condition is known as trichotillomania beta. That condition that you have to remember which is known as trichotillomania. So these females are suffering from trichotillomania and later on they eat those same hairs beta after pulling them out, and that is called as a trichophagia. So they will give you a history of trichotillomania or trichophagia in the female beta, after which the patient is actually going to have this trichobezol like collection in the stomach. Okay. So obviously beta, if you do the investigation, you will be able to see this kind of a trichobezor beta. And when you remove it surgically beta, this is the trichobezor which is seen. Can you see the hairs which are there? They have actually taken the shape of the stomach. So many hairs have collected inside the stomach. Okay. This one which is there beta, yaad rakhna, this trichobezor which is there beta. This has been given in your examinations earlier, okay? And they once asked definitely what is the diagnosis. Answer was trichobezor. Second time they definitely asked beta that what should be the treatment in the patient. The answer was clear beta. The answer was nothing else but surgical removal we have to do, right? We can go for a endoscopic surgical removal. Now endoscopic removal could be done or a open surgical removal can be done beta. Depends. If it is a very small one, then we can go for an endoscopic removal. But if it is a large one, we have to go for an open surgical removal over here. Okay, that is important. Now, the another question which came in your examination beta, and that was that this trichobezor was given in the picture beta, and they asked that the female is actually having this kind of collection inside her stomach. Okay, this kind of collection was retrieved in a stomach after the surgery. Okay, after the surgery, the patient should be referred to which among the following specialists for consultation. We know better that the female is having a psychiatric disorder, so the female should be referred for consultation beta to a psychiatrist. So refer for consultation to a psychiatrist. If she has not already been looking at the psychiatrist, better to send her to a psychiatrist beta. Now this is one type of a bezoar beta known as the trichobezoar. There are other types of bezoars also beta. The next type of bezoar that we are able to see is beta in this picture out here. And what is this? Here you are able to see beta the plant material or the vegetable material beta collected inside the patient's intestine. Again, bezoar is not only collected in the stomach, it can be anywhere in the intestine, in anywhere in the GIT beta, wherever there is stasis of food basically or stasis of substances and collection over there. That can lead to formation of a bezoar. More commonly it is seen in the stomach because stasis is more common in the stomach. First thing, okay? Second, it can not only be only hair beta, it can be anything. So here you are able to see beta the vegetable matter basically collected inside the patient's GIT. This is what is called as a phytobezoar beta. So what is phytobezoar? Phytobezoar beta, it is nothing else but collection of vegetable matter if it occurs in the GIT beta. That is what is called as a phytobezoar. Clear about? Next important is lactatobezor. If I talk about lactatobezor, what is lactatobezor? Collection of milk and dairy products which is there beta. Collection of milk and dairy products which is there is what is known as a lactatobezor. Collection of the milk and dairy products which is there beta is known as a lactatobezor. That has to be remembered. No issues with this. Now let's talk about the next one beta, and that is nothing else but the bariatric surgery. If I talk about bariatric surgery beta, I hope all of you are quite aware that bariatric surgery is also known as the metabolic surgery beta, and it is actually the surgery which is done for weight loss. Yes, normally for a weight loss beta, the first line management is always the lifestyle modification. After that, we always try medical management beta. There are drugs which are there. You have an anti-diabetic drug known as liraglutide which helps in weight loss. Okay, so a lot of things can be tried beta, but even after that, if the patient is not able to reduce weight, in those conditions beta, we have to go for a bariatric surgery. Okay, it is actually a growing specialty now in surgery. Okay, so now if I talk about the bariatric surgery, if I talk about a bariatric surgery, it is also known as beta AKAL, right? It is also known as a metabolic surgery. Now this surgery which is there beta, as I've told you, it is basically a surgery which is done for the purpose of weight loss beta. It is a surgery done for weight loss, but in which patients beta? Obviously not in the patients who are just overweight or who are just having mild obesity. No, it is only done in patients beta who are actually having morbid obesity. Okay, who are basically having morbid obesity beta, and they fail to lose the weight beta. The patients with morbid obesity who fail to lose the weight basically by trying almost everything. That means what they have tried, they have definitely tried lifestyle changes, they have tried pharmacotherapy, and they have tried psychotherapy. Now you'll be like, sir, psychotherapy? Yes, but I hope all of you are quite aware. In surgery, sorry, in psychiatry, you might have discussed about a disorder beta known as binge eating disorder, not bulimia, not anorexia, only binge eating disorder, where the patient eats a lot of food beta and does not do anything after that. So definitely in those conditions, the patient may have weight gain. So you should also go for a psychotherapy if the patient is having any of the psychiatric disorders. Okay, so even after trying all of that beta, still the patient is not able to lose the weight. That is what is an indication of bariatric surgery. Now if they ask you what are the indications beta, what is the cutoff value of the BMI or body mass index after which we have to do a bariatric surgery in a patient beta? So if I talk about this, so yaad rakhna, the cutoff basically for the body mass index after which we have to go for a bariatric or a metabolic surgery will be if the patient has a BMI of more than 40. Okay, with or without comorbidities. Now what is comorbidities beta? Comorbidities is nothing else but beta the associated disorders which will be there, like diabetes mellitus, hypertension, take hyperlipidemia. Okay, all of these conditions which are there beta, hypertension for that matter, take OSA for that matter, or osteoarthritis, all of them. So yaad rakhna, if the patient is having a BMI of more than 40, does not matter whether he is having any comorbidities or not beta. A BMI of 40, a BMI of more than 40 individually is a indication of a bariatric surgery beta. BMI of more than 40 is a individual indicator of a surgery itself. Next important beta, BMI of more than 35. okay, a BMI of more than 35 beta, but with comorbidities, okay, so we can also go for a bariatric surgery beta at a BMI of more than 35, but the condition is what? The condition is the patient should have comorbidities then, okay. So BMI of more than 35 with comorbidities, that can also be an indication of surgery. No issues with this, anybody? That has to be remembered beta, okay. So that is important. Whereas if I talk about beta, these are the cutoffs which are there definitely for the standard cutoffs, or basically the cutoffs set according to the Western population, right? And we know beta Western population are already obese. Normally they are somewhat obese as compared to a Asian population beta. Okay, तो एशियन पॉपुलेशन के लिए ऑब्वियसली द कट ऑफ शुड बी समवॉट डिफरेंट. ओके, सो एशियन पॉपुलेशन के लिए बेटा द बीएमआई कट ऑफ व्हिच इज देयर. So please remember, with or without comorbidities beta, it can be more than 37.5. So our cutoff, our BMI, if it is more than 37.5 beta, okay, Asian population mein, if the cutoff is more than 37.5, then we have to go for a bariatric surgery with or without comorbidities, does not matter. Okay. Next important, if we can also go for a bariatric surgery beta if the cutoff is more than 32.5 beta with comorbidities. अगर patient में disease है, then at a BMI of more than 32.5 also beta we can take a patient for a bariatric surgery. ठीक है. These are the cutoffs. What are the comorbidities associated with it? So do remember beta, the comorbidities which are associated with the case of bariatric surgery which is there. The first one that you have to remember beta is the type 2 diabetes mellitus. I hope all of you are quite aware. Type 2 diabetes mellitus mein due to insulin resistance the patient has obesity. Next beta, the patient having hypertension. Next, a case of coronary artery disease. Okay, that means the cases of angina usually. Then the patients of metabolic syndrome. I hope all of you are quite aware from medicine. Metabolic syndrome is diabetes mellitus, hypertension, hyperlipidemia, obesity, all of that together. Okay. Next important is osteoarthritis. Why? Because of extreme weight beta, the patient is actually going to develop osteoarthritis in the joints. Okay, mainly in the knee joints. Or a patient having obstructive sleep apnea. Now, what is this condition? So, yaad rakhna beta, in medicine you might have studied when a patient is extremely obese beta, there is a lot of fat tissue usually around the neck, okay, and that fat tissue actually can cause compression beta during the sleep as well. So please remember, it can actually cause snoring during the sleep, and it can also be a important complication beta. That's the reason if the patient is having OSA. So if comorbidities are present beta, then at a BMI of more than 35 in worldwide, or at a BMI of more than 32.5 itself beta, we can take up the patient for a bariatric surgery. Okay. Now, important is if they ask you beta, which is the most effective and the most common bariatric surgery. Now, you have to just see beta first, and then we will talk about the most common and most effective. The three types of bariatric surgeries which are there. The first one is, here we are able to see beta. We will do the surgery with the help of a laparoscopy beta, and we just have to apply a adjustable band over the stomach beta, right? As you apply this adjustable band over the stomach, bache, what is going to happen? Please remember, once this adjustable band has been applied over the stomach, the access port of this band which is there, it is kept at the level of umbilicus beta. Via this access port beta, we are actually going to inject saline inside it. Okay, we are actually going to inject saline inside it. Why? So that once you inject saline beta, this gastric band which is there, it is going to inflate, and as this gastric band is going to inflate beta, it is actually going to compress the stomach. Okay, when this gastric band is inflated with the saline from the access port, it is actually going to compress the stomach. And if the stomach of the patient will get compressed, will the patient be able to eat a lot of food? No beta. As the stomach is compressed beta, if the patient tries to eat a lot of food, the patient will immediately get a lot of bloating over here. That's the reason beta, the patient does not eat a lot of food. And this surgery is either called as a gastric banding only, or you can call it as a laparoscopic adjustable gastric banding beta. Okay, so you can call it as gastric banding or a laparoscopic adjustable gastric banding. Okay, that is the one and the same thing. But beta, in this surgery, failure rates are very high. Reason? Because if the patient is educated beta, he can actually learn to access the, he can actually learn beta to operate this access port, and maybe that patient can definitely drain all the saline beta from the port basically, and he can definitely eat a lot of food, and after a few hours beta, he can again inflate the gastric band. Okay, so that's the reason beta, here with the laparoscopic adjustable gastric banding beta, there can be chances of failure beta if the patient is not very willing for the surgery. Okay, so that is important. Second important beta, it is this one. This is known as a sleeve gastrectomy. Now gastrectomy is what beta? Removal of stomach. So here basically what we do, here we actually use a linear stapler. I have told you linear stapler. So with that linear stapler beta, you can cut out and immediately staple the stomach. So what we have done over here, understand. Here, beta, we have actually applied the stapler between the in the middle of the stomach itself. As you have applied the stapler beta in the middle of stomach, obviously this part of the stomach which is there, beta, it has got resected. Yes, this is the resected part of the stomach. We have removed this part of the stomach. So now, what is the part of stomach left behind? Only this much. And as you can see, beta, this part of the stomach, doesn't it look like the sleeve of a shirt? Yes, that's the reason, beta. Here now only a gastric sleeve has been left after the surgery. Therefore, it is called as a sleeve gastrectomy. And now, obviously, only a very small size of the sorry, stomach has been left behind, beta. Therefore, the appetite of the patient is going to decrease. And as the appetite of the patient decreases, obviously, the patient is going to have weight loss, beta. That is important to be seen. Okay, no issues with this. This is actually the most common bariatric surgery, beta, that we tend to perform. Okay, because it is easy to perform also, and the outcome rates which are there, they are pretty good. Next important, beta, the best surgery which is there, it is this one. And what is this surgery over here? It is known as a Roux-en-Y gastric bypass surgery, beta. This is going to be the Roux-en-Y gastric bypass surgery. Now, when I talk about a Roux-en-Y gastric bypass surgery, what we are doing over here, understand. Here, beta, we are trying to bypass the stomach directly. That means the food will not go into the patient's stomach. Kaise? Understand. We have to first of all cut this part of the stomach, beta. And what we are going to do, we are going to cut the jejunum and we are directly going to pull the jejunum up. So what we have done, we have directly pulled up the jejunum, beta, and now we have actually sutured the jejunum, or we have performed an anastomosis of the jejunum, beta, with the esophagus or with the small gastric pouch which is left. Okay, so we have directly, beta, anastomose or connected this jejunum which is there, beta, with this esophagus or the small gastric pouch, so that what is going to happen now. Now, definitely, beta, the food when it comes from the esophagus, it will directly enter into the patient's jejunum, beta. And once it enters into the patient's jejunum, it will travel further. Now, beta, okay, the food is traveling via the patient's jejunum, that's fine. Okay, so that what is going to happen? Here, the food is actually going to bypass the stomach. And when the food will not go into the stomach, beta, the food is going to bypass the stomach. What will be the benefit? We know, beta, that when definitely the patient's food goes into the stomach, it stays collected. We know stomach has an extensive distension capacity, beta. It will keep on distending more and more. Okay, and the patient keeps on eating more and more. But, beta, if you directly connect the jejunum now, what is going to happen? Here, beta, if the patient tries to eat a lot, immediately the patient will get a lot of bloating sensation, nausea and vomiting like features, beta, called as which syndrome we had discussed, early dumping syndrome, right? So when a lot of food goes into the patient's jejunum, beta, the patient actually may suffer from this problem, beta, that the patient immediately gets a bloating sensation. That's the reason, definitely, beta, we are trying to do this surgery, so that the patient will not eat too much. The patient will try to avoid eating excessively. Okay, next important is, beta, definitely. Now, here this is fine that the food is directly going into the jejunum. No issues with that. Problem is, beta, we know that for the digestion or absorption of food, we need the bile juice as well. We need the bile as well as definitely the pancreatic juices, beta. Now, if you have to mix bile or the pancreatic juices, what you should do, definitely, you should connect this duodenum, beta, to the jejunum, because definitely, beta, the bile or the pancreatic juices are going to drain in the second part of duodenum itself. That is the reason, beta, this jejunum which we have cut, beta, we are actually connecting this part of the jejunum back to this main lumen of the jejunum, beta. So here we are doing an anastomosis between the two parts of jejunum itself. Here we have done an anastomosis, beta, between the two parts of jejunum itself, and this will be called as a jejunal anastomosis or a jejuno-jejunostomy. Clear about this? Is important to be remembered. So this is classically called as which surgery, beta? This is the Roux-en-Y gastric bypass surgery. Why Roux-en-Y? Because this limb which is created, beta, obviously, as I told you, this is an extra limb. An extra limb is known as the Roux-en-Y limb. And how many anastomoses have been made? Definitely, beta, here we have made two anastomoses. The first one is basically made either with the esophagus or the gastric pouch, and second one definitely is made with the jejunum and jejunum itself. Okay, so two anastomoses and one extra limb is always called as a Roux-en-Y surgery. So if they ask you, beta, that which is the most effective surgery for a bariatrics, so most effective bariatric surgery which is there, beta, the most effective bariatric surgery has to be the Roux-en-Y gastric bypass surgery. It has to be the Roux-en-Y gastric bypass surgery. But if they ask you, as this surgery is much complex, right? As this surgery is much complex. Therefore, if they ask you, beta, that which is the most common surgery to be performed, As I told you beta, the most common surgery which is performed is nothing else but a sleeve gastrectomy beta. The most common bariatric surgery that we perform is known as a sleeve gastrectomy. No issues with this, anybody? Chalo. Done with this? That has to be remembered. Next important beta, if I talk about what could be the complications of this bariatric surgery beta, there are certain complications which are associated commonly with bariatric surgery beta. As you are cutting out the stomach basically beta, obviously the amount of acid secreted will decrease definitely, and that may affect the iron absorption also, that may affect vitamin B12 absorption also, right? So a lot of nutritional deficiencies will happen. Secondly, if the food is not passing via the stomach, if the food is bypassing the stomach, again beta, absorption of a lot of nutrients is going to get affected. Okay, so please remember beta, the complications of these surgeries which are there, first is definitely beta, nutritional deficiencies could happen. So that's the reason after a lot of bariatric surgeries beta, we have to give nutritional supplements to the patient as well. Next important beta, if we have performed anastomosis like in ruin by gastric bypass surgery beta, there can be chances of anastomotic leak over here as well. Or if the patient definitely is going to have beta, if this patient who is there is going to have prolonged immobilization, the patient will have a high risk of DVT, and then these patients of DVT beta can definitely develop a pulmonary embolism also beta. Okay, so that is important. These could be the complications definitely associated with the bariatric or the metabolic surgery. These were all the things beta that you need to know about the bariatric or the metabolic surgery. Done with this? Now let's talk about the next one beta. Now the next one which is there beta, it is nothing else but intestinal obstruction. Okay? If I talk about intestinal obstruction, please remember it is one of the most common surgical emergencies that we have beta. Okay? So yaad rakhna definitely. The most common surgical emergency worldwide is definitely acute appendicitis, but even intestinal obstruction is one of the commonest surgical emergencies that we have beta. Clear? Now if I talk about intestinal obstruction beta, what will be the complaints of the patient? So do remember, the complaints of the patient would be, the first one, the patient is going to have a colicky abdominal pain beta. The patient is going to have a colicky abdominal pain. That is important. Second important beta, the patient is going to have abdominal distension. Why? Because if there is intestinal obstruction beta, the patient is not able to pass the feces, or the patient is not even able to pass the gas beta, the flatus. That's the reason all that will stay collected inside the intestine, and that will lead to intestinal or abdominal distension further. Next, as the patient will have inability to pass feces, that is called as constipation, or the patient will have inability to pass flatus beta. Flatus is nothing else but gas. Okay, so inability to pass flatus beta, and that is what is called as obstipation beta. That is absolute constipation, right? So inability to pass flatus is known as obstipation, or the patient may have a late feature known as vomiting beta. So please remember, intestinal obstruction अगर होता है, the patient is going to have colic abdominal pain, there will be abdominal distension, there will be constipation, there will be obstipation, and there will be vomiting. These are the common features. याद रखना, vomiting is usually a late feature in patients of intestinal obstruction. No issues with this, anybody? That is important. Now please remember beta, there are two types of intestinal obstruction that we have to talk about. The first type of an intestinal obstruction that we need to know is basically this one beta, where there is a physical obstruction in the intestine. Now what is that physical obstruction beta? The commonest cause of that physical obstruction is usually adhesions beta. What is adhesions? For example, if there is any kind of inflammation in the intestine, or we have done any kind of surgery, after that beta, definitely the walls become sticky, and due to that beta, there is chances of adhesions. So please remember, the intestinal walls will stick to each other. That is known as adhesions. That will be one of the commonest cause beta for the physical obstruction. Or another can be stricture beta. Yes, due to fibrosis in the intestine beta, the patient is going to have strictures formed in the intestine that leads to an obstruction. It can definitely be any kind of tumors for that matter beta. It can definitely be a very big fecalith which is formed due to chronic constipation, right? So all of these features can be there. Now if there is a physical obstruction beta, okay, so please remember, is there any problem with the motility of the intestine, or is there any problem with the peristalsis of the intestine? No, the peristalsis is absolutely normal beta. The only problem is this physical obstruction. So what will happen beta? Now in the proximal part to the obstruction beta, okay, proximal to the obstruction. Now what will the intestine will do to overcome this obstruction beta? The intestine will try to overcome this obstruction, and therefore proximal to the obstruction beta, the intestine will do a very vigorous or a very strong peristalsis beta. And as the intestine is doing a very vigorous or a strong peristalsis, so when this patient is brought to me in the emergency beta, and when I auscultate the patient's abdomen, I am able to hear these hyperperistaltic bowel sounds beta, because of that vigorous peristalsis बच्चे. Clear है बात? That is important. Now important is beta, sometime later what happens basically, now when I auscultate the abdomen of the patient's beta, the patient's abdomen beta, the patient's abdomen has become silent. Now why it has gone silent basically? The reason is beta, that vigorous peristalsis which was there, due to that vigorous peristalsis beta, either there was a perforation which has happened, or there was strangulation. Strangulation is decreased blood supply to the intestine is known as strangulation. Okay, so either there was strangulation or there was perforation beta, and due to that now suddenly the abdomen of the patient has got silent, and that is an emergency beta, where the patient has to taken out to the where the patient has to taken to the OT beta and has to be operated. Okay, exploratory laparotomy has to be done. Clear about that is important. So this is one type of obstruction beta. Okay, then this is what is classically called as beta, the dynamic intestinal obstruction. You will be like, so why dynamic? Because here the intestine is dynamic now. Here the intestine is able to perform peristalsis. That's the reason this is called as dynamic intestinal obstruction. The other kind of obstruction, if I talk about beta, it is this one. Over here, beta, are you able to see any kind of physical obstruction as such? No. Here there is no physical obstruction. Then why are we calling it as intestinal obstruction, beta? The reason is, here definitely beta, the intestines which are there, they are not motile. Here the intestines which is there beta, they are not motile. And as the intestines are not motile definitely beta, therefore they are not able to perform peristalsis only. And if the intestines are not able to perform peristalsis, will the food or the feces move further in the intestine? No. That's the reason beta, there is stasis of food or feces in the intestine, and that's the reason beta, the patient will have intestinal obstruction. Now this kind of intestinal obstruction beta, where there is no physical obstruction, okay, but just the intestines are not motile beta, this type of intestinal obstruction is known as adynamic intestinal obstruction. Okay, this is known as an adynamic intestinal obstruction. Clear about? So that has to be remembered beta. So do remember that dynamic intestinal obstruction which is there beta, over there there is a physical obstruction, but the peristalsis is absolutely normal. Adynamic intestinal obstruction mein there is no physical obstruction, but the peristalsis is absent. Okay, so let's talk about them. So if I talk about beta, dynamic intestinal obstruction, here as I've told you beta, there is a physical obstruction in the intestine basically. Okay, so there is a physical obstruction to the flow of feces, and due to that beta, there is a vigorous peristalsis in the intestine. There is vigorous peristalsis proximal to the obstruction beta, and as there is a vigorous peristalsis, therefore I am able to hear those hyperperistaltic bowel sounds initially. But beta, after some time what can happen? Due to that vigorous peristalsis beta, obviously there can be a chance of perforation or strangulation, and if there is a perforation or strangulation beta, now the intestine or sorry, now the abdomen will suddenly turn silent beta. Okay, so that is important to be remembered. So the vigorous peristalsis leads to hyperperistaltic bowel sounds, but later on the perforation or strangulation leads to a silent abdomen. This is a case of a dynamic intestinal obstruction, that has to be remembered. Next important, if I talk about beta, it is going to be the next important, if I talk about, it is nothing else but adynamic intestinal obstruction. Now if I talk about the adynamic intestinal obstruction beta, do remember that here there is no physical obstruction. Okay, here there is basically no physical obstruction beta, but the problem is what? The bowel is not motile beta. The bowel is not able to do the peristalsis itself. Okay, so that is the problem over here, that the bowel is not motile. And as the bowel is not motile beta, obviously that means there is no peristalsis only. And if there is no peristalsis, will you get any kind of peristaltic sound? No. Here beta, the bowel will be silent itself. Sorry, here the abdomen will be silent itself. So yaad rakhna, in adynamic intestinal obstruction, the abdomen is silent since the time of presentation itself. But in dynamic intestinal obstruction beta, the abdomen will turn silent after the perforation only. Okay, so that is important. So this is an example of adynamic intestinal obstruction. Now if I talk about beta, that whenever a patient of intestinal obstruction comes to us, what is going to be the first line investigation beta? So yaad rakhna, the first line investigation, if they ask you, the answer has to be, always remember, it has to be an X-ray abdomen beta. Yes, whenever a patient of intestinal obstruction comes to us beta, the first line investigation is always an X-ray abdomen. याद रखना ये बात. A lot of people mark it as ultrasound and all. No, the first line investigation in all patients of intestinal obstruction is X-ray abdo. That X-ray abdomen which is there, beta, it is usually taken in two views, beta. Yes, the X-ray abdomen is taken in two views. One is going to be called as the erect view. That means when the patient is standing, and second is called as the supine view. That means when the patient is lying down, beta. Now, if I talk about the erect view, beta, both of these views, beta, they actually have their own significance. Okay, what are the significance? First, erect view which is there, beta, it can actually tell me whether my patient is having any obstruction or not. Okay, I will be able to see whether my patient is having any obstruction or not, beta, with the help of the X-ray erect view. Okay, whether obstruction is present or absent, that I'll get to know with the help of a erect view. If they say X-ray abdomen supine view, beta, so yaad rakhna, the X-ray abdomen supine view which is there, definitely it can actually tell me the exact site of obstruction or the exact location of obstruction, that which is the site in the whole GIT, beta, where you are able to see the obstruction. Okay, so I'll be able to see the exact site of obstruction, definitely. No issues with this, anybody? That is important. Now if they ask you, beta, that what we will be able to see, let's talk about that, shall I? Okay. So first of all, beta, this picture which is there, this is an X-ray abdomen, beta. You might have studied that in radiology also. This is the X-ray abdomen, beta, and this X-ray abdomen is the erect view. Now when we do a X-ray abdomen erect view, bache, okay, when we do a X-ray abdomen erect view, we will see definitely whether the patient has an intestinal obstruction or not. कैसे पता चलेगा? Normally beta, we should be able to see continuous bowel loops, na? We should be able to see continuous bowel loops. Here, are you able to see continuous bowel loops? No. Here you are able to see actually as if there are breaks in the bowel loops, right? So that means some areas are appearing black, that is called as air, and some areas are appearing white, that is called as fluid. So can I say here, definitely I am able to see air fluid levels, beta, right? Here I am able to see air fluid levels, yes. So X-ray abdomen erect view, if you are able to see air fluid levels, how many? At least more than 3 air fluid levels if you are able to see, beta, that is suggestive of an intestinal obstruction. Okay, that is strongly suggestive of an intestinal obstruction. समझे? तो X-ray abdomen erect view कैसे बताएगा that whether my patient has obstruction or not? So please remember, beta, if that X-ray abdomen erect view shows me air fluid levels more than 3 air fluid levels, that is what is suggestive of a intestinal obstruction in my patient. Next important, supine view which is there. Both of these which are there, beta, those are supine views now. Okay, both of these are supine views. Now please remember, beta, what we will see on the supine view. On the supine view, definitely we'll be able to see, beta, what is the exact site of obstruction or what is the exact location of obstruction. Now if I talk about that, remember, beta, for example, if my patient is having an intestinal obstruction, beta, the gas which is there is not able to pass outside, therefore all the gas stays collected inside the intestinal loops or the bowel loops, beta. Due to that, the intestinal or the bowel loops are going to get distended, beta, and as there is too much of gas and the distended bowel loops, beta, they definitely appear more prominent on the X-ray, right? Now please tell me, beta, if I say that these prominent distended bowel loops are seen in the periphery, if these distended bowel loops are seen in the periphery, beta, that means it is which intestinal obstruction? If the distended bowel loops are seen in the periphery, beta, that is suggestive of a large bowel obstruction or a colonic obstruction, beta. Okay, at the same on the same side, beta, if I say that the distended bowel loops are seen in the center of the abdomen, so obviously, bache, if the distended bowel loops are only in the center of the abdomen, that is what is suggestive of what? That is suggestive of a small bowel obstruction, beta, right? That is suggestive of a small bowel obstruction. Now important is, beta, if the patient is having a large bowel obstruction, one thing, as I've told you already, that you are able to see, beta, definitely that these intestinal bowel loops are in the periphery, beta. Apart from that, definitely they are having this special feature. Can you see these peripheral constrictions? These peripheral constrictions which are seen in the large bowel, beta, what are they called as? These peripheral constrictions which are able to see in the large bowel, what are these structures? What are these called as? These are known as hostrations, beta. So here definitely you are able to see, beta, there are hostrations which are seen. Okay, so one thing, definitely there is hostrations which are seen, beta. Apart from hostrations, basically, okay, I am also able to see that all the intestinal bowel loops are in the periphery. So this picture which is there, beta, it is suggestive of LBO, that is a large bowel obstruction, right? That is important. Whereas the second picture here, beta, we are able to see definitely that Here definitely the distended bowel loops, all of these distended bowel loops beta, you are able to see they are in the center of the abdomen. If they are in the center of the abdomen beta, we know that it is suggestive of a small bowel obstruction. So this is a picture of small bowel obstruction. Now we know beta in the small bowel basically we have two things. One is the jejunum beta, second is the ileum. Yes, because duodenal obstruction is very easy to pick up beta. It is basically the jejunal or the ileum obstruction basically. Okay, so jejunal or ileal obstruction अगर होता है so please remember how to differentiate both of them. I hope all of you are quite like aware about that you have studied in physiology and anatomy beta. Kia? So in the jejunum beta, in the jejunum, basically we have these continuous mucosal folds, and these continuous mucosal folds in jejunum are known as, anybody? These continuous mucosal folds in the jejunum beta are called as the valvulae conniventes. These are known as the valvulae conniventes beta or the plicae circularis. So these valvulae conniventes or the plicae circularis which are there, they are usually seen beta in this distended bowel loops. If you are able to see these valvulae conniventes or the plicae circularis beta in the distended bowel loops, this will definitely give you which kind of pattern beta? It looks like a step ladder pattern. So if the distended bowel loops beta are showing you the step ladder pattern, that means it is basically the valvulae conniventes which are seen. And if valvulae conniventes are seen, that means it has to be a case of jejunal obstruction beta. Okay, so that is important to be remembered. So here the picture which is there beta, it is definitely of a jejunal obstruction, right? Because the step ladder pattern is seen. Whereas on the other hand beta, the ileum which is there beta, the ileum loops which are there, they do not have any special feature, any special character. That is the reason beta, when the ileal loops are going to be distended, they will be called as featureless loops and characterless loops beta. ठीक है, तो याद रखना ये बात. If the patient is having a large bowel obstruction beta, if the patient is having a large bowel obstruction, याद रखना the distended bowel loops which are there, those will be seen in the periphery beta. Those will be seen in the periphery. And second beta, what is the special feature? The second feature which will be present beta is going to be called as the hostrations. The hostrations are going to be present. Okay, so that is a special feature. Next important beta, if I talk about the small bowel obstruction, if there is a small bowel obstruction in a patient beta, if there is a small bowel obstruction in a patient, please remember these distended bowel loops which are there, those distended bowel loops beta, they are usually seen in the center of the abdomen. They are usually seen in the center of the abdomen beta. And if it is a jejunal obstruction, if it is a jejunal obstruction, we are able to see which pattern? In jejunal obstruction beta, we are able to see the step ladder pattern. In jejunal obstruction, we are able to see the step ladder pattern beta. But if it is the ileal obstruction beta, if it is the ileal obstruction, I hope all of you are quite aware. As I told you, we will be able to see featureless loops. No special feature will be there. Clear to all of you now? That has to be remembered. Chalo. So that is how you have to remember. And X-rays of intestinal obstruction have come in your examination earlier. So it is not that X-rays have not come. X-rays have come in your examination earlier. Radio se bhi question hai. या फिर it is integrated with surgery also. ठीक है? So do remember this properly. Now if I talk about beta, what is the investigation of choice? Now whatever the X-ray tells beta, obviously we have to confirm it further with the help of a investigation of choice. Now otherwise I cannot rely on the X-ray only. That's the reason beta, you have to remember one thing, that the investigation of choice, okay, for all the cases beta, henceforth remember, for all the causes of intestinal obstruction, usually beta, the investigation of choice in an adult is going to be a CECT, that is a contrast enhanced CT scan abdomen, whereas for a child beta, it is usually a safer investigation like a ultrasound abdomen beta. Okay, even in a child, when you are not able to make a diagnosis with ultrasound, then you can go for a CECT. Okay, but we try to avoid it. Okay, so adults में definitely beta, please remember the investigation of choice has to be a CECT abdomen beta. Adults में the investigation of choice has to be a CECT abdomen, whereas in children definitely बच्चे the investigation of choice has to be an ultrasound abdomen. ठीक है, तो adults के लिए it is CECT abdo, children के लिए it is ultrasound abdo. If they ask you beta what is the treatment, so please remember what is the treatment in a case of intestinal obstruction. The mainstay of management is conservative or surgical. So please remember beta, the mainstay of management, okay, the mainstay of management has to be conservative management beta. Please remember that. Yes, the mainstay of management in intestinal obstruction is not surgical beta, it has to be a conservative management. And whenever I say conservative management beta in surgery, henceforth remember what are the four things that a surgeon means when he says conservative management. We mean beta that our patient should be kept nil per oral beta. Okay. Second, as the patient is nil per oral, we have to give IV fluids for nutrition in a patient beta. Third, we have to give IV antibiotics. And fourth, we have to give painkillers beta, that is analgesics. Okay, so NPO, IV fluids, IV antibiotics, analgesics. These are the four things beta that we mean whenever we say conservative management. Now important is, apart from this beta, you have to remember what is the fourth thing to be added here, and that is nothing else but we have to insert the nasogastric or the rice tube beta. Why in patients of intestinal obstruction we insert a nasogastric tube? Are you going to give nasogastric feeding or what? No. Enteral feeding is not given in intestinal obstruction. Then why? Reason beta, we have to insert the nasogastric tube basically beta, because all the gas which is collected inside now, that gas has to get released basically. So to cause decompression beta, we have to insert the NG tube. Okay, that is important. So yaad rakhna beta, the conservative management which is there, the conservative management in a patient of intestinal obstruction is nothing else but we have to insert a NG tube or we have to insert a nasogastric tube beta for the purpose of decompression. Okay, we have to insert a NG tube or a nasogastric tube for the purpose of decompression beta, and we have to keep the patient NPO, that is nil per oral. We have to give IV fluids, we have to give IV antibiotics. Okay, we have to give IV fluids, we have to give IV antibiotics beta, and we have to give analgesics, that is nothing else but painkillers beta. Clear about? These are the things that you need to remember. Now, if I talk about beta, that if this conservative management fails, that means the patient is showing no improvement in the symptoms at all. Yes, in those conditions, I may take my patient for a surgery beta. If the conservative management fails, then we may go for a surgery. And what is that surgery beta? That surgery is definitely, we have to open the abdomen of the patient and we have to search beta that what is the problem, where is the obstruction, and that kind of a surgery will always be called as an exploratory laparotomy beta. That is known as the exploratory laparotomy. And once you find the cause beta, you have to treat the underlying cause. Whatever is the problem, you have to treat that and relieve the intestinal obstruction beta. So the surgery of choice, if they ask you, it is exploratory laparotomy beta, but that is the last choice. Please remember that. Always the mainstay of management in a case of intestinal obstruction is going to be conservative management. If that fails, then only we go for a exploratory laparotomy. Okay? Now, if I talk about beta, the next one, that the dynamic and adynamic intestinal obstruction, what could be the causes for it? So first of all, beta, if I talk about dynamic intestinal obstruction, the most common cause of dynamic intestinal obstruction, I've told you beta, that when the intestinal walls are going to stick to each other. And what is that called as? When the intestinal walls are going to stick to each other beta, that is what is known as adhesions. So the most common cause of dynamic intestinal obstruction is adhesions beta, followed by the second most common cause is going to be strictures beta. The most common cause of dynamic intestinal obstruction is going to be adhesions, followed by the second most common cause which is there beta, it is going to be strictures. If they ask you beta, what are the causes in the patient? So please remember beta, the causes which are there, it is nothing else but see all the infections which are there, all the inflammation which are there, okay, they are actually going to make the wall sticky and therefore there will be high chance of adhesions beta. Okay? Or there can be inflammation which will heal with fibrosis that leads to formation of strictures. Okay? याद रखना all the causes of adhesions or strictures which is there. The first one would be tuberculosis, okay, gastrointestinal TB, or it can be Crohn's disease beta in the patient, or it can be PID. What is PID? It is pelvic inflammatory disease. When the pelvic inflammatory disease spreads to the intestine beta, that is the condition. Endometriosis, that means when the ectopic endometrium is present in the patient's intestine. Yes. Okay, or it is radiotherapy, because radiotherapy is known to cause fibrosis of the GIT. That is the reason beta. Always remember that for any colon cancer, any intestinal cancer beta, we never use radiotherapy, because otherwise there will be formation of fibrosis and that can lead to strictures. Okay, so that is important. Or any kind of surgeries beta. Surgeries may also cause definitely risk of adhesions or strictures as well. Important is if they ask you what should be the treatment beta. So yaad rakh lo, if the cause of dynamic intestinal obstruction was adhesions beta, if the cause was adhesions, basically what we have to do, we have to go inside the intestine bache, and once we go inside the intestine, we definitely have to break out these adhesions beta, and breaking adhesions is called as adhesiolysis. Okay, so you have done any which ways an exploratory laparotomy now, and once you have done an exploratory laparotomy beta, you have to break down the adhesions by using adhesiolysis technique. Next important beta if I talk about is strictures beta. If strictures are going to be the cause, basically what we will do, see, if there is a very small segment of the intestine beta which has a stricture, if there's a very small segment of intestine which basically has a stricture in it, what we can do, we can just cut this part out of this intestine beta and we can join the remaining parts. Cutting is called as resection, joining is known as anastomosis. So beta, if you are going to cut out a small part and we are going to join the remaining parts beta, that is what is known as a resection and anastomosis beta. Okay, that is what is classically called as resection and anastomosis. Okay, but beta, if there is a very large segment which is actually having a stricture, if there is a very large segment beta or multiple segments having strictures, I cannot cut such a large segment or I cannot cut multiple segments, right? So in that conditions beta, if there is a multiple segments or a large segment, in that condition we have to repair the stricture beta. We do not cut it, we just repair it beta, and that is called as a stricturoplasty. That is known as a stricturoplasty. Next one, if I talk about beta, adynamic intestinal obstruction. So if there is an adynamic intestinal obstruction beta, what is the most common cause of it now? If I talk about adynamic intestinal obstruction, बच्चे याद रख लो, ठीक है? Adynamic intestinal obstruction, that means definitely beta that the patient is having no motility in the intestine beta, there is no peristalsis in the intestine itself. And if there is no motility in the intestine, definitely what is the reason for that? Intestine में motility नहीं है, that means the intestines are not performing peristalsis, that means the intestines are lazy. What is that condition? I have told you, that condition is classically called as the paralytic ileus. The most common cause beta of adynamic intestinal obstruction has to be a paralytic ileus beta. Clear about? Hopefully that has to be remembered. So paralytic ileus is the leading cause beta for that condition. If they ask you what is the reasons for it, so please do remember the first one is here definitely as see paralytic ileus or adynamic intestinal obstruction is what? There is failure of the bowel beta to contract. Why the bowel is not able to contract? Because the bowel which is there or the muscles which are there they are not stimulated properly. Okay, there is a failure of neuromuscular transmission, and as there is a failure of neuromuscular transmission beta, due to that the GI muscles are not stimulated properly, and that's the reason definitely beta the patient will have a paralytic ileus. Yes, very good. Chronic TPN can be one of the reasons beta, but the most common cause is not chronic TPN. The most common cause is what? I've told you this. The most common cause you have to remember beta, it is nothing else but surgery itself. Yes, the post surgery it is usually seen beta, right? The most common cause is definitely it is seen post surgery, which is now why it is seen post surgery. Please remember during the surgery if there was too much of bowel handling beta, please remember the chances of paralytic ileus are going to increase. Normally beta any which ways after the surgeries, please remember any which ways beta after the surgeries beta there is a adynamic intestinal obstruction or paralytic ileus for some time beta, and that's the reason I hope all of you are quite aware. That's the reason you directly don't start giving beta the whole food basically to the patient like sabji, roti, dal, chawal, all of that, right? You do not give it immediately to the patient. What we do after the surgery is done beta, for the initial few hours definitely up to the 2 to 4 hours of surgery we don't give anything at all. Okay, depends on the surgery also, but at least for the 2 to 4 hours we don't give anything. After that we start giving clear fluids to our patient beta. Okay, slowly as we give clear fluids beta, after a span of almost 12 hours beta, okay, or at least a span of 6 to 8 hours beta, after that we can start giving other fluids to the patient, that is definitely your coconut water or something. Then we can definitely add a bit of soups vagera, juices vagera, and then we will start giving after a span of almost 24 hours beta, we usually start giving semi solids, and then ultimately we will give solids beta. Okay, this is how feeding is usually done beta after a surgery. The reason is what? The reason is this, because your intestine or your GIT is not motile after surgery immediately. Okay, it is going to regain the motility, but regaining that motility is going to take a time for almost a span of 24 to 48 hours. Therefore you have to slowly start giving fluids definitely. Okay, that is important. So that is important thing beta. So that's the reason, do not start immediately do not start a lot of food after the surgery beta. So most common cause of adynamic intestinal obstruction or paralytic ileus is post surgery beta. Usually surgery is going to be the leading cause. Apart from that, yes, the other causes can be what? The other causes can be uremia beta. Okay, because toxins which are there can actually affect the neuromuscular transmission, or it can even be hypothermia. Okay. Now, apart from that, beta, a very, very important cause which has been asked in your examination, and that is nothing else but dyselectrolytemia. That is electrolyte disturbances, beta. Now, a previous year question of your examination was that which is the most common electrolyte disturbance which is known to cause paralytic ileus in the patient. So, yaad rakhna beta that the most common electrolyte disturbance to cause paralytic ileus is going to be hypokalemia, beta. Okay, the most common electrolyte disturbance to cause paralytic ileus which is there beta, it is nothing else but hypokalemia. So hypokalemia is the most common electrolyte disturbance to cause paralytic ileus. Okay, so that is important to be remembered. Next important beta, if they ask you definitely that which is what are the clinical features of the patient, obviously beta that adynamic intestinal obstruction will also have exactly the same clinical features beta as intestinal obstruction only one feature will be different, and that is pain. Okay, yes, adynamic intestinal obstruction or paralytic ileus will not have pain. Why? In dynamic intestinal obstruction, why we had that colicky abdominal pain? We had that colicky abdominal pain because of that vigorous peristalsis, right? Here there is no peristalsis at all. Leave behind vigorous. Normal peristalsis bhi nahi ho raha. So obviously, will the patient have pain? No. So adynamic intestinal obstruction or paralytic ileus beta, these people do not have any kind of pain. But what are the other features? All the other features will be there then. That means the patient will have a severe abdominal distension. The patient is going to have constipation. The patient is definitely going to have beta obstipation, and the patient will have a lead feature, that is vomiting as well beta. Okay, so all of these features could be present in a patient of paralytic ileus beta. If they ask you what should be the management, so management is nothing else but beta. Management is nothing else but correction of the underlying cause and the electrolyte disturbances. So we have to definitely correct the electrolyte disturbances beta. Management is nothing else but correction of electrolyte disturbances beta. That is actually going to help in majority conditions. Okay, so that is important. The management of paralytic ileus or adynamic intestinal obstruction is nothing else but correction of the electrolyte disturbances that has to be done. Next important, if they ask you beta that which structures definitely regain the motility after surgery. I've told you now, during the surgery obviously these structures are going to be immotile. So obviously after the surgery beta, slowly the GI tract will start regaining their motility. Another previous year question of your exam, that which is the first part of the GI2 to gain the motility beta. Okay, okay. So if they ask you which is the first part of the intestine or the GIT to regain the motility after surgery, the first one to regain the motility beta after the surgery is going to be anybody? It is going to be your jejunum. This was a previous year question. Do remember that. The first one to regain the motility after the surgery beta, it is going to be the jejunum. And the last one which is there beta to regain the motility is going to be the colon beta. That is your large intestine. The last one definitely to regain the motility is the colon or the large intestine. Yes. Okay, the first one is jejunum, followed by the ileum, followed by the stomach, and the last one being colon beta. Okay, so they slowly start regaining their motility. Next important beta, if the patient is having an intestinal obstruction, obviously I've told you beta that definitely what can happen, the patient can have beta more and more distension of the intestine also, right? And if there is more and more distension of the intestine beta, what can happen? There can be rupture of the intestine also. So please tell me beta, at what cutoff basically, or at what diameter there is a risk of rupture. Okay, so याद रखना है, there is a rule of three or a table of three that we can say beta, we can follow definitely. Okay, so risk of rupture definitely, if I talk about beta, risk of rupture if I talk about, it is usually seen if the diameter exceeds how much? The risk of rupture is seen beta if the diameter exceeds in a small bowel, if the diameter is more than 3 centimeters, in a large bowel if the diameter is more than 6 centimeters, and in the cecum is already 5 to 6 centimeters. So in the cecum, if the diameter is more than 9 centimeters. So 3 ones are, 3 twos are, 3 threes are, right? So that is important. So please remember beta, small bowel which is there, when it is going to exceed more than 3 centimeters, when the large bowel is going to exceed more than 6 centimeters, and when the cecum is going to exceed more than 9 centimeters. This was a question. So when the cecum is going to exceed more than 9 centimeters beta, then there will be a risk of rupture. Okay? And obviously if there is a ruptured sorry, when there is a definitely a rupture beta or a perforation. So obviously that perforation case has to be treated like we have discussed in hollow viscous perforation beta, right? Hollow viscous perforation, and what did we discussed? The patient is brought to the emergency. We have to definitely do X-ray. On that, you will be able to see what the gas under diaphragm. Apart from that, the patient will have other features of peritonitis beta. Then definitely beta, you can do a CT and then you take the patient for a surgery. First line is basic resuscitation, but surgery is exploratory laparotomy beta again, and we have to do a peritoneal lavage if there is a peritonitis. Okay, and we have to either go for a early repair or a delayed repair. That depends on the time of presentation beta. No issues with this, anybody? Next important now. Let's talk about the next condition, and that is nothing else but duodenal atresia beta. Okay, let's talk about the next condition, and that is nothing else but duodenal atresia. Now, if I talk about beta duodenal atresia, what is basically duodenal atresia, which is, as I've told you, atresia means what we have discussed in esophagus. Atresia is nothing else but absence of some part beta. So what happens over here? Understand. For example, beta, we know that your GIT, which is there, it develops from three parts basically, right? Embryologically, there is a foregut, then we have the midgut, and then we have the hindgut beta. The foregut, which is there beta, it usually starts from the lower part of the esophagus till the second part of the duodenum. This is what is developed by the foregut. Next, from the third part of the duodenum onwards till the proximal two-third of the colon beta, till the proximal two-third of the colon, we have the midgut. From the distal one-third of the colon bache till the rectum, okay, till the distal one-third of the from the distal one-third of the transverse colon till the upper two-third of rectum, it is the hindgut beta. I hope all of you are quite aware about that. याद रखना बेटा, here definitely you have to remember one thing, that the duodenum which is there, it actually develops from two parts basically. Okay, the first and second part usually develops from the foregut, third and fourth part develops from the midgut beta. Okay, now here the foregut and the midgut has to fuse at the level of the duodenum beta. But if the foregut and midgut does not fuse at the level of duodenum, so there is going to be a gap in the duodenum or absence of duodenum beta in some part, and that is what is called as duodenal atresia. The next type will be, here the foregut and the midgut has fused with each other beta, but with the help of a fibrous band. Yes, there is not a proper connection beta, there is just a fibrous band. That is also a case of duodenal atresia. Or the third type beta, where the foregut and the midgut have almost fused with each other beta, but the problem is after fusing, the septum which is there beta, it is still there over there. Okay, so therefore there is not a direct connection basically. So this is also a case of duodenal atresia itself. Clear about? So this is what is duodenal atresia beta. So we know duodenal atresia is nothing else but when the foregut fails to fuse with the midgut beta. That is what is going to cause duodenal atresia in a patient. Duodenal atresia beta, it is actually going to be the most common cause of neonatal bowel obstruction. Yes, it is actually the most common or the leading cause of neonatal bowel obstruction beta. If they ask you, will you be able to get an idea of that whether the baby has a duodenal obstruction during pregnancy or not? Yes beta, in the mother's womb itself beta, during her pregnancy itself, we can get an idea. How? As I told you beta, if there is duodenal atresia, the baby will not be able to swallow the amniotic fluid properly, and all that amniotic fluid in the sac is going to increase. That will lead to polyhydramnios in the mother. So if the female is having polyhydramnios in the pregnancy beta, so severe polyhydramnios ka cause, as I've told you, it is GI anomalies. Either it can be esophageal or a duodenal atresia. Next, the child will present to you at birth beta. Which kind of symptoms? First thing, the child presents at birth itself beta, not after 2 to 3 weeks of life. Okay, and here the food which is there beta, it is going to come back from the duodenum of the patient. As the food is going to come back from the duodenum, that means it would have mixed up, beta with the bile now, and therefore there will be a greenish color vomiting which will be seen. That is called as a bilious vomiting. So these two symptoms which are there beta, that the child presents to us at birth with a projectile bilious vomiting beta, is actually going to help us differentiate this condition from CHPS. I told you in CHPS beta, the baby is going to present to us after 2 to 3 weeks of life, and that too with a non-bilious vomiting. But in duodenal atresia, at birth, symptoms appear with the symptom that is bilious vomiting beta. Now we have to remember that this duodenal atresia which is there beta, the duodenal atresia is a condition which is commonly associated with nothing else but trisomy 21. And what is trisomy 21? Down syndrome. याद रखना, there are two gastrointestinal anomalies beta which are commonly associated with Down syndrome. One you have to remember is duodenal atresia. Second we will talk about beta is known as Hirschsprung's disease. These are the two conditions which are commonly associated. If they ask you beta, that what we have to do for the purpose of diagnosis. So in a patient of duodenal atresia beta, when the child will present immediately at birth with these kind of symptoms, the first line investigation has to be a X-ray because it is a feature of intestinal obstruction, right? So please remember the first feature, the first investigation has to be an X-ray abdomen. And when we do a X-ray abdomen, you are able to see below it itself beta what is seen. Here beta we are able to see definitely a large gastric bubble and a small duodenal bubble beta. Okay, so how many bubbles are seen? Here we are able to see the classical double bubble sign. Yes. So please remember in CHPS we were able to see single bubble sign, but in patients of duodenal atresia we are able to see double bubble sign. That is another difference between both of them. Clear about? So here we are able to see a double bubble sign beta. Next important thing you have to remember that double bubble sign, is it only seen in patients of duodenal atresia beta? No. Yaad rakhna, double bubble sign is actually seen in three conditions beta. The first condition that we are talking about is known as duodenal atresia beta, where there is a duodenal obstruction in the baby. Second important beta, we will talk about a condition in pancreas, a congenital anomaly of pancreas known as annular pancreas beta. अब annular का मतलब क्या होता है? Annular means ring like beta. Okay, so here definitely what is going to happen, there is a ring like pancreatic tissue around the second part of duodenum, and as that ring like pancreatic tissue is going to compress the second part of duodenum beta, due to that the patient will have a duodenal obstruction over there. So that condition can also show us a classical double bubble sign beta. And the third condition which is there beta, okay, the third condition which is there basically, it is going to show us what? So that third condition is known as Latz band which is. So these are the three conditions definitely in which we are able to see the double bubble sign, okay, on the X-ray abdomen. Hopefully that's clear to all of you now. Chalo. Investigation of choice beta, we have to remember that obviously the investigation of choice is not going to be the X-ray. We have to confirm the diagnosis with the help of a CECT. Reason is beta, ultrasound is preferred in neonates beta, but in this patient, even if you do an ultrasound beta, you are not able to get a proper idea. That's the reason beta in duodenal atresia. This is a condition that where in children beta or in neonates, we tend to use a CECT abdomen beta. Okay, chalo. So investigation of choice is nothing else but a CECT abdomen which is, and once you do a CECT abdomen, you can confirm the diagnosis. Okay, so that is important. Apart from that beta, here you have to see what is the treatment in the patient. We know beta that both the parts of the duodenum are not connected to each other. So what we should do? We should just connect both the parts of duodenum with each other, right? And when we are going to connect both the parts, that is called as a duodenal anastomosis, or we can call it as a duodenostomy, right? So the surgery of choice which is done over here beta is nothing else but a duodenostomy or a duodenal anastomosis. If beta, the gap between both of them is very big, okay, the gap between both of them beta is more, definitely beta I cannot pull the duodenum, we know that. So if the gap between the two parts of duodenum is very high, then what we do basically, then we better go for a duodenojejunal anastomosis beta, right? In that condition you can go for a duodenojejunal anastomosis, also known as a DJ-stomy beta. If they ask you which one is preferred, obviously is beta, the same organ to same organ is always preferred. Now, why to connect the same organ to a different kind of one organ to a different organ basically, right? So please remember duodenostomy beta is always preferred over a DJ-stomy. DJ-stomy is only done if the two ends are very far away from each other. Now, important is beta the next picture which is there. Here in this next picture you are able to see how many bubbles beta. This is also an X-ray abdomen, and on that X-ray abdomen beta, instead of single or a double bubble, I'm rather able to see three bubbles beta. So one is definitely the gastric bubble bache, the second is definitely the duodenal bubble beta, and the third is going to be your jejunal bubble bache. Okay, so this is classically called as the triple bubble sign, and I hope definitely that triple bubble sign you are aware. It is usually a feature of which condition? It is a feature of jejunal atresia beta. याद रखना, triple bubble sign is usually seen in patients who are suffering from jejunal atresia. याद रखना, jejunal atresia is actually much more common than duodenal atresia beta. Okay, the investigation is definitely investigation of choice is same, that is CECT. Treatment is same, we have to do an anastomosis or a stomy, that is here we go for a jejunostomy. Okay, so everything is same. Remember this picture, that is classically the triple bubble sign. Next important beta if I talk about is this one. How many bubbles are seen over here? Here we are able to see multiple bubbles beta. Okay, even it is beyond counting. So if you are able to see multiple bubbles, you are not able to count it, you can immediately call it as beta multiple bubble sign. I can call it as the multiple bubble sign. And if there is a multiple bubble sign beta, that is suggestive of obstruction where? If there is a multiple bubble sign beta, it is suggestive of obstruction in the, okay, it is suggestive of obstruction in the ileum beta. Okay, it is suggestive of an ileal obstruction. It is suggestive of an ileal obstruction. No issues with this, anybody? Chalo, so that is important. Again, same thing, beta, CECT abdomen for diagnosis and ileostomy has to be done. Clear? Hai? Next important, if I talk about beta, is going to be a GI TB beta or a gastrointestinal TB. In that, okay. Now, when I talk about a GI TB beta, obviously it is also caused by the same organism, that is your Mycobacterium tuberculosis beta. And we know as the tuberculosis is known as a Koch's bacillus. Therefore, the GI TB or the intestinal TB can also be called as abdominal cox beta. Yes, any TB in the any TB in the abdomen beta can be called as abdominal cox. Whether it is GI TB or it is the mesenteric TB, basically the mesenteric lymph node TB, mesenteric lymphadenitis that is seen due to TB, that is also together. Okay, so all of them definitely can be called as abdominal cox as well. Okay, so now definitely beta, when I talk about the intestinal tuberculosis, okay, when I talk about intestinal tuberculosis, bache, do remember that here it is actually a type of abdominal cox beta. Yaad rakho, it is basically a type of abdominal cox that we need to remember. If they ask you what is going to be the most common site beta, if they ask you what is going to be the most common site for intestinal TB, it is nothing else but the ileocecal junction beta. Yes, where the small intestine is going to end and the large intestine is going to begin, right? Where the ileum ends and the cecum begins beta in the right iliac fossa, right? So that ileocecal junction is considered as the most common site beta for an intestinal TB. Now, if they ask you, beta, there are how many types of TB? So please remember, beta, in the intestine, there are basically two types of TB. One TB, beta, where there is inflammation and ulceration in the intestinal mucosa. And the second TB, beta, when there is hyperplasia, that is increase in the number of cells or growth which is seen over here in the intestinal mucosa. Clear about? So the ulcerative TB which is there, I hope all of you are quite aware, beta. TB ulcers are going to be transverse or longitudinal. Let me know that in the chat box. Okay, TB ulcers are going to be transverse or longitudinal. I'll wait for that answer basically from patho or something. Hyperplastic TB which is there on the other hand, beta. Please remember hyperplastic TB which is there on the other hand. Okay, here definitely due to hyperplasia, there is going to be formation of a mass beta. And as I told you, ileocecal junction is in the right iliac fossa. Therefore, this mass will be palpated beta in the right iliac fossa of the patient, right? There will be a mass in the right iliac fossa itself. And that mass which is formed beta at the ileocecal junction, that mass is also known to cause bowel obstruction beta. That mass is also known to cause bowel obstruction in the patient. If they ask you ulcerative TB beta, so the ulcers which are seen usually in a patient of intestinal TB are going to be the transverse ulcers beta. Please remember that the transverse ulcers are usually seen in the intestinal mucosa in a case of tuberculosis. Okay, in patients of typhoid, basically in patients of typhoid beta, what is seen? In patients of typhoid beta, what is going to be seen? In patients of typhoid, definitely beta, we are able to see what? We are able to see longitudinal ulcers beta. In patients of typhoid, you are able to see longitudinal ulcers, but in patients of TB beta, we are definitely able to see transverse ulcers, right? In patients of TB, we are able to see transverse ulcers. Okay, and due to that transverse ulcers in patients of TB beta, yaad rakhna, the patient is actually going to have what? There will be a risk of perforation and strictures. There will be a risk of perforation and strictures over here. Now, if they ask you what are going to be the complaints in the patient, see, if it is only a case of intestinal tuberculosis or a GI TB beta, this patient is going to have an abdominal pain, and majority of the times beta, this patient goes to medicine OPD, and these patients usually get treated by the physicians itself. Okay? They are usually sent to surgery beta. Okay, these people usually come to the surgery emergencies most of the times beta with the complaint of bowel obstruction. Yes. Okay. So these patients do not come to us for the basic treatment. Basic treatment is given by medicine people beta. It is basically the bowel obstruction or the complications for which the patients are going to come to us. Okay, so that is important. So beta, what are the complaints of the patient? Obviously, the patient may have an abdominal pain beta. Okay, the patient is going to have an abdominal pain. Along with abdominal pain beta, the patient will have all the constitutional symptoms of TB. And what are the constitutional symptoms of TB? I hope all of you are quite aware. Patient will have loss of appetite, that is anorexia. Patient will have a low grade fever, mainly rising in the evening. Patient have drenching night sweats, that is severe night sweats where the clothes of the patient will be wet beta. And sorry. Okay. So this patient is going to have a severe weight loss. Okay, so anorexia will be there, weight loss will be there. There will be a low grade fever mainly rising in the evening time beta. Okay, as I told you, and the patient will have drenching night sweats. These are considered as the constitutional symptoms of TB. याद रखना है बात. ठीक है, तो abdominal pain is always going to be a constant symptom beta in this patient. Apart from that, these other symptoms are seen. ठीक है. Now apart from that, as I told you beta, abdominal cocks can be anything. It can definitely be beta GITB only, or it can be definitely TB of the mesenteric lymph nodes also. And when there will be TB of mesenteric lymph nodes, that can be called as mesenteric adenitis or mesenteric lymphadenitis. That is infection or inflammation of the mesenteric lymph nodes. Next, the patient can also develop ascites beta. Okay, and the patient may also develop pyoperitoneum. That means if the patient is immunocompromised and the TB is very severe, then there can be pus also collected inside the peritoneal cavity. Diagnosis, if they ask you, so yaad rakhna, in patients of intestinal or GITB beta, usually there is a clinical diagnosis. We do not need to prove the diagnosis by taking a CB-NAT or something. No, it is usually a clinical diagnosis beta. At least the medicine people can start the ATT directly if they are able to do a clinical diagnosis of TB beta. Okay, that is important. Then definitely, if you want to confirm the diagnosis further, you can go for anything else. But if I talk about surgery beta, please remember, surgery may definitely when the patient comes. As I told you, the patient would come to us with features of bowel obstruction. And as the patient comes to us with features of bowel obstruction beta, we have to go for a CCT abdomen in the patient, right? You have to go for the first sign will be X-ray and investigation of choice will be CECT abdomen. Clear about? If they ask you what is this investigation below, this investigation is what beta? Here we have inserted a catheter into the patient's rectum, and via that catheter we have injected barium sulfate solution. Now the barium sulfate solution will travel all the way up from the rectum to the sigmoid colon, to the descending colon, the transverse colon, ascending colon, and the cecum and the ileocecal junction, right? So this is nothing else but an investigation known as a barium enema, and we know barium enema is usually done for the large intestine. Please remember that. And here are the ileocecal junction on the barium enema. What are the features we are able to see? First beta, due to the fibrosis beta, due to infection and fibrosis at the ileocecal junction, these features are seen. The first one, the ileocecal junction which is there beta, it becomes very narrow due to fibrosis, and this is classically called as which deformity beta? It looks like the goose neck basically. So either you can call it as the goose neck or the swan neck deformity as well, right? So this is classically known as the goose neck deformity beta. Whereas this one which is there beta, here the cecum appears to be pulled up upwards basically because of the fibrosis. This is called as a pulled up cecum. So here you are able to see the two classical findings beta. One is called as the pulled up cecum. Second is going to be called as the goose neck deformity beta. Clear about? That is important. If they ask you what is going to be the treatment in the patient beta, so yaad rakhna, we know in all types of TB beta, wherever we have TB in the body, the treatment has to be nothing else but ATT. And what is ATT? Anti-tubercular therapy. So please remember beta, ATT or the anti-tubercular therapy is going to be the treatment of choice in the patient. Okay, so that has to be remembered. Anti-tubercular therapy is the treatment of choice in the patient beta. That has to be given. Now important is beta, as I've told you, this can be started by the physicians itself. Why the patient would have come to us? The patient would have come to us beta because of usually bowel obstruction or the lump. Okay, the patient would be sent to us either because of the lump in the right iliac fossa, that is due to hyperplastic TB, or due to the bowel obstruction like symptoms beta, or due to perforation for that matter. Okay, so in all these patients, definitely the patient will come to us. So if the lump or the obstruction persists beta, then definitely we have to go for a surgery. And that surgery, as I've told you beta, it is nothing else but an exploratory laparotomy. That is nothing else but an exploratory laparotomy. Okay, so that is important. So when the patient comes to us initially beta, obviously we are not knowing initially the patient is having TB and all of that. Okay, if the patient is a diagnosed case, that is a different funda. But if the patient is not a diagnosed case beta and the patient suddenly comes to us in the emergency, we are going to manage it like intestinal obstruction only. That is, first we will send the patient for conservative management only. If the patient improves, we are going to discharge the patient. But if the patient worsens, we have to take up the patient for the surgery. And here as I said, definitely beta, here as the patient is going to have persistent features of bowel obstruction or lump, then we have to take up the patient for an exploratory laparotomy. If that bowel obstruction, I've told you, TB can cause adhesions or strictures. If that bowel obstruction is due to adhesions, you have to do adhesiolysis. If it is due to strictures in a smaller part, you can go for resection and anastomosis, right? So that is important. Depending on the cause, you have to do the treatment in the patient. Beta. Clear? Hai? Want a break? Let me know if you want a break. Then we can take a break and then we will start the next part after the break. Okay, take a small break and then after the break, let's start this remaining session. चलो बच्चों, now let's start with very very important topic. Just like achalasia, cardia is your favorite, is your examiner's favorite. Another two topics that are his favorite beta. One is Meckel's diverticulum, another is intussusception. Okay, so let's talk about both these conditions now. So first of all, let's talk about Meckel's diverticulum, bache. Now, what is a Becker's diverticulum? We know that diverticulum is nothing else but an outpouching. So this time, beta, there is going to be an outpouching which is present from the intestine, right? You can see over here. So we know, beta, this is the intestine which is there. This is the mesentery which is there, beta. So you are able to see this outpouching. On which border? We are able to see the outpouching of the Meckel's diverticulum, beta, on the anti-mesenteric border, right? This picture has come earlier in your exam. Yaad rakhna isko. So this Meckel's diverticulum is usually seen on the anti-mesenteric border, beta. That has to be remembered. Now, why this outpouching is actually there? To understand, beta, during the fetal life, beta, we have this midgut. Okay, this is your midgut, beta. So during fetal life, क्या होता है? The midgut which is there is actually in connection with the umbilicus, beta. Yes, there is a connection between the midgut and umbilicus during the fetal life, beta. इन दोनों के बीच में connection होता है. And what is that connection called as? This connection between the midgut and umbilicus is called as the vitellointestinal duct, beta. We call this connection as the vitellointestinal duct, also known as the omphallomesenteric duct, bache. Now, what is going to happen here, beta? This connection known as vitellointestinal duct should usually disappear after birth, beta. Yes, it should undergo fibrosis, and that leads to formation of vitelline ligaments. Okay, so matlab it should disappear after birth. What is going to happen, beta? In some patients, this vitellointestinal duct does not disappear. It remains completely open. And if the vitellointestinal duct will remain completely open, beta, what will happen? All the feces or all the meconium which is there in the baby, right? So all that feces or the meconium of that baby, beta, will start coming out from the umbilicus, right? When all the feces or the meconium start coming out from the umbilicus, beta, we know that definitely the baby's vitellointestinal duct has not disappeared. It is completely patent. And this condition which is there, beta, is known as a vitelline fistula. Why fistula? Because it has a two-way connection, right? So the condition which is there due to patency of the vitellointestinal duct is known as vitelline fistula. And this was a previous year question, beta, when they said that the pediatrician sees meconium coming out from the baby's umbilicus. So answer is vitelline fistula. Next, beta, is a condition that we have to talk about, and that is, now in this condition, beta, that usually your vitellointestinal duct undergoes a fibrosis, beta, but it does not completely close. Okay, it undergoes a fibrosis, but it does not completely close. Rather, beta, this part which is connected to the intestine, beta, it remains open, it remains patent. And when definitely the vitellointestinal duct which is there, beta, it has actually undergone a partial disappearance. Matlab only some part of the vitellointestinal duct has disappeared. Some part is still patent, some part is still open, beta. That leads to formation of this outpouching from the vitellointestinal duct, and this outpouching which is formed, beta, from the vitellointestinal duct is known as the Meckel's diverticulum. As this diverticulum will be present since birth, it is a congenital diverticulum, and as all the layers will be present inside its wall, beta, that is mucosa, submucosa, as well as muscularis, it is known as a true diverticulum. Clear hai baat? Chalo. So first of all, beta, we know that Meckel's diverticulum is nothing else but an outpouching, okay, which is seen on the anti-mesenteric border, beta, from the bowel or from the intestine, which and it is due to partial persistence, beta, of which structure? So it is due to not complete persistence. Complete persistence की वजह से vitelline fistula होता है. Partial persistence of which structure? Vitellointestinal duct. And this has been a previous year question, that the Meckel's diverticulum is due to partial persistence and patency of which structure? Answer is vitellointestinal duct. Okay, here you are able to see if the vitellointestinal duct is completely open, beta, that is called as a vitelline fistula. If it is partially open, beta, that is called as a Meckel's diverticulum. And if it has undergone fibrosis, beta, but in some part it is still having a cyst, beta, that is called as a vitelline cyst. Okay, that is important. Now please remember, beta, in a Meckel's diverticulum there is a rule of two which is going to be followed. Now the rule of two of Meckel's diverticulum says what? That Meckel's diverticulum will be seen, beta, in 2% of the population. Okay, it is seen in 2% of the population. It is going to be 2 inches long, beta. It is approximately 2 centimeters wide. This 2 centimeters wide is not everywhere written, okay, but most of the Meckel's diverticulum are around 2 centimeters wide. Next, beta, it is 2 feet proximal to the ileocecal junction, beta. So now when I say 2 feet proximal to the ileocecal junction, that means it is present in the small intestine, beta, mainly in the ileum part. Okay, 2 feet proximal to the ileocecal junction. Apart from that, one more thing, that 20% patients of Meckel's diverticulum who are there beta, the 20% patients of Meckel's diverticulum will not have an intestinal mucosa, they have an ectopic mucosa in the Meckel's beta. Yaad rakhna, 20% patients of Meckel's diverticulum will have an ectopic mucosa definitely in the Meckel's diverticulum. And if they ask you previous year question of FMG exam, which is the most common ectopic mucosa in the Meckel's diverticulum, तो याद रखना है बच्चे, the most common ectopic mucosa in the Meckel's diverticulum, answer has to be the gastric mucosa followed by the pancreatic mucosa. Then answer has to be the gastric mucosa followed by the pancreatic mucosa. Okay. So most common ectopic mucosa in the Meckel's diverticulum, answer is gastric. This has been a previous year question. Next important, as I told you, that in the Meckel's diverticulum beta, as all the layers are going to be present, as all the layers are present beta, it has to be a true diverticulum, right? It has to be a true diverticulum beta. Now obviously it is going to be present since birth, so it is congenital. So it is going to be a true diverticulum beta, that has to be remembered. Apart from that, what will be the clinical features? So please remember beta, Meckel's is usually an incidental diagnosis. Now what do I mean by incidental diagnosis beta? Incidental matlab you are actually doing surgery for something else, and at that time beta you got to know, okay, the patient is having a Meckel's diverticulum. Yes, okay. So most of the patients, that means, are going to be usually asymptomatic. So most of the patients are usually asymptomatic beta, okay, and that's the reason it is going to be an incidental diagnosis. You are doing, for example, an appendectomy in the patient, and it is a rule beta that every time we do an appendectomy, okay, what we have to do, we have to pull out the proximal 2 feet of the ileum beta, and we have to check for a Meckel's diverticulum. Reason, a lot of times it has happened beta that the patient was actually having a Meckel's diverticulitis beta, but as the symptoms are very similar to acute appendicitis, the patient was operated for appendectomy beta, and at that time the proximal 2 feet of the ileum was not pulled out. Due to that, what happened, that Meckel's diverticulitis was left like that itself, and ultimately the Meckel's diverticulum perforated, and the patient landed up in perforation peritonitis. Isliye it is a rule in appendectomy that we always have to pull out the proximal 2 feet of the colon to rule out any Meckel's diverticulum. Clear about that? Is important. So usually beta, Meckel's will be found as an incidental diagnosis itself. If they ask you what is going to be the most common clinical picture, previous year question again, the most common clinical picture beta is nothing else but bleeding per rectum beta. Yes, usually the most common clinical picture in a patient of Meckel's diverticulum is going to be bleeding per rectum बच्चे. Okay, that has to be remembered. Now if they ask you, if will there be pain in Meckel's diverticulum, pain in Meckel's diverticulum beta only occurs if definitely there is any obstruction. Why? Because if there is obstruction of the Meckel's diverticulum beta, obviously all the mucus which is there beta, it stays collected in the Meckel's diverticulum, ultimately due to which the Meckel's diverticulum gets infected and inflamed, leading to Meckel's diverticulitis. And the Meckel's diverticulitis is the reason for pain in a patient of Meckel's diverticulum beta. Okay? So pain which is there beta, it is actually going to be due to Meckel's diverticulitis itself. If they ask you investigation of choice, very important beta. If they ask you investigation of choice, तो याद रखना beta, investigation of choice has to be technetium 99 per technate scan. This is somewhat different beta. It is actually a nuclear scan which can pick up even the minute amount of bleeding in a patient of Meckel's beta. That's the reason technetium 99 per technate scan is the investigation of choice. And as it is different, it is very commonly asked in your examination. Can anybody tell me in the chat box that technetium 99 cystamoeba scan is the investigation of choice for which gland? Technetium 99 cystamoeba scan is the investigation of choice for which gland? The recent FMG 6 July question था वो. Treatment, if they ask you beta, now in a patient of Meckel's diverticulum, if beta definitely the Meckel's is having, see, a wide mouth and a wide base, will that Meckel's even get obstructed beta? No. And if the Meckel's will not get obstructed, there is no risk of any diverticulitis or perforation, right? So that's the reason bache, if there is a wide mouth and a wide base beta, there is no problem as such. You can leave the Meckel's diverticulum as it is. Yes, okay, so please remember beta, if there is a wide mouth and a wide base, you can leave the Meckel's diverticulum as it is beta, no issues with that. But if there is a narrow mouth and narrow base beta, do not leave the Meckel's diverticulum. Reason is, if there is a narrow mouth and a narrow base beta, obviously the chances of obstruction in the Meckel's diverticulum will be very high. That can actually increase the risk of diverticulitis and even perforation. Therefore beta, then we have to remove the diverticulum, and removal of diverticulum, I hope all of you are quite aware, is known as diverticulectomy beta. Are clear here? That is important. Now if they ask you what can be the complication beta, so you have to remember bache, the complication in a patient of Meckel's diverticulum, as I've told you beta, the diverticulum which is there, it is going to perforate. Okay, if there is too much of pressure or there will be ulceration, that diverticulum is ultimately going to perforate, and due to perforation of the Meckel's diverticulum, the patient will have peritonitis beta. Okay, Meckel's diverticulum is perforating, matlab intestine is perforating, and hollow viscous perforation, we know it is going to cause peritonitis. So please remember beta, perforation peritonitis will occur as a complication. और हमें पता है whenever the patient has a perforation peritonitis, again I am repeating, you have to first do a basic resuscitation in the patient, then you have to go for a definitive management, and that is exploratory laparotomy with peritoneal lavage has to be done. And finally what we will do, if the Meckel's diverticulum is perforated beta, is there any use of keeping this perforated part in the intestine now? No beta, there is no use of keeping this perforated part, so we cut out this part beta and we join the remaining parts beta. Now when I cut out, that is called as resection, and when I join the remaining ones, that is called as anastomosis beta. Clear hai? So perforation peritonitis agar hota hai, then the definitive surgery which is there along with exploratory laparotomy and peritoneal lavage has to be resection and anastomosis beta. So technetium 99 system EB scan is the investigation of choice for parathyroid gland problems. Okay, not thyroid, parathyroid. ठीक है, तो याद रखना बेटा, parathyroid gland problems के लिए the investigation of choice is technetium 99 system EB scan. System EB, SESTAMIBI. याद रखना ये बात, very very important question. ठीक है, clear to all of you now? This was all about your Meckel's diverticulum beta. Okay, this is all about your Meckel's diverticulum. Let's talk about the second important condition for your examination, and that is known as intussusception beta. Now what do I mean by intussusception? See, these are the two parts of your intestine beta. So when one part of the intestine goes into the adjacent part of the intestine beta, yes, when one part of the intestine goes into the adjacent part of the intestine beta, this is what is known as intussusception beta. Okay, so intussusception is nothing else but telescoping, invagination, okay, whatever you call it as. So it is either called as telescoping or invagination of one part of the bowel into the adjacent part of the bowel beta is what is known as, okay, it is telescoping or invagination of one bowel loop into the adjacent bowel loop beta is known as intussusception. Now there are two types of intussusception beta we have to remember. Either it can be a primary intussusception or it can be a secondary intussusception beta. Now what are the basic differences? Let's talk about them. The primary or secondary intussusception. याद रखना, more common is going to be a primary intussusception itself. More common is going to be the primary intussusception. Now if they ask you beta, what are the differences? First of all, primary intussusception is more common in which age group beta? It is more commonly seen in children between 6 months to 2 years of age. Primary intussusception is more common in very small children beta between 6 months to 2 years of age. Why after 6 months? Because complementary feeding is usually started after this. Okay, secondary intussusception which is there beta, it can be more common in older children beta who are more than 2 years of age, or it can be very commonly also seen in adults as well. Okay, याद रखना, the primary intussusception is more common in small children beta, that is 6 months to 2 years of age. Secondary intussusception can be seen in children or adults. Next important, if they ask you what is the most common site, the most common site for a primary intussusception is going to be the iliocecal junction. Reason beta, we know that the ileum is smaller and the cecum is larger in diameter. So that iliocecal junction which is there beta, it is actually going to be the most common site definitely for a primary intussusception beta. No issues with this. Whereas if I talk about definitely beta, the secondary intussusception is going to be colocolic beta, right? It is going to be more commonly colocolic. That means when one part of the colon goes into the adjacent part of the colon. So more common is going to be which one? As I've told you already, iliocecal junction is going to be much more common site beta. Next important, if they ask you what is the most common cause now, so yaad rakhna, for primary intussusception beta, the cause is actually going to be hypertrophy of the Peyer's patches. Peyer's patches are the lymphoid tissue in the ileum beta. So due to hypertrophy of the Peyer's patches beta, the ileum of the patient is actually going to become heavier and it slips into the cecum of the patient. Clear about? So please remember, it is due to hypertrophy of the Peyer's patches beta that the patient may develop a primary intussusception beta. Okay? Whereas secondary intussusception which is there beta, it is either due to some tumors. Okay, it is either due to some tumors or it can be due to polyps beta. So tumors and polyps are the reasons why the secondary intussusception is going to develop. Can anybody tell me that which vaccine is basically associated with intussusception? कौन सी vaccine है that could be associated with intussusception? Anybody? The vaccine that is associated with intussusception would be, it is the rotavirus vaccine beta that will be associated. Okay, so that is important. Now if they ask you beta that what will be the clinical features in the patient, see this one is the intussusception beta. Very good. So here you are able to see beta the one part of intestine going into the adjacent part of intestine beta. This is what is classically called as intussusception beta. Okay. Now important is what will be the symptoms of the patient. We know if there is intussusception beta, can you see there is going to be intestinal obstruction? Yes. So please remember bache, if I talk about an intussusception, so for example this is an intussusception beta. याद रखना, the part which is going inside beta, the part which is going, or the loop which is going inside basically is known as the intussusceptum. Okay, the loop which is going inside beta is actually called as the intussusceptum beta, whereas the loop which is receiving, okay, the receiving loop which is there beta, it is known as intussuscipiens. The loop which is receiving it is known as the intussuscipiens. Okay, whereas this part which is there beta, it is basically going to be the apex. Okay, and this is going to be the neck of the intussusception. याद रखना, if they ask you beta that minimum blood supply is received by, याद रखना minimum blood supply is received by the apex, and that's the reason beta there will be a very high chance of strangulation and perforation at the level of apex. Okay, there is a very high chance of strangulation and perforation at the level of apex beta because it receives the minimum blood supply. Clear? The one that goes inside is the intussusceptum. The one which receives it is known as intussuscipiens. Okay, and then we have the apex and the neck. Apex is the most common site for strangulation or the perforation of the intussusception. Now, what will be the clinical features? As I've told you beta, if the patient is having a intussusception, obviously the baby is going to have intestinal obstruction or bowel obstruction. So all the features of intestinal obstruction can be there, right? So the patient is going to have abdominal distension beta. Apart from that, the baby can also have abdominal pain as well, right? The patient is going to have abdominal distension. The baby can definitely have an abdominal pain, or even beta a late feature can be present, and that is vomiting. Okay, due to bowel obstruction, a late feature of vomiting can be there. Apart from that, very classical, and that is these blood and mucus containing stools can be there in patients of intussusception beta. Okay, the blood and the mucus containing stools in the patients of intussusception is classically called as the red currant jelly stools beta. Those are known as the red currant jelly stools. One of the important hints for intussusception beta. Next important, if I'm going to palpate the abdomen of the patient, we know the most common site is the iliocecal junction beta. We know the iliocecal junction is normally present in the right iliac fossa. But when intussusception happens now, the iliocecal junction which is there beta, it gets pushed or it gets shifted upwards beta. And that's the reason beta in the upper part of abdomen on palpation, okay, you will be able to feel this kind of a lump or this kind of a mass beta. A longer mass when you are able to feel like this beta. That is what is called as a sausage shaped lump. We have discussed that olive shaped lump which is there beta is a feature of CHPS. But if they say on palpation beta, you are able to feel a sausage shaped lump, that is going to be a feature of intussusception. And as the iliocecal junction has been pushed upwards, the right iliac fossa of the patient is going to be empty beta, and the right iliac fossa which is empty is classically called as the sign of dance. Okay, write down on palpation definitely beta there is a sausage shaped lump which will be felt in patients of intussusception, and this is a keyword beta in the patients. Okay, it is actually the keyword to diagnose the question again. Sausage shaped lump is seen in. So sausage shaped lump is a feature of intussusception. Next important, due to that beta, there is an empty right iliac fossa, and I've told you this empty right iliac fossa which is there is classically called as which sign? The empty right iliac fossa is classically called as beta the sign of dance. It is known as the sign of dance. No issues with this, anybody? If they ask you beta what is going to be the first line investigation over here, so the patient comes to us beta with features of intestinal obstruction. So as the patient comes to us with features of intestinal obstruction, the first line investigation we will do is going to be an X-ray abdomen. And when we go for an X-ray abdomen in this child beta, we will be able to see, okay, we will be able to see a very classical finding. A half moon shape is seen, and I hope all of you are quite aware. Half moon shape in medicine is always called as either a crescent sign or we can call it as the meniscus sign beta. Okay, either we can call it as the crescent sign or the meniscus sign. That is rare beta. that you are able to see that sign. ठीक है, तो एक्सरे is just the first line investigation, you have to remember. And if they ask you कि एक्सरे पे कौन सा साइन दिखता है, the answer has to be the crescent sign or the meniscus sign. What is more important and what is actually the investigation of choice beta? The investigation of choice has to be an ultrasound abdomen beta. ठीक है, the investigation of choice for a very small children is going to be an ultrasound abdomen. Yes, definitely if the patient is an adult beta, then you may have to go for a CECT abdomen in some cases. ठीक है, so you may have to go for a CECT abdomen if the patient is an adult beta, but otherwise ultrasound abdomen is more than enough to make a diagnosis of intussusception. And when we do an ultrasound abdomen beta, we will be able to see a very classical feature. And what is that? It is this sign beta over here. Obviously one loop of intestine in the another loop of intestine is seen now. So therefore beta, we are able to see concentric circles in the ultrasound. And we know whenever concentric circles are going to be seen beta, this is classically called as which sign? It is classically called as the target sign, or we can even call it as the donut sign beta. So the ultrasound abdomen which is there beta, it is going to show us the classical sign, which is either called as the target sign beta, also known as the donut sign. Okay, so that has to be remembered. So याद रखना, very classical, that ultrasound abdomen in patients of intussusception shows a target sign or a donut sign. And laterally if you see beta, then you will be able to see a pseudo kidney sign. Okay, it looks like the kidney, basically it is not the kidney. Now if they ask you beta, what is the gold standard investigation? Do remember, the gold standard investigation for a patient of intussusception has to be a barium enema or any contrast enema for that matter. Now we might have seen beta that barium enema is usually not even done in most of the conditions. Even if it is done, it is very rarely an investigation of choice. But here it is a gold standard investigation. Now why barium or a contrast enema would be a gold standard investigation in a patient of intussusception? Understand. Now first of all beta, you will insert a catheter up to the patient's rectum beta from the anal canal, and via that catheter you have to inject a contrast beta, that is a barium sulfate solution. I've told you it will travel all the way into the patient's large intestine, and then you will take a x-ray. That is how you get the barium enema of the patient, right? This is the picture of the barium enema. Now when you have got the barium enema of the patient beta, you are able to see these two very classical signs. And what are these two classical signs that you are able to see on the barium enema? On this barium enema beta, I am able to see first of all this sign over here that they have highlighted, and this is classically known as the claw sign beta. Doesn't it look like a claw, right? This is basically called as the claw sign. Apart from that beta, the other sign which will be there, claw sign is very classical, yaad rakhna. And this picture is also very commonly repeated in your exam. Okay, apart from that, this another sign which is there. Can you see the distal part to the intussusception? So this sign which is there beta, it is classically called as the coiled spring sign. Doesn't it look like a coiled spring? So this is known as the coiled spring sign. याद रखना बेटा, we are able to see a cross sign, and secondly we are able to see a coiled spring sign beta. These are the features that are definitely visible in the barium enema of an intussusception case beta. Okay, that is important. Now this is helping us in diagnosis beta, right? So with the help of barium enema we were able to make a diagnosis, that's fine. But now with the same catheter, with the help of which beta you have pushed in the barium sulfate solution, with the same catheter, can I also push in a lot of fluid beta or a lot of air also? Yes, because if I push a lot of fluid or a lot of air via that catheter beta, so there is a lot of fluid or a lot of air coming from downwards. So what is going to happen beta? Ultimately there will be a lot of pressure on this part which has gone inside, and therefore slowly beta, this part is actually going to reduce. This part is going to come outside beta. And if I'm going to use water, that will be called as a hydrostatic reduction. If I'm going to use air, it is called as a pneumostatic reduction beta. Please remember, with the help of a contrast enema or a barium enema, as I was also able to treat the patient, as it is diagnostic as well as therapeutic, therefore it should be called as the gold standard investigation. Clear about that? Is important. So if they ask you beta, treatment which is there, so please remember the treatment would be contrast enema beta, which would be done over here. Okay, the treatment which is there बच्चे, it is nothing else but contrast enema in the patient. And contrast enema से क्या करेंगे अपन? Either we will go for a hydrostatic or a pneumostatic beta. Okay, either we will go for a hydrostatic or a pneumostatic reduction. And if you have tried beta the hydrostatic or a pneumostatic reduction, but still you are not able to reduce that beta, then what we are going to do? Obviously you are going to open the patient. That means you are going to go for exploratory laparotomy. And then when we go for exploratory laparotomy beta, okay, in the surgery basically, if this fails, then we take up the patient for exploratory lab. And please remember, when we do a exploratory laparotomy beta, we do one thing, we try to reduce this surgically. Now when we will try a surgical reduction beta, do remember what we are going to do. Surgical reduction mein beta, there is a rule that is followed for interception, and that is the rule, that is what rule beta? Never pull, always push. Reason, if you are going to pull it beta, there will be a very high risk of strangulation or perforation. That's the reason how we will do. We are actually going to press beta the distal part. Why? Because as you are going to press the bowel loop beta, okay, sorry, as you are going to press the distal bowel loop beta, obviously the proximal loop which has gone inside will come outside, right? See, for example, if I am pressing this loop beta from outside, right? As you press this loop, keep on pressing this loop beta, slowly, you can see this loop has come outside. So never pull, always push beta. That is what is done. Clear about? That is important beta. So if it fails, definitely we can go for a surgical reduction. If this pneumostatic or hydrostatic reduction fails, then you have to go for a surgical reduction. And surgical reduction mein, what is the rule that is followed? I hope all of you remember. You can write down also, and that is never pull, always push. Okay, that is important. Next important beta, if they ask you, there are certain conditions, like for example, a patient is having a recurrent intussusception beta, or the patient is basically having perforation or strangulation beta. If the patient is having recurrent intussusception, or there is perforation or strangulation, in these conditions, what is going to be the surgery of choice beta? If there is recurrent case, or if there is perforation or strangulation, obviously can we keep the perforated part over there? Obviously not. In these conditions, what we do, we actually go for cutting that part out beta and joining the remaining part. Cutting the part and joining the remaining ones is called as resection and anastomosis beta. So please remember, if they ask you what will be the surgery of choice in these all conditions, surgery of choice in all these indications, if they ask you, then your answer has to be beta, resection and anastomosis. Okay, no issues with this, anybody? That is important. So that was all about your intersusception beta. That was all about your intersusception. Now let's talk about the next condition, and that is a sigmoid volvulus. Now I've told you all beta already what is the volvulus. Volvulus is nothing else but beta when the organ which is there, it will undergo twisting or it will undergo malrotation. So when an organ is going to undergo twisting or malrotation beta, that is what is known as a volvulus. And I've told you the most common site for volvulus in the whole GIT is going to be the sigmoid colon itself. Okay? So sigmoid volvulus, if I talk about bache, it is nothing else but malrotation of the gut beta. It is nothing else but malrotation of the gut. In which manner? In an anti-clockwise manner or anti-clockwise direction. That means, see, if this is the sigmoid colon beta, it will undergo a twisting basically in this direction beta. Okay, it will undergo a twisting in this direction. That is the anti-clockwise direction. Sorry. Risk factors, if they ask you beta for sigmoid volvulus now. We know that this is the sigmoid colon bache, and if this is the sigmoid colon, it is going to be supported with the help of mesentery beta. Okay, it is going to be supported with the help of mesentery. Now important is, if this mesentery which is there beta, it is very narrow and thin beta. If the mesentery which is there, it is extremely long, it is extremely narrow. Okay, so what is going to happen? If the mesentery is very thin, it is extremely long beta and narrow. Due to that, what will happen? The sigmoid colon now will be free, and if the sigmoid colon is free beta, therefore it will undergo twisting. There will be more chances that the sigmoid colon can undergo twisting if it is not having a proper support. Okay, or if the sigmoid colon is filled with a lot of feces beta, that is a loaded sigmoid colon. Okay. So the risk factors for sigmoid volvulus beta, they are going to be, first is if the patient is having beta a long and a narrow mesentery. Okay, and second one, if the patient is actually having a loaded sigmoid colon. Okay. If they ask you what will be the complaint, so same beta, we know sigmoid volvulus is a part of intestine, so it undergoes a twisting, so that will lead to intestinal obstruction. So all the features beta, so marked in the patient will have a marked or a severe abdominal distension, because the patient will not be able to pass any feces or any gas beta. Next important, the patient will have inability to pass feces, that is constipation, inability to pass flatus, that is obstipation, and the patient who is there beta can also have abdominal pain at times beta, and there will be vomiting as well. Okay, vomiting will be a very late feature in patients of sigmoid volvulus, very very late. Okay. If they ask you, beta, what are going to be the complications now? So please remember, beta, if I talk about the complications could be, as the intestines have undergone a twisting, beta, or a volvulus, maybe the intestinal loops are not receiving enough blood supply, beta, and that is the reason the intestines have undergone a strangulation. Second important, beta, here the patient will have a very high risk of perforation, beta, and due to perforation, what will happen? Why perforation? I hope all of you are quite aware. As the sigmoid volvulus has undergone twisting, it is not receiving enough blood supply. Therefore, it will undergo necrosis and that will cause perforation. Due to perforation, the patient will have peritonitis, bache. And lastly, the patient may land up into sepsis also, beta. Okay, these could be the complications of sigmoid volvulus. If they ask you when the patient comes to us in the emergency, what should be the diagnosis, beta? I hope all of you are quite aware. The first line investigation. Any patient this patient is coming to me with all the features which are suggestive of intestinal obstruction. Therefore, the first line investigation has to be an X-ray abdomen. The first line investigation would be an X-ray abdomen. And if I go for an X-ray abdomen, you are able to see very classical feature in patients of sigmoid volvulus. In the X-ray abdomen, in a case of sigmoid volvulus, beta, we are able to see this twisted sigmoid colon, okay, which is giving us a very classical sign. It looks like the coffee bean. So this is classically called as, beta, the coffee bean sign. Okay, so X-ray abdomen which is there, if that X-ray abdomen is showing us the classical coffee bean sign, beta, that is what is suggestive. Okay, if the X-ray abdomen is showing us the classical coffee bean sign, beta, that is what is suggestive of a sigmoid volvulus on an X-ray. Understood? Very good. Next important, if I talk about, beta, this investigation which is done over here, this investigation is nothing else but a barium enema. And when I go for a barium enema, beta, you are able to see that the barium which is there, it is coming from the rectum, it is going into the sigmoid colon, but it is not able to travel further, beta. Why? Because here in the sigmoid colon somewhere there has been a twisting, and due to that you are able to see very classical appearance, beta. Here there is a narrowing which is seen and which looks like the beak of a bird, beta. So this is classically called as the bird beak sign, beta. Right, this is classically called as a bird beak appearance or the bird beak sign. Apart from that, beta, here you are able to see this contrast which is going, beta. It looks like as if the bird is actually having some prey in his mouth, beta, so or in his beak, beta. This is called as the bird of prey sign also. This is classically can be called as the bird of prey sign. Or we can even call it as the ace of spade sign. So whatever you call, beta, the sign, the name of the sign remains same. Okay, so whether you call it as the bird beak sign, or you can call it as the ace of spade sign, or you call it as the bird of prey sign, whatever. ठीक है, याद रखना है बात, बेटा, that the bird beak appearance on a barium swallow is a feature of achalasia cardia, and bird beak appearance on the barium enema is a feature of sigmoid volvulus. Clear to all of you now? That has to be remembered. Now, if they ask you what is the investigation of choice, whether you go for a X-ray, beta, or a barium enema, both of them are not going to confirm your diagnosis. So your investigation of choice, beta, in all cases of intestinal obstruction, we know the investigation of choice for an adult has to be a CECT abdomen, beta. That is nothing else but a contrast enhanced CT scan of abdomen. So for an adult, beta, the investigation of choice which is there, it is a CECT abdomen to be remembered. Whereas for a child, it has to be an ultrasound abdomen. For a child, we have to go for an ultrasound abdomen. That is important. Clear about? If they ask you, that what is going to be the treatment in the patient, so let's talk about that. If I say my patient is stable, beta, by stable here I don't mean hemodynamically stable, beta. By stable in patients of sigmoid volvulus, we mean that means the patient is having no complications. Clear about? By stable, beta, in patients of sigmoid volvulus, we mean basically that the patient is having actually no complications. So when my patient is going to have no complications, then I will consider my patient as stable, beta. So in this patient, what should be the emergency management? So emergency, beta, what we will do, understand. Here the sigmoid colon is twisted. So we will pass a sigmoidoscope, beta, via the patient's anus up to the patient's sigmoid colon. Right. Once that sigmoidoscope basically goes up to the patient sigmoid colon, beta, we are going to connect an empty syringe to it, and we are going to aspirate all the gas, beta. Right. Reason is, if I aspirate all the gas from this twisted sigmoid colon, obviously the pressure inside the sigmoid colon is going to decrease, and due to that beta, the sigmoid colon will come back into its original position, and this is what is called as a decompression beta. And as it is done with the help of a sigmoidoscope beta, it is known as a sigmoidoscopic decompression. So yaad rakhna, the emergency management bit in the patient of a sigmoid volvulus when the patient is stable is a sigmoidoscopic decompression. When we have done a sigmoidoscopic decompression beta, after that definitely, now what should be the definitive management? The definitive management is beta, there are two options. One is definitely either removal of the sigmoid colon called as a sigmoidectomy, or second is beta fixation of the sigmoid colon known as sigmoidopexy. What is going to be better? So if they ask you beta definitive management in a stable patient, the better option which is there beta, it is actually a sigmoidectomy. You will be like, sir, why? Reason beta, if you do a sigmoidectomy, the chances of recurrence are going to decrease. There will be no recurrence, only no sigmoid colon. Okay, so please remember beta, as in sigmoid volvulus, there is a very high chance of recurrence beta. So even after fixation, there is a high chance of recurrence. So it's better to get it resected beta, that is sigmoidectomy will be considered as a better option than a sigmoidopexy, because if the next time the patient has a sigmoid volvulus, and that can lead to perforation, the patient may die out of it, right? That's the reason the better option is sigmoidectomy. Next important, if the patient is unstable beta, now what is going to be the surgery of choice? So please remember, my patient is unstable, that means my patient is having complications, that is patient is having either strangulation, perforation, sepsis, peritonitis, something like this. So what we do in this patient beta, we have to go for an exploratory laparotomy. Once we go for an exploratory laparotomy, if there is peritonitis, we have to clean the peritoneum by peritoneal lavage. After that beta, as the sigmoid is perforated or strangulated over here, we have to remove the sigmoid colon, that is sigmoidectomy. And after we have done a sigmoidectomy beta, now what is left behind? We definitely have beta the descending colon which is left behind, and then we have the rectum over here which is left. Can I immediately go for a colorectal anastomosis beta? No. Reason why we should not go for immediate colorectal anastomosis? Reason beta, if you go for immediate anastomosis over here, now as there was peritonitis or as there was infection in the abdomen beta, the sutures which are there, those are not going to stay, those will break immediately. That's the reason beta, it's better that you wait for few days and then you go for a anastomosis. But for few days, how the patient is going to pass the stools beta? So for that, definitely you have to bring out this descending colon beta on the anterior abdominal wall. Yes, you have to create an opening beta with the descending colon on the anterior abdominal wall, so that the patient will definitely pass the feces out from here beta, and they will be collected basically in the stoma bag. Okay, and the stoma bag has to be regularly cleaned, right? So this is actually a temporary procedure beta. After few days, once the patient's infection which is there beta, it has got resolved, okay, then definitely you can bring inside the sigmoid colon beta, sorry, you can bring inside this descending colon beta, and then you can immediately go for a colorectal anastomosis. But till that time beta, you have to do a colostomy, right? This procedure which is there where we have created an opening for the colon has to be called as a colostomy, and this is actually a proximal end colostomy which we do as a temporary procedure for few days. Okay, and later on we can go for a delayed anastomosis. This surgery which is there beta, the what I've explained to you now, this surgery together is classically called as the Hartmann's surgery or the Hartmann's procedure. Alright, this surgery which I have explained to you beta is classically known as the Hartmann's surgery or the Hartmann's procedure. Right, Hartmann's surgery or Hartmann's procedure. What we did an exploratory laparotomy. After doing an exploratory laparotomy, we did a peritoneal lavage properly. After that, we have removed the sigmoid colon, that is a sigmoidectomy, and after that, we have done a proximal end colostomy beta. This together is what is called as the Hartmann's procedure or the Hartmann's surgery. Clear about? Sure. Next important beta, if I talk about, is going to be definitely our Hirschsprung's disease beta. Shall I? Now, if I talk about the Hirschsprung's disease beta, okay, Hirschsprung's disease is also known as congenital aganglionosis or congenital megacolon beta, right? This condition which is there is known as congenital megacolon or congenital aganglionosis. Now, what is this condition? Let's try to understand. So beta, we know that in our GIT basically we have four walls: the mucosa, submucosa, muscularis, and the serosa. Okay, I've told you that in the mucosa, sorry, and in the submucosa beta, the plexus that is going to be present is known as the Meissner's plexus. Okay, whereas in the muscularis beta, the plexus that is present basically is going to be the Myenteric or the Orbach's plexus. Now, in this condition, what happens, beta? In Hirschsprung's disease, also known as congenital aganglionosis. नाम में ही सब कुछ है. Congenital means present since birth. And what is the problem? Aganglionosis. That means there will be absence of ganglionic cells, beta, from both these plexuses. Yes, not only one, both the plexuses. ठीक है? So, beta, in some part of the intestine, basically in patients of Hirschsprung disease, there is absence of ganglionic cells or absence of neurons, beta. Right? Both from the Meissner's as well as the Myenteric plexus, beta. ठीक है? And that's the reason definitely. Now please tell me, this segment of intestine which is not having ganglionic cells in their plexus beta, will the muscles of this part get stimulated? No. So will there be any proper peristalsis in this part beta? No. So as there is no peristalsis itself beta in this aganglionic segment, this aganglionic segment beta remains collapsed, right? The basically this aganglionic segment which is there beta, it is going to remain collapsed basically, and that is the reason the baby is going to have an intestinal obstruction. Clear about? Hopefully that's clear to all of you. And we know beta that if this affected segment which is there beta, if this affected segment will remain collapsed beta, okay, obviously all the food which is there, all the feces which are there, they will collect in the proximal normal segment beta, and as the proximal normal segment beta will keep on collecting a lot of gas, feces, everything, therefore that segment will go dilated beta, and as that proximal segment gets too much dilated, that will be called as a megacolon. Okay, so either you can call it as congenital megacolon or a congenital aganglionosis. So Hirschsprung's is basically, sorry, it is basically beta due to absence of, okay, it is basically due to absence of beta the ganglionic cells in the Orbach's, that is the Myenteric plexus, as well as the Meissner's, that is the submucosal plexus beta. Clear about? Please remember that that both the plexuses are having absence of ganglionic cells. In the recent NEET PG, there was a question where they gave a histopath of the wall beta and they marked mucosa as 1, submucosa as 2, muscularis as 3, and serosa as 4. And they gave a classical clinical picture of Hirschsprung disease, and they asked that in which among the following layers there is a problem in this patient. So obviously we know beta that if it is a case of Hirschsprung disease, there is actually absence of ganglionic cells in the Meissner's, that is submucosal plexus, and the Myenteric, that is a muscularis plexus. So it was the layer number 2 and 3, right? So that is how the questions are framed. So if they ask you beta that Hirschsprung disease is associated with which condition, so do remember beta the Hirschsprung disease is associated with a trisomy 21, that is known as Down syndrome. I've told you the two GI anomalies which are associated with Down syndrome beta. One was duodenal atresia. The second one you have to remember is known as Hirschsprung's disease. Okay? If they ask you beta that what is the most common site for Hirschsprung disease, so please remember beta the most common site which is going to have this absence of ganglionic cells, it is basically the distal part of intestine, most commonly the rectum, followed by the sigmoid colon. So together I can call that part as rectosigmoid beta. Okay? Together you can call it as the rectosigmoid. So the most common site which is there beta, it is the rectosigmoid, rectum followed by the sigmoid colon. Okay. Now if they ask you beta what will be the features, understand now. If I say beta that a very small segment of the intestine is aganglionic, so obviously the baby may not have severe symptoms, and the patient who is there beta may come to me later in life, not immediately at birth. The patient can come to me later in life because there is a very small segment which is aganglionic, right? So the patient may come to me in the childhood beta, and the patient's complaint will be what? The mother will say that the child will have a chronic or a recurrent constipation, and there is some sorry, abdominal distension somewhat. Okay, so that is important beta. That is going to be the complaint definitely in a child who is having a very small segment which is aganglionic. But if a baby is having a very long segment beta which is aganglionic, right? If there is a very long segment which is aganglionic beta, then the baby is having severe problem, and therefore the baby will present to me in the emergency beta, and that too at birth itself, right? The baby will be brought to me in the emergency, and that too beta at birth or immediately after birth, because we know definitely beta we wait for the meconium to pass within 48 hours. I hope you might have discussed in pediatrics. Okay, So the meconium which is there, the first stools of the baby, should be passed within the first 48 hours, beta. Even after the first 48 hours, the meconium haven't been passed, then definitely we have to assess the baby properly, beta. Okay? And if the meconium has not been passed for more than 48 hours, that can be considered as a diagnosis of meconium ileus, right? And one of the reasons for meconium ileus could definitely be a case of Hirschsprung's disease, beta. So let's see now. If beta neonate is presenting to us, that means there is an acute presentation. A very long segment is aganglionic means. Okay? And here what will be the complaint of a neonate? The complaint of a neonate is going to be failure of passage of meconium, beta. The baby was not able to pass the meconium itself. Okay, and due to that the baby is having a severe abdominal distension. Can you see in this baby, beta? This is a neonate of a Hirschsprung disease. Can you see such a severe distension of abdomen is seen, beta? Okay. Now if they ask you on digital rectal examination, what will be done? See, as this baby will be brought to me, beta, I will perform a digital rectal examination. Normally we do a digital rectal examination with index finger. In neonates we will do it with the help of little finger. Now please be prepared, beta, for doing a DRE of this patient. ठीक है? तब क्या करोगे? You'll do a DRE of this baby, beta. And when I do a DRE of this baby, see what is the problem? That as the neurons are not present, beta, the rectum is not getting stimulated. And therefore, beta, the meconium is not able to pass. As I do a DRE, beta, and as I stimulate the rectum, as I do a DRE and stimulate the rectum, beta, there is a gush of meconium which comes outside. Jitna meconium andar tha, beta, whatever meconium was stored inside, na, all that flows outside, beta, like a flood. So the meconium floods outside, beta, if we are going to perform a DRE and we are going to stimulate the rectum. This is a classical case of Hirschsprung's disease. Now you are going to answer me a second condition which I am going to ask you, and that is babies again having failure of passage of meconium, beta. That is again there is a case of meconium ileus. In that condition also I perform a DRE, beta, but even on performing DRE and stimulating the rectum, there is no meconium which comes outside, beta. Meconium aata hi nahi hai. What is that condition which is a differential for Hirschsprung's? Please tell me that in the chat box. So as I told you, in patients of Hirschsprung's, beta, when you do a digital rectal examination, okay, so definitely there will be a meconium, the meconium which is there, beta, it is going to flood out. The meconium floods out over here. Right, the meconium is going to flood out over here, beta. That is important. Doing a DRE or a digital rectal examination, the meconium floods out. Yeah, tell me that in the chat box. Now next important bit if I talk about is if there is a small segment beta, as I told you, then a patient will present to me in the childhood beta. Okay, if only a small segment is affected, okay, then the baby will present to me in the childhood, not immediately in the neonatal period beta. And in this condition, the patient's complaint will be a chronic constipation, and along with chronic constipation beta, the patient will have a problem as failure to thrive. Okay, the baby will have a problem of failure to thrive, that is inability to gain weight. बच्चे का वजन नहीं बढ़ पाता है, that is important. ठीक है, please remember. Yes, very good. Yes, it is the diagnosis of cystic fibrosis. शाबाश. ठीक है, the closest differential, very common question of your exams. ठीक है, so if you do a DRE beta in a patient of meconium ileus, and if the meconium floods out, it is the case of Hirschsprung disease. And if the meconium does not come out even on a DRE, very good, it is a case of cystic fibrosis. ठीक है, that is important. Now beta, if I talk about this investigation of choice, तो याद रखना beta, the investigation of choice in the patient is nothing else but a suction or a full thickness rectal biopsy beta. Either I can go for a suction or a full thickness rectal biopsy. ठीक है, reason beta, if I have to see definitely whether the ganglionic cells are present or absent, obviously I have to do what? I have to do a rectal biopsy itself, na? So please remember beta, either a suction or a full thickness rectal biopsy. This is a common question which has been asked in your exam. Okay, so suction or a full thickness rectal biopsy is the investigation of choice in patients of Hirschsprung disease. Now once definitely you have done a rectal biopsy beta, and you know okay, there is absence of ganglionic cells beta in both the plexuses in the rectosigmoid area, then definitely how to check the extent of the disease beta. How we are going to actually check the extent of disease? Extent of disease means how much segment is actually affected. Okay, how much segment is actually affected. How we are going to check that? For that, definitely beta, the best investigation, henceforth remember, the best radiological investigation for all your pelvic and perineal structures is going to be a MRI. So therefore beta, to see the extent of disease, that how much segment is actually aganglionic or how much segment is collapsed, okay, uske liye we have to do a MRI. But if MRI is not available or it is not an option, you can go for a barium enema also beta. Even a barium enema can tell you about the extent of disease. This will not diagnose the condition. Diagnosis के लिए investigation of choice is rectal biopsy only. It will only tell you the extent of disease, how much segment is aganglionic then. ठीक है? If I talk about this is the barium enema over here in a patient of Hirschsprung's, and you are able to see on this barium enema what is seen. See this part which is there beta. This part of the rectum basically beta, which appears, this part of the intestine or the rectum which appears collapsed. This is a normal part or affected part. This part which basically appears collapsed beta, this is actually the affected or the aganglionic segment, right? So as you are able to see that how much segment is aganglionic over here, right? So please remember this is going to be the collapsed aganglionic segment. This is basically the transition zone beta, and this is the normal zone over here. And you see in the normal parts of the intestine there is too much of distension basically due to collection of all that feces and everything. Okay, therefore it is called as megacolon. Clear hai? So either a MRI or a barium enema can definitely tell you about the extent of the disease beta. If they ask you what is the surgery means there is a very easy beta thing that has to be done. That is, we know we cannot correct the neurons or ganglionic cells over there. So what we can do, the part which is not having definitely beta, the neurons basically, okay, we have to cut out that part, that is called as resection, and we have to join the remaining parts of the intestine, that is known as anastomosis. So all the surgeries of your Hirschsprung which are there beta, definitely they are based on this fund out itself beta, that is resection and anastomosis will be done in all of those surgeries. Slight modifications are there in each one of them. You don't have to remember anything, you just have to remember the main names of those surgeries beta. What are those surgeries done? The first one which is there beta we do is known as the Duhamel's operation. The first one that you have to remember is the Duhamel's operation. The second one that you do beta is known as the Swenson's operation. And the later one which was there definitely beta, it is known as the Sove and Parks operation, you can say, or Sove and Parks coloanal anastomosis. Reason, obviously beta, if I am going to remove the rectosigmoid area, what will be left behind will be the descending colon, okay, and the anal canal of the patient. So I have to do a anastomosis between the descending colon and anal canal now, so it will be called as a coloanal anastomosis. Okay, so याद रखना एक बात. So Duhamel's operation, Swenson's operation, Sove and Park surgery, these are the various kinds of surgery beta. Those are done in a patient of Hirschsprung's disease beta, that has to be remembered. Remember the names of surgery. All these three surgeries are still in practice beta. You can perform any one of them. That depends on the surgeon. Okay, so which one he prefers. Important is beta, if there is massive distension beta, yaad rakhna, if there is going to be a massive distension which is present, so please remember, do not go for an immediate repair. Do a colostomy for few days beta, and after you have done a colostomy for few days, once definitely the condition goes back to normal, once the diameter of the intestine goes back to normal, then go for a delayed definitive repair. So if there is a massive distension or a megacolon beta, do not go for an immediate repair. Do a colostomy for few days and then go for a delayed definite repair. Okay, chalo. Next condition that we have to talk about beta is nothing else but diverticulosis of colon. Now we know beta that diverticulum is what? It is outpouching. So diverticulosis will be what beta? Multiple outpouchings, right? Ossus is always excess beta. याद रखना है बात. ठीक है? So diverticulosis of colon is what? When there is multiple diverticulum beta, or there are multiple outpouchings basically from the intestine beta. That condition is what is called as a diverticulosis of colon. If they ask you which is the most common site, so please remember the most common site for diverticulosis of colon beta has to be the sigmoid colon. The most common site for diverticulosis of colon has to be the sigmoid colon. Okay, that is the left iliac fossa. Age, if they ask you beta, diverticulosis of colon is actually a condition beta which is usually seen in elderly patients. Yes, diverticulosis of colon is more commonly seen in elderly patients beta. Now what will be the complaints of the patient? Usually beta, if the diverticulum are large in size and if they are not getting obstructed or there is no problem as such, the majority of the patients are going to be asymptomatic. Okay, so usually beta, majority patients of diverticulosis of colon are asymptomatic itself, but certain patients may have some problems beta. And what will be those problems? The first one beta, the patient will have difficulty in passing stools, known as constipation beta, and second, the patient may have abdominal pain also. Okay, the patient definitely may have chances of constipation, or the patient may have abdominal pain. Now important is beta, apart from that, there can be certain complications which may arise in a patient of diverticulosis. The complications which are seen in a patient of diverticulosis beta, those will be the first one beta, obviously that diverticulum may bleed. I have told you yesterday itself beta, rather yesterday nahi, aaj hi. Today itself we have definitely discussed beta that what is the most common cause of lower GI hemorrhage in elderly patient. It is diverticulitis of colon, right? So definitely beta, it is going to cause bleeding. Okay, so please remember the patient initially develops diverticulitis, that is inflammation, and later on definitely there can be bleeding from it. The patient may also have a pericolic abscess beta, right? The infection can happen inside the diverticulum, and that can actually lead to pus formation beta around the colon. Now if they ask you what is the investigation of choice and management beta, so now let's talk about it. Investigation of choice and management for diverticulosis of colon. If my patient is uncomplicated beta, that means there are no complications like strangulation, perforation, diverticulitis, nothing is there. Okay, so if my patient is an uncomplicated case of diverticulosis of colon, the investigation of choice has to be a barium enema beta. Uncomplicated cases mein the investigation of choice is barium enema, and the barium enema will give me a very classical appearance beta. And what is the classical appearance of the barium enema in a patient of diverticulosis of colon? This classical appearance beta, आरी के दांतों जैसा लग रहा है ना, this classically is known as the sawtooth appearance beta. ठीक है, this classical appearance which is there beta in the sigmoid colon, it is classically known as the sawtooth appearance. So barium enema, when it shows a sawtooth appearance, it is very classical of the diverticulosis of colon beta. It is very classical of diverticulosis of colon. Now in this patient beta, what should be done? Please remember, in this patient beta, definitely whatever part of the intestine which is there, whatever part of the intestine is basically is having that multiple diverticulae beta, you have to cut out that part, that is resection, and join the remaining part beta, that is anastomosis. So beta, in uncomplicated case, the surgery of choice which is there is going to be a resection and anastomosis. It has to be a resection and anastomosis beta. Next important picture, if I talk about the complicated cases, that means the patient is either having abscess or perforation or diverticulitis. In these conditions, beta, if there is a complicated case of diverticulosis of colon, in those conditions, beta, the investigation of choice has to be a CECT abdomen. The investigation of choice has to be a CECT abdo. And apart from that, beta, if they ask you what is the management or the surgery of choice, so yaad rakhna beta, understand what we are doing. We are doing an exploratory laparotomy because there has been a perforation. We have to do a peritoneal lavage. After that, the sigmoid colon which has been perforated or strangulated, we have to cut out that is sigmoidectomy. And after that beta, we cannot go for immediate anastomosis because now there is an infection or inflammation. Therefore, we wait for a few days. Till that few days, we bring out the descending colon on the anterior abdominal wall and we create an opening for that colon, okay, on the anterior abdominal wall for the passage of stools, and that is called as a proximal end colostomy. What is this surgery called as? I've just now explained it to you. That surgery is classically called as the Hartmann's procedure beta. Hartmann's procedure is not only done bache in, okay, Hartmann's surgery or Hartmann's procedure, if I talk about, is not only done in a complicated sigmoid volvulus beta, it is also done in complicated diverticulosis of colon. Clear about? And here you will go for a delayed anastomosis once the infection or the inflammation is going to heal over there. This is actually beta a colonoscopy, and on that colonoscopy you are able to see these multiple outpouchings. Okay, done with this. Next important beta, if I talk about another condition, and that is called as mesenteric ischemia. Now what is ischemia? Ischemia basically means a decreased blood supply. Okay, ischemia is nothing else but beta a decreased blood supply, that is known as ischemia. Done with this. Okay, so we know beta what is the problem in mesenteric ischemia. Let's try to understand. For example, beta, if I talk about, see, this is the intestine of the patient beta, and I have told you that the intestine of the patient is usually supported by this fatty tissue called as the mesentery. But I've told you this also, that the mesentery does not only bring the mesentery does not only support the intestine beta, the mesentery also brings blood supply to the intestine, right? All the blood vessels which are there, okay, which supply the intestine are present in the mesentery itself. So now what is going to happen beta? I am saying that one of the blood vessels which is supplying the intestine, basically one of the blood vessels which is supplying the intestine is actually blocked, right? Now please tell me beta, if the mesenteric blood vessels which are there, if they get blocked, will your intestine receive blood supply beta? No, there will be decreased blood supply to the intestine, and that condition is what is called as a mesenteric ischemia. Now due to whatsoever reason that mesenteric blood vessel has got blocked beta, either it has got blocked due to a thrombus formation on that particular site, or it has been blocked due to embolism. That means the thrombus was in the heart, from there it has come all the way to these mesenteric blood vessels and it has caused a blockage over there, okay, due to whatsoever reason. But yes, the mesenteric blood vessels are blocked, and due to which beta the intestine is not receiving enough blood supply, and it has actually landed up in strangulation. Clear to all of you? That is important beta. So mesenteric ischemia, if they ask you beta, what is the most common cause? The most common cause of mesenteric ischemia is acute mesenteric artery embolism. Okay, if they ask you what is the most common cause, it is an acute mesenteric artery embolism. We know embolism occurs all of a sudden beta. Okay, so there was all of a sudden, definitely there was a blockage of the mesenteric artery. So acute mesenteric artery embolism. I hope all of you are quite aware beta, the main three blood vessels or the main three arteries which supply your GIT. Foregut which is there is supplied by the celiac trunk. The midgut is supplied by the SMA, that is superior mesenteric artery, and the hindgut is supplied by the IMA, that is inferior mesenteric artery. The most common vessel beta which undergoes an embolism, the most common vessel beta which undergoes an embolism is going to be the SMA. And what is SMA bache? It is the superior mesenteric artery. So the embolism which is there beta is usually seen in the superior mesenteric artery. That means the midgut which is there beta, it is not going to receive enough blood supply. Okay, so SMA of the superior mesenteric artery is the most common blood vessel to be blocked. Now if they ask you beta, what will be the problems in the patient, you have to remember beta, the problems are going to be the patient will have a mesenteric vein thrombosis. Okay, apart from that, the other causes which are there beta for mesenteric ischemia, one can be there is mesenteric vein thrombosis. Isme kyun? Because if the mesenteric veins are blocked beta, due to which the deoxygenated blood stays collected over there, and therefore the new oxygenated blood is not able to come to the intestines. That is another reason beta. Or it can be a mesenteric artery thrombosis also, that the mesenteric artery of the patient is blocked. तुम बोलोगे वो तो embolism में भी थी. Embolism में the blockage which was there or the clot which was there, it has come from somewhere else. Thrombosis में it has formed over there itself. ठीक है. Next important beta, CHF. What is CHF? Definitely that is congestive heart failure. Why? Because in CHF or in congestive heart failure beta, your heart is not able to pump properly, and if your heart is not able to pump, your intestine or your mesenteric blood vessels are not going to receive enough blood supply beta. Clear about that will cause a mesenteric ischemia. Now what are going to be the risk factors for a mesenteric ischemia? Yaad rakhna. As I told you beta, embolism is going to happen, and embolism happens when a thrombus comes from the heart. We know thrombus forms in the heart when the heart is only twitching. That is the case of atrial fibrillation beta, or in case of aneurysms. Okay. What will be the clinical features in the patient? As the intestine is not receiving blood supply, there is strangulation of the intestine. Therefore, the patient will land up into a sudden abdominal pain beta. Along with that, the patient will have a postprandial angina or a postprandial pain. Okay. That means after eating the meals beta, obviously now after eating the meals, the intestines have to perform peristalsis. But as they are not receiving blood supply, that will cause actually extreme pain in the patient. Okay? That is what is called as a postprandial angina or a postprandial abdominal pain. Along with that beta, the patient will have anorexia, there will be weight loss. Okay, the patient will have strangulation, as I've told you, and the patient will ultimately have peritonitis. Reason? If there is strangulation or necrosis of the intestine, ultimately the intestines are going to perforate, causing peritonitis as well. Okay? If they ask you what is going to be the investigation of choice, bache, sorry, the investigation of choice in this patient has to be a CT angiography. Why a CT angiography? Reason beta, here you have to see the blockage inside the blood vessels, and mesenteric vessels matlab the central blood vessels of your body. That's the reason the investigation of choice has to be a CT angio. Now beta, due to mesenteric ischemia, definitely there can be a problem also which can arise. And that one more complication which can arise beta is basically ischemic colitis. That means due to mesenteric ischemia beta, as there was decreased blood supply to the colon beta, definitely that colon has undergone an inflammation, and that is what is known as a ischemic colitis. So ischemic colitis, you can say it is nothing else but a complication of the mesenteric ischemia itself. And the patient, when he has a mesenteric ischemia or ischemic colitis, beta, there will be a very classical presentation on the barium enema. This classical sign which is seen in patients of ischemic colitis or mesenteric ischemia on a barium enema is called as what? Here definitely beta, the contrast is not taken up. So these are all the filling defects which are seen. But these filling defects are seen like a thumbprint basically. So this is classically called as the thumbprint sign beta. So barium enema in patients of ischemic colitis or in patients of mesenteric ischemia gives us the classical thumbprint sign beta. They give us the classical thumbprint sign. Here about that is important. So thumbprint sign on the barium enema is a very classical feature of ischemic colitis or mesenteric ischemia. Chalo, done with this. Now if they ask you about the treatment beta in the patient, what should be the treatment? See if the patient presents to you early beta. Shall I? Done with this. If the patient is presenting to us early, so early presentation hai, so obviously beta, we can try to remove the embolus or the thrombus from there na, and it is removed with the help of which catheter beta? I've told you we can remove it with the help of a Fogarty's vascular catheter, right? So removal of the thrombus or an embolus will be called as what? Embolectomy or a thrombectomy. So if the patient comes to me early beta, obviously we can go for an embolectomy or a thrombectomy beta. That could be done. But if the patient presents us, okay, along with embolectomy beta, what can be done? See, if the large vessel is blocked beta, I can easily go for an embolectomy. Okay, but if it is a very small vessel, then I can just go for an anticoagulation beta. An anticoagulation can be done. Anticoagulation in emergency is done with the injection of low molecular weight heparin beta. Okay, so that is important. Along with that beta, we should go for a bypass grafting as well. Sometimes definitely a bypass grafting will be required if that mesenteric vessel is still blocked and if the embolectomy does not work. In those conditions, you have to go for a bypass grafting. But if the patient has presented to us late beta, if the patient has presented to us late presentation में क्या करेंगे बच्चे? We know that in late presentation, the intestines would have undergone strangulation and perforation and ultimately led to peritonitis. So, जब भी there is peritonitis beta, we have to go for an exploratory laparotomy. We have to do a peritoneal lavage, and after that beta, the area which is strangulated or perforated, we do not keep that area, cut that area out, join the remaining parts, that is resection and anastomosis. So here beta, definitely in this patient, we have to go for an exploratory lab, peritoneal lavage any which ways, and the main surgery is resection and anastomosis beta, that has to be done. No issues with this, anybody? Chalo. Now let's talk about the next condition beta, and the next condition is nothing else but this you might have discussed even in patho and even in medicine beta. That is important to be remembered. Let's talk about that condition, and that is IBD. What is IBD? It is inflammatory bowel disease beta. So let's talk about IBD or the inflammatory bowel disease now. So if I talk about the IBD or inflammatory bowel disease, bache, okay, there are two types of inflammatory bowel disease. The first one is going to be Crohn's disease, second is going to be ulcerative colitis. So it is just a chronic inflammatory disorder of your GI tract or the chronic inflammatory disorder of your intestines mainly beta. Okay, the first condition is Crohn's disease, as I told you. The second condition is ulcerative colitis. If they ask you beta which is the most common site affected in both the conditions, तो याद रखना है बेटा that in a patient of Crohn's disease beta, any part of the GIT can be affected. Yes, any part of the GIT from mouth till the anus can be affected beta, except the rectum. Rectum is never affected in patients of Crohn's disease. That has to be remembered. First thing, the most common site affected is which one then? The most common site affected in patients of Crohn's disease is going to be terminal ileum beta. The terminal ileum is going to be the most common site affected in patient of Crohn's. Whereas in patients of ulcerative beta, do remember that Crohn's mein rectum is never involved, and in ulcerative rectum is the most common site. Okay? So rectum and beta, the most common site involved is going to be the rectosigmoid, that is rectum and sigmoid colon. The patients of Crohn's disease beta will come to you with crampy abdominal pain beta. Okay, they are going to come to you with crampy abdominal pain along with a watery diarrhea. Reason, the patient does not have absorption properly. Intestines are not going to absorb food. So due to that, definitely the beta patient develops an osmotic or a watery diarrhea. Next important, ulcerative colitis. As there is ulceration over here, there will be bleeding, and that's the reason the patient will have a bloody diarrhea or the patient will have tenesmus. What is tenesmus? The patient likes to pass, the patient definitely goes for passing stools beta but definitely there's nothing comes out. There's constant urge to defecate basically. Okay, that is known as tenesmus. Next important association, that these conditions are mainly associated with which other conditions beta. So Crohn's disease, which is there beta, it is commonly associated with inflammation of the joints. That is nothing else but arthritis beta. Whereas if I talk about ulcerative colitis, it is associated with a condition beta which is going to cause inflammation of the bile ducts. Inflammation of bile ducts will be called as cholangitis, and here due to inflammation there will be later on fibrosis, and due to fibrosis beta the bile ducts of the patient will get blocked, leading to obstructive jaundice, and that condition is known as a PSC, that is primary sclerosing cholangitis. So ulcerative colitis is commonly associated with a condition beta known as primary sclerosing cholangitis. Clear है? Next important, if they ask you about the involvement beta, तो याद रखना that in patients of Crohn's disease, definitely how is the involvement. Let's talk about that. So for example, if this is the wall beta, in patients of Crohn's disease beta, the involvement is going to be something like this, right? You can see, is it superficial involvement or the transmural involvement? Obviously we are able to see it as a transmural involvement. It is seen throughout the wall. Second, is it skip lesions or continuous lesions? Obviously you are able to see beta these are skip lesions. Okay, so please remember the involvement in patients of Crohn's disease is obviously going to be transmural beta, and that's the reason the risk of stricture formation is going to be more over here, and the regions which are there beta, as I've told you, the regions are going to be skip lesions in patient of Crohn's. If I talk about on the other hand beta, in cases of ulcerative colitis, what will be there? So yaad rakhna, in patients of ulcerative colitis beta, the lesions are something like this. In patients of ulcerative colitis, the regions are something like this beta. These are called as definitely the this is definitely the superficial involvement. First thing, there is a superficial involvement which is seen. Secondly beta, you have to remember that here the lesions which are there, they are skip or continuous. Here you are able to see beta there are continuous regions. In ulcerative colitis there will be continuous regions beta. Clear hai? Now if they ask you serology, what is serology? I hope all of you are quite aware. Serology is study of antigens and antibody, right? Serology is study of antigens and antibody beta. So obviously this conditions mein beta we will be able to see specific antibodies. Okay, now the antibodies which are usually seen in patients of Crohn's disease will be called as beta the ASCA antibodies. You might have studied. ASCA is what beta? It is anti-Saccharomyces cerevisiae antibody beta. Okay, what is ASCA? Basically it is anti-Saccharomyces cerevisiae antibody which will be seen in patients of Crohn's disease. Whereas if I talk about beta ulcerative colitis, in ulcerative colitis the antibodies which are seen beta, those are going to be called as the P-ANCA antibodies. Yes, in patients of ulcerative colitis beta, the antibodies seen are known as the P-ANCA antibodies, anti-neutrophilic cytoplasmic antibodies. याद रखना, ASCA antibodies in ASCA antibodies in Crohn's and P-ANCA antibodies in ulcerative colitis will be there. If they ask you what is the investigation of choice, तो याद रखना है बच्चे, investigation of choice for both the conditions would be colonoscopy plus biopsy beta. Yes, investigation of choice in both the conditions which is there beta, it is nothing else but we have to go for a colonoscopy with biopsy beta. Whether it is Crohn's disease or ulcerative colitis, the investigation of choice is going to be same beta. It is nothing else but colonoscopy and biopsy. When I go for colonoscopy in these patients beta, on the next page you will be able to see on the colonoscopy in a patient of Crohn's and ulcerative, the classical findings will be seen. Can you see? When you do a colonoscopy in a patient of Crohn's beta, due to a lot of fibrosis, you are able to see the classical cobblestone mucosa beta. Yes. So if they ask you cobblestoning or cobblestone mucosa is a colonoscopic feature of, answer has to be Crohn's disease beta. Whereas the second one, in patients of ulcerative colitis beta, you are actually able to see the edema, and due to beta that the mucosa is hanging outside. So this hanging out mucosa is what is called as a polyp, but this is not actually a true polyp beta, this is a pseudo polyp. So please remember, pseudo polyps on the colonoscopy beta is usually a feature of ulcerative colitis. So these are the things beta that you have to remember. No issues with this anybody? That is important. Now if I talk about the biopsy beta, okay, colonoscopy findings we have seen, biopsy pe now. When we do a biopsy and histopathological examination, on that biopsy and histopath beta, very classical findings are going to be seen. First of all, if I talk about a Crohn's disease beta, क्या दिखता है biopsy पे? Histopath and pathology and medicine you might have discussed. In the biopsy beta, you will be able to see the classical non-caseating granuloma beta. you will be able to see the classical non-case-eating granuloma. Whereas beta, in patients of ulcerative colitis, we will be able to see a very classical feature. I hope all of you are quite aware. In the intestines, we have villi, and then beta, there are definitely depressions between the villi. Okay, definitely these depressions which are there, they will be having collection of neutrophils within them beta. So these depressions are known as crypts, and if there is collection of neutrophils within them on the histopath, it is classically called as the crypt abscess beta. Right, on the histopath, it is classically known as the crypt abscess. No issues with this, anybody? Next, important, if they ask you what is the drug of choice. So याद रखना बेटा, drug of choice, if they ask you, this is the diagnostic features. Histopath is diagnostic for a case of ulcerative colitis or Crohn's disease for that matter. Now important is beta, before definitely we can also go for a barium enema beta. And when we go for a barium enema, these are the features on the barium enema beta. ये जो दिख रहा है दोनों, both of them are definitely barium enemas. And when we go for a barium enema in the patient, bache, in a patient of ulcerative colitis and Crohn's disease, what will be the features? Let's talk about them. First of all, beta, in a patient of Crohn's disease, we know that there will be a lot of fibrosis now. So here there is fibrosis and formation of strictures inside the intestine. And due to formation of strictures, beta, there is narrowing which is seen. And this is classically called as the string sign of Cantor. So if you are able to see beta, a string sign of Cantor in the intestine, that is very classical of a Crohn's disease beta. If you are able to see a string sign of Cantor in the intestine, that is classical of Crohn's disease. Next important bache, here in the patient of ulcerative colitis beta, you are able to see that the large intestine normally has that hostrations, right? But here beta, the large intestine is not having any hostrations. It is appearing like a pipe straight beta. So this is classically called as beta. This is classically known as the lead pipe colon. So if I am able to see definitely bache, lead pipe colon. Okay, that is what is suggestive of an ulcerative colitis. It is due to loss of hostrations beta. It is due to loss of hostrations. ठीक है, याद रखना string sign of Cantor is because of fibrosis in patients of Crohn's disease, and lead pipe colon is seen in patients of ulcerative colitis due to loss of hostrations. Done with this, so that has to be remembered. Now if they ask you beta, what is the drug of choice, I hope all of you are quite aware that inflammatory bowel disease mainly goes for a medical management beta. And when we have to do a medical management bache, the drug of choice for Crohn's disease, we know it is an inflammatory condition, so the drug of choice for Crohn's disease has to be steroids beta. याद रखना, the drug of choice for Crohn's disease will be steroids definitely. Whereas the drug of choice for ulcerative colitis beta, it is a 5-amino salicylic acid derivative, 5-ASA derivative known as sulfasalazine beta. It is a 5-ASA derivative known as sulfasalazine. Clear hai baat? That is important to be remembered, bache. If they ask you what are the other drugs, see, in both the conditions, both the drugs are usually given. But yeah, the drug of choice, if they ask you for ulcerative colitis, it is sulfasalazine. For Crohn's disease, it is steroids beta. The other drugs which are given, it is definitely antibiotics to prevent any secondary bacterial infections. The 5-ASA derivatives, apart from that beta, immunomodulators like TNF alpha inhibitors can be given. Clear about? Now, what can be the complications of these conditions beta? So do remember the complications of Crohn's disease. As I told you, it causes a lot of fibrosis beta. It can lead to formation of strictures in the intestine, leading to dynamic intestinal obstruction, right? Next, the patient may also have development of a perianal fistula. Yes, because of the because of the transmural involvement beta, it may actually lead to development of a fistula with the perianal skin. Yes, so one side there is connection with the intestine, another side there is connection with the perianal skin beta. That will be called as a perianal fistulae beta. And the patient may also develop a colorectal cancer as well. Now important, if I talk about beta, ulcerative colitis on the other hand, ulcerative colitis mein the complications can be: one, the patient is going to have toxic megacolon. Second, definitely beta, the patient definitely may have perforation, because ulceration hai. Due to that beta, the intestinal wall will become thinner and it can perforate also. And ultimately the patient will have even in ulcerative colitis, there will be equal chances of colorectal cancer in the patient. Clear about? So this table, if you remember beta, you will remember the inflammatory bowel disease in one go itself. Okay, तो याद रखना है बात. No issues with this. Next important, if they ask you beta, that if a patient is having an inflammatory bowel disease beta, and if the patient is having this perianal fistulae, okay, if a patient is a case of Crohn's disease and he has developed this perianal fistulae, so what should be the treatment? This was a previous year NEET PG question. याद रखना, Normally, whenever there is a perianal fistula, beta, we'll talk about that condition in a while. The management is surgical. But if that perianal fistula was due to inflammatory bowel disease or due to a Crohn's disease, beta, then the first line management is not surgical. Then we try to manage it medically, beta. Reason we know it is due to Crohn's now, so it will get healed in time. Okay. So if it does not get healed, then we will talk about surgery. But initial treatment, beta, has to be definitely, beta, a infliximab infusion. Infliximab is a TNF alpha inhibitor. It is a immunomodulator drug. So infliximab infusion will be given to the patient, which will help in causing fibrosis and closing the perianal fistula, beta. Yes. But in case, beta, it does not help, if it fails, then you may go for a surgical correction of the fistula. Hopefully that's clear to all of you. Yaad rakhna ye baat. This has been a previous year NEET PG question. If they ask you, beta, what is the surgery of choice? Now, do remember, here, beta, the patient is having a very high risk of cancer. That is the reason, beta, if the patient is not getting treated, okay, it's better to go for resection of the intestine, beta. Yes, we have to remove the intestine over here, beta. And removal of intestine, we have to remove the colon basically, beta. So we have to do a total colectomy. But in patients of ulcerative colitis, beta, we know even the rectum is involved. So we have to even remove the rectum also. Rectum is known as proctum. So ulcerative colitis, we have to go for a total proctocolectomy. See, in Crohn's disease, we have done a total colectomy. In ulcerative colitis, we will do a total proctocolectomy. After that, beta, what is left is the ileum. Now we have to bring the ileum, beta. Now obviously it is not possible to connect the ileum directly to the anal canal, beta. Reason is there is difference in the diameter. So that is the reason, beta, we actually create a J-shaped pouch of the ileum, and then to that J-shaped pouch, beta, we actually connect the anal canal. So this will be called as the ileal pouch anal anastomosis, beta. Right? What we have done over here, we have done a ileal pouch anal anastomosis. Clear about? That is important to be remembered. So the surgery of choice, I am writing total proctocolectomy, but yaad rakhna, proctum will not be removed in Crohn's disease because it is never involved. So surgery of choice is nothing else but total proctocolectomy. Proctocolectomy will be done in ulcerative colitis and colectomy only in Crohn's. So total proctocolectomy with an ileal pouch anal anastomosis, IPAA also you can call it as ileal pouch anal anastomosis. Now there was a previous year question of FMG exam once, and that was, what is the most common complication of this surgery which is done for the inflammatory bowel disease? Yaad rakhna, beta, if they ask you what is the most common complication of this surgery done for the inflammatory bowel disease, तो याद रखना है, it is nothing else but anybody, it is pouchitis, beta. ये जो pouch बनाया तुमने ileum का, okay, that pouch will undergo an inflammation, beta, and there will be pouchitis. This was a previous year question, याद रखना है pouchitis वाला. No issues with this, anybody? Chalo. Next important, beta, if I talk about, is nothing else but colorectal polyps, beta. Let's talk about the next topic, and that is colorectal polyps. Now, there are various types of polyps, beta, which will be present inside the patient's intestine or the rectum, beta. Okay? Let's talk about those polyps once. So the first one, if they ask you, beta, that which are going to be the most common polyps in the patient. If they ask you that which are going to be the most common polyps in the patient's intestine. So याद रखना है बच्चे, the most common polyps in the patient are going to be hyperplastic polyps. Now hyperplasia is what? Increase in the number of cells. So hyperplastic polyps, beta. When there is hyperplasia in the mucosa, no? So definitely that can lead to formation of hyperplastic polyps. But if they say, beta, that whether the hyperplastic polyps are pre-malignant or not. What do I mean by pre-malignant? Matlab whether they will further develop into a cancer or not. Okay, if they ask you this. So please remember, beta, though it is hyperplastic, okay, you have to remember they are not pre-malignant. Yes, a lot of times we may feel that it is pre-malignant. No. They are now the hyperplastic polyps in intestine, beta, they are basically not pre-malignant in nature. So the most common type of polyps in intestine are hyperplastic polyps. Are they pre-malignant? No, they are not pre-malignant, beta. Next important type of polyps, beta, in the intestine are going to be hematomatous polyps. Okay, now if I talk about the hematomatous polyps, beta, they will be seen in multiple conditions. Yaad rakhna, when hematomatous polyps are seen alone, matlab if hematomatous polyps is not a part of any syndrome or if it is not due to any gene mutation, then they will not be pre-malignant. But if hematomatous polyps are due to a particular gene mutation, beta, or if they are associated with certain syndrome, then definitely they will be pre-malignant in nature. Then definitely they may develop into a cancer. Okay? So if I talk about hematomatous polyps, the first condition with which it is associated is known as Peutz-Jeghers syndrome, beta. Now if I talk about Peutz-Jeghers syndrome, definitely please remember, Peutz-Jeghers syndrome definitely is a condition, beta, which is actually pre-malignant in nature, which may develop into colorectal cancer further. So Peutz-Jeghers syndrome is due to what pattern of, sorry, it is for going to follow which pattern of inheritance? I hope all of you are quite aware. The pattern of inheritance followed by Peutz-Jeghers syndrome is going to be AD, that is autosomal dominant. It follows autosomal dominant pattern of inheritance. Another important question, which is the gene mutation in Peutz-Jeghers syndrome? The gene mutation in Peutz-Jeghers syndrome is going to be the STK11 gene mutation, chromosome number 19. It is basically the STK11 gene mutation, beta, that you have to remember. Next important, what are the features in Peutz-Jeghers syndrome? Please remember this patient is going to have multiple hematomatous polyps, beta, in the intestine. Previous question again, which is the most common site in the intestine where these hematomatous polyps will be seen in the patient. तो याद रखना बेटा, the most common site is nothing else but the jejunum, beta. The most common site will be the jejunum. If they ask you that what is the most pathognomic feature, I hope all of you are quite aware. You might have seen in patients of Peutz-Jeghers syndrome, beta, in derma, in patho, in medicine, everywhere. ठीक है, तो in patients of Peutz-Jeghers syndrome बच्चे, there is a very classical feature. क्या होता है वो? Those brownish and blackish spots which are seen on the oral cavity or the lips, beta, right? So those brownish and blackish spots on the lips or the oral cavity of the patient, beta, those are the most pathognomic or the most important feature in a patient of Peutz-Jeghers syndrome. क्या बोलते हैं उसको? We can call it as perioral melanosis, beta. Okay, we can call it as perioral melanosis. In derma, there was a question in your exam that whether those are called as lentigens or freckles. क्या बोलते हैं उसको? These blackish brownish spots or perioral melanosis will be called as lentigens or freckles. तो याद रखना बेटा, those are known as lentigens. Hopefully you are quite aware about that. Next important, if they say beta that Peutz-Jeghers syndrome, obviously it is going to cause colorectal cancer. It also increases the risk of other cancer, but beta, it increases the risk of multiple cancers as I told you. But one such cancer is there, beta, whose risk is going to be almost increased by 100 times. Yes, there is one such cancer of your body, beta, in patients of Peutz-Jeghers syndrome, uski risk is going to increase 100 times, and that is nothing else but pancreatic cancer. The most common cancer, beta, which is usually seen in patients of Peutz-Jeghers syndrome is going to be pancreatic cancer. 100 times higher risk, beta, in these patients will be there. Okay, so that is important. Now, if they ask you about the second condition, beta, and that second condition we know is known as the Cowden syndrome, beta. If I talk about the Cowden syndrome now, okay, if I talk about the Cowden syndrome, we have discussed, beta, the Cowden syndrome also again has the same pattern of inheritance known as autosomal dominant as the pattern of inheritance. Gene mutation, I've already told you, beta, the gene mutation in patients of Cowden syndrome, recent question tha exam ka, it is known as the P10 gene mutation, chromosome number 10 itself. Okay, it is a P10 gene mutation, beta. And we know that Cowden syndrome also is going to have, Cowden syndrome is also going to have, beta, multiple hematomatous jejunal polyps. Okay, this is also going to have multiple hematomatous jejunal polyps. And please remember, beta, it will actually increase the risk of 3 cancers. What are the 3 cancers whose risk is going to increase in case of Cowden syndrome? I've told you yesterday in thyroid itself. Cowden syndrome increases the risk of BET cancers. I told you, या butt cancer, जो भी याद रखना तुम्हें, BET और BUT. ठीक है, तो BET और butt cancers. B stands for breast cancer, beta. Okay, U stands for uterine cancer, and E say you can remember endometrial cancer. Okay, you can remember anything. Either you can remember uterine cancer or you can remember the endometrial cancer, beta. And T say thyroid cancer. These are the 3 cancers, beta, whose risk is actually going to increase along with colorectal cancer. Okay, so colorectal cancer though is obviously there, beta, but apart from that, these 3 cancers ka risk is going to be high, beta, in a patient of Cowden syndrome. No issues with this. Now, the third type of polyps, we have seen about the hyperplastic polyps. Second, we have seen about the hematomatous polyps. Now, let's talk about the third type of polyps, beta, and those are going to be the inflammatory polyps. Now, we have just seen, beta, inflammatory polyps are actually not true polyps, those are pseudo polyps. Seen in which patients? It is seen in patients of ulcerative colitis, beta. याद रखना, the inflammatory polyps which are there, basically they are due to edema of the mucosa. Okay, the inflammatory polyps which are there, those are actually considered as pseudo polyps, beta, and it is usually seen in patients who are suffering from ulcerative colitis. Seen in patients of ulcerative colitis. Clear about? Please remember that these pseudo polyps or these inflammatory polyps are also not pre-malignant beta. Yes, याद रखना है, these inflammatory polyps or these pseudo polyps are also not pre-malignant. So you will say कि sir, ulcerative colitis as a disease is a pre-malignant condition, but these polyps are not the pre-malignant ones. ठीक है, तो याद रखना ये बात, it is not pre-malignant. Next, the last type of polyps beta which you might have seen in pathology as well, and those are adenomatous polyps. Very important. Adenomatous polyps which are there beta, those will have highest risk of malignancy. याद रखना, adenomatous polyps which are there beta, they will have definitely the highest risk of malignancy. If they ask you out of all the polyps of the intestine, which has highest risk of cancer or malignancy, answer is adenomatous polyps. Okay, these are highly malignant. So please remember, if they ask you beta, which is the most common type, there are three types of adenomatous polyps you might have discussed now. There will be tubular, tubulovillous and villous beta. So yaad rakhna, the most common type of adenomatous polyps will be the tubular variety. It is actually going to be beta, the tubular variety. But the most dangerous or the most malignant which is there beta, it is definitely going to be the tubulovillous variety. Sorry, it is the villous variety which will be even more malignant. The most malignant which is there beta, it is going to be the villous variety. Clear about that is important. Now if they ask you beta that these adenomatous polyps are seen in which conditions, you have to remember we have seen a condition beta jahan pe adenomatous polyps will be seen in the intestine. So adenomatous polyps beta are usually seen in a condition, and that condition is known as what? FAP. What is that FAP? Familial adenomatous polyposis beta, right? That condition is known as FAP, known as familial adenomatous polyposis. Now what is familial? Familial means which runs in the fam, which runs in the families beta, which is genetic or hereditary. Adenomatous polyposis, that is multiple adenomatous polyps will be seen in this patient. The pattern of inheritance over here is also autosomal dominant beta, that has to be remembered, and the gene mutation for familial adenomatous polyposis, I hope all of you are quite aware, is the APC, adenomatous polyposis coli. Okay, it is the APC gene mutation beta located on chromosome number 5. They have even asked chromosome from pathology, yaad rakhna ek baat. So it is the APC gene mutation beta on chromosome number 5 definitely, which is going to be responsible for FAP syndrome. If they ask you how many adenomatous polyps are seen in this patient, so yaad rakhna bache, these patients are actually going to have more than 100 adenomatous polyps beta. Yes, they have usually more than 100 adenomatous intestinal polyps over here. That is important to be remembered. Okay, more than 100 adenomatous polyps in the intestine, and obviously all of them definitely are going to be pre-malignant in nature beta, right? All of them definitely are going to be pre-malignant in nature. So how much percent is the risk of malignancy in familial adenomatous polyposis? कितना परसेंट रिस्क होता है कोलोरेक्टल कैंसर का? How much percent is the risk of colorectal cancer in patients of FAP syndrome? There is 100% risk of colorectal cancer beta in patients of FAP syndrome. Yes, there is going to be 100% risk of malignancy beta in patients of familial adenomatous polyposis. Now, when you know beta, that means each and every patient of familial adenomatous polyposis will surely develop a colorectal cancer sooner or later, but they are going to develop a cancer. तो याद रखना बेटा, in this condition, if we know that the patient is going to develop a cancer beta, what should be done then? In that condition, what we should do? We should go for removal of the colon itself beta, and that is called as a total proctocolectomy has to be done. और हमें पता है when we do a total proctocolectomy beta, after that the ileum is left. What we do? We actually make a J-shaped pouch of the ileum and then connect it with the anal canal. So total proctocolectomy with the ileal pouch. Total proctocolectomy with the ileal pouch anal anastomosis. Okay, total proctocolectomy with the ileal pouch anal anastomosis. No issues with this, anybody? That is important. Okay, this is the same surgery that we did for IBD beta. यहाँ पे भी वही करेंगे, but the only thing is this surgery which is there beta, it is done for treatment or prophylaxis. So please remember the surgery that we have done beta, it is actually going to be prophylactic. What do I mean by prophylactic? That means the patient has not developed a cancer yet. Even before that itself beta, we are going for the surgery because we know na 100% risk hai. So why let the patient develop the cancer first? Better go for the surgery early, right? That is important. Next important condition beta, which is also pre-malignant and which can actually increase the risk of colorectal cancer in the patient beta, and that condition is going to be HNPCC. You might have heard this condition. ठीक है, you might have heard about this condition that is known as HNPCC. HNPCC क्या होता है? हेरिडिटरी नॉन पॉलीपोसिस कोलोरेक्टल कैंसर और कोलोरेक्टल कार्सिनोमा. ठीक है, that condition is HNPCC. We know that HNPCC is a part of which syndrome? HNPCC is part of a Lynch syndrome, beta. It is actually a part of Lynch syndrome. Now it is due to which it is going to have which type of inheritance? Again, same. It is also going to have autosomal dominant pattern of inheritance itself, beta. It is also going to have autosomal dominant pattern of inheritance. याद रखना ये बात. And what is the gene mutation, beta? याद रख लो, the gene mutation in cases of HNPCC is going to be the MSH2 followed by the MLH1 gene mutation. It is going to be the MSH2 followed by the MLH1 gene mutation. Now I am going to ask this question to you, all of you, because this is a commonly repeated question of FMG examination. Patho biochem सबसे आता है. What is that? Which DNA repair defect is responsible if there is MSH2 or MLH1 gene mutation? ना इसकी वजह से which is that DNA repair defect which is going to cause HNPCC in the patient? बोलो जल्दी से in the chat box. The DNA repair defect which is the cause of HNPCC in the patient, beta. Anybody? Ray? Very common and a very important question. It is known as the mismatch repair gene defect. Very good. Yes, it is the mismatch repair defect, beta. ठीक है, so it is definitely a mismatch repair defect which is usually going to be the cause, beta, of a HNPCC or a Lynch syndrome. Clear है बात? That is important. No issues with this, anybody? That has to be remembered. Chalo. Next important if I could talk about is nothing else but the colorectal cancer. I hope all of you are quite aware that definitely we have discussed except oral cavity, esophagus and anal canal, everywhere we have squamous. So obviously the colorectal cancer has to be adenocarcinomas, beta. ठीक है, so colorectal cancer which is there, beta, it is going to be an adenocarcinoma except oral cavity, esophagus and the anal canal where we have the squamous cell carcinoma. बाकी पूरे GIT में there is adenocarcinoma. Now important is if they ask you what is the most common site, याद रखना the most common site for a colorectal cancer is going to be the rectum followed by the sigmoid colon. So rectosigmoid again. The most common site, beta, for the colorectal cancer is going to be rectum followed by the sigmoid colon, beta. Now important is what are the risk factors in a patient of colorectal cancer. So please remember the risk factors are, the first one is always that is alcohol, beta. Okay, the alcohol is actually considered as a risk factor. You will be like, sir, smoking which is there, beta, it is considered protective in some of the journals. Okay, textbooks do not say it completely, but yeah, some journals are definitely said that smoking can be a protective risk factor for colorectal cancer. Next important, beta, high fat diet definitely, beta, is going to be an important risk factor. High fat diet or even red meat for that matter. Reason, high fat diet or red meat, beta, is actually going to increase the risk of constipation, and a chronic constipation can increase the risk of colorectal cancer. Next important is polyps, beta, as we have discussed. Okay, we have discussed that hematomatous polyps or the adenomatous polyps, they are actually going to increase the risk of colorectal cancer, beta. Next is IBD. What is IBD? Inflammatory bowel disease, Crohn's and ulcerative. I've told you in both the conditions, beta, there can be a risk of colorectal carcinoma. Selenium deficiency is another important condition, beta, which may increase the risk. Family history of colorectal cancer, beta, is going to be important, and ureterosigmoidostomy. Now what is ureterosigmoidostomy, beta? See, previous days mein, when we used to remove the urinary bladder, after that, beta, we used to divert the ureters of the patient, beta, towards the sigmoid colon. Why? So that the urine was able to pass via the sigmoid colon. That means the urine was able to pass via the anal canal. Yes. So once you have removed, beta, the urinary bladder of a patient, after that, in previous days, you used to divert the ureters towards the sigmoid colon. That was called as a ureterosigmoidal anastomosis or a ureterosigmoidostomy. Problem क्या हुआ उससे, beta? We have observed that definitely as the urine was coming in contact with the sigmoid colon, the risk of sigmoid colon cancer in this patient was actually increasing. That's the reason this ureterosigmoidostomy is not followed nowadays. Nowadays, beta, if the bladder is removed, we either go for a ileal conduit or we definitely make a new bladder with the help of IVM. Okay, so that is what is done. If they ask you beta now for screening, why screening is important beta? A reason, the incidence of colorectal cancer is very high. It is among the top 3 cancers beta in males basically. That's the reason definitely you have to remember that colorectal cancer ki screening should be done. And if they ask you what is the best method for a colorectal cancer screening, the best method for a colorectal cancer screening has to be a colonoscopy beta. Okay? So colonoscopy would be the best method for cancer screening beta. Apart from that, we can also go for a fecal occult blood testing. Okay, so fecal occult blood testing can also be another method, but the most common the best method is going to be colonoscopy. Next important, what will be the clinical features in a patient of colorectal cancer? Obviously beta, there is a cancer which is developing in the colon. The patient may have bleeding per rectum beta. Okay, that is a lower GI hemorrhage can be there. The patient may have weight loss because it is a cancer. Patient is going to have altered bowel habits beta. Altered bowel habits means the patients can have constipation, or some patients can have diarrhea, or most of the patients may have beta sometimes diarrhea, sometimes constipation. That's the reason we have written it as altered bowel habits. Patient may also have a bowel obstruction because of that mass na, there can be a dynamic bowel obstruction. If I talk about the TNM staging, I hope all of you are quite aware that the TNM staging in all the GIT cancers, mainly the T staging, is based on depth of invasion. So T1 matlab involvement of mucosa and submucosa. T2 matlab involvement of muscularis, that is mucosa, submucosa, muscularis, everything is involved. T3 matlab the pericolorectal tissues are involved beta. Okay? So please remember T3 matlab the pericolorectal tissues are involved. T4A means involvement of the visceral peritoneum, the inner peritoneum which is there na, which is attached with the intestine. So T4A matlab involvement of the visceral peritoneum, and T4B matlab involvement of the adjacent organs beta. Okay, so that is important. If they ask you two important one-liners beta that you have to remember for your examination, and those two important one-liners are: first, the staging used for the colorectal cancer is known as, anybody name of the staging? The staging used for the colorectal cancer is known as, याद रखना बेटा, the staging that is used for colorectal cancer will be called as the Duke staging beta. Okay, the staging that is used for the colorectal cancer is known as the Duke staging. Previous year exam में पूछा था, the Duke staging is based on again depth of invasion. ठीक है, याद रखना ये बात. तो Duke staging is used for the staging of colorectal cancer. 3 things from Duke's beta, याद रखना. Duke staging for staging of colorectal cancer. Duke's criteria for the diagnosis of infective endocarditis, and Duke's grading for the severity of chronic stable angina. Right? These 3 Dukes you have to remember for your exams. Next important beta, if they ask you that what is going to be the most common site for distant metastasis, we know all the GIT cancers, the most common site for distant metastasis is bichara liver again. Okay, so liver is again going to be the most common site beta for distant metastasis even in a colorectal cancer. Now this table again for diagnosis beta, just like in esophageal cancer and gastric cancer we had beta, similar to that this table is going to be, that is going to be, see, if they say beta what is the investigation of choice, we know the best investigation for a cancer has to be a biopsy, but this time to take a biopsy beta we cannot perform an upper GI endoscopy. Upper GI endoscopy only for esophagus, stomach and duodenum, right? यहाँ पे क्या करना पड़ेगा, we have to go for a colonoscopy. तो investigation has to be a colonoscopy plus biopsy beta. Okay, investigation of choice has to be a colonoscopy with biopsy. That is important. If they ask you what is the investigation of choice beta for a T and N staging, now we know beta that T and N staging definitely, that is tumor and nodal staging. उसके लिए the investigation of choice in esophageal and gastric cancer was what? It was an endoscopic ultrasound. But here it is not that beta. Here it is an MRI. Okay, here definitely the investigation of choice for the tumor and nodal staging has to be MRI. If they ask you what is the investigation of choice for TNM staging overall, again same. For the distant metastasis, PET scan, and the local one, that is CT. So PET CT is the investigation of choice beta for the overall staging in a patient of colorectal cancer. Another important question, that what is the best tumor marker for a colorectal cancer? So I hope all of you are quite aware that the best tumor marker in a patient of colorectal cancer is going to be, anybody patho say, it is going to be serum CEA beta. What is CEA? Carcinoembryonic antigen, right? So please remember the carcinoembryonic antigen is considered as the best tumor marker in colorectal cancer. It can also be used as a tumor marker in multiple other conditions like the pancreatic cancer, but it is the best one for the colorectal cancer. Clear? Hai? When I go for a barium enema in a patient of colorectal cancer beta, okay, in a patient of colon cancer, when you go for a barium enema, see, and if there is this kind of a tumor beta from both the sides of the wall, Definitely you'll be able to see narrowing beta in the lumen basically. So a barium enema in a patient of colorectal cancer. Okay, a barium enema in a patient of colon cancer will give you a very classical appearance. And what is this appearance called as? So this appearance is known as the classical apple core appearance beta. So याद रखना, if they say apple core appearance on a barium enema, answer has to be a colon cancer or colorectal cancer. But if they say apple core appearance on a barium swallow, apple core appearance on a barium swallow, then answer has to be esophageal cancer beta. ठीक है, apple core appearance on a barium swallow can be seen in patients of esophageal carcinoma. Clear है बात? Next important beta, if they ask you about the management now. Okay, if they are going to ask you about the management, let's talk about the management now. Easy है beta. First one. Okay, first one which is there beta, it is nothing else but see, the patient is having a cancer in the cecum beta. If the patient is having a cancer in the cecum beta, you have to remove the whole right half of the colon. And when we remove the whole right half of the colon beta, that is called as a right hemicolectomy. So when the cancer is in the cecum, we have to go for a right hemicolectomy, which is clear. We have to go for a right hemicolectomy if there is a cecal cancer. Next, if the cancer is anywhere inside the ascending colon or in the hepatic flexure, this turn which is there is the hepatic flexure, or anywhere in the transverse colon beta, we have to go for a right hemicolectomy and we have to extend it and also remove the transverse colon. So what we should call it as now? Now it will be called as a extended right hemicolectomy, right? Now it should be called as. So if there is any cancer beta in the ascending colon or in the hepatic flexure or in the transverse colon, we have to go for an extended right hemicolectomy. We have to go for an extended right hemicolectomy. Next important beta, if I say if there is any cancer in the splenic flexure or the descending colon, any cancer in the splenic flexure or descending colon, you have to remove the right half of the colon beta. And removal of right half of the colon, okay, so descending colon or splenic flexure, if there is any cancer, removal of right half of the left half of the colon beta will be called as a left hemicolectomy. It should be called as a left hemicolectomy. Next important beta, it is nothing else but if there is any cancer in the sigmoid colon, bache. As you are able to see, if there is any cancer in the sigmoid colon, we are going to remove the sigmoid colon. That is called as a sigmoidectomy or sigmoid colectomy, whatever we call it as. Or sometimes beta, we also have to remove the rectum. Reason, the sigmoid colon and rectum beta, they share the blood supply and the lymphatics. That's the reason there is a very common risk that both these areas which are there beta, they are commonly involved together. So that's the reason beta, we may have to remove the sigmoid colon and rectum together. That will be called as low anterior resection. Okay, याद रखना, if the sigmoid colon is involved beta, either we can only go for a sigmoidectomy, which is rare, or we mainly go for beta or LAR. And what is that LAR? Low anterior resection, which we go for a LAR, that is a low anterior resection. Clear to all of you? Now let's talk about beta. If there is a rectal cancer, then what we do? Okay, rectal cancer mein beta, you have to remember what is done. And rectal cancer ke liye you have to remember the anatomy first. तो यहाँ पे बता रहा हूँ मैं, understand. For example beta, ठीक है, this is the anal verge or the anal opening. जो बाहर की anal opening होती है ना, that is this one. This one which is there beta, which divides the anal canal into two halves. This line over here is definitely known as the dentate line or the pectinate line beta. Okay, which divides the anal canal into two halves. This ring over here which is there beta, this ring is known as the anorectal ring beta. Okay, that is important. Now here definitely beta, we are going to have two sphincters. This one which is there beta, this green one that you are able to see, this ring over here is the anorectal ring, as I told you. Okay, this green one that you are able to see beta is definitely called as the which sphincter? It is known as the internal anal sphincter. And then beta, we are able to see these red ones. These are which ones beta? These are definitely the external anal sphincter. Okay. Now important is, please remember the distance between the anal verge and the dentate line is 2.5 centimeters beta. The distance between the anal verge and dentate line is 2.5 centimeter, and the distance between the dentate line and the anorectal ring is further 2.5 centimeters beta. Clear about? So the total length of the anal canal will be around 5 centimeters. Important. If I say beta that if there is any cancer, if there is any rectal cancer beta in this area, ठीक है, if there is any cancer, any rectal cancer बेटा, more than 5 centimeters away from the anal opening, right? From more than 5 centimeters away from the anal verge, if there is any rectal cancer, then what we have to do? We can easily take a proximal 5 centimeter margin and a distal 2 centimeter margin beta, and we can remove the rectum of the patient, and along with that sometimes we have to remove the sigmoid colon of the patient, and we can go for a surgery known as LAR or a low anterior resection beta. But अब मुझे बताओ, if there is any cancer within the 5 centimeter range of the anal verge, if there is any rectal cancer within the 5 centimeter range of the anal verge beta, is it possible to remove the cancer without damaging the sphincters? Is it possible to remove this cancer beta without damaging the sphincters? No, we have to damage the anal sphincters. So beta, here we do a surgery which is called as APR, abdominoperineal resection beta. So surgery में क्या होता है? One team operates from the abdomen, one team operates from the perineum. We separate the sigmoid colon and the rectum properly and we resect it out. But obviously in this surgery beta, the anal sphincters of the patient will get damaged. And if the anal sphincters are damaged beta, we know what is the function of anal sphincters. They will control whether the anal canal of the patient is going to close or it is going to open up. Matlab, it actually controls the passage of feces beta. If the anal sphincters are damaged, the anal sphincters will never be able to close beta, and therefore the anal canal will always remain open, and there will be a constant leakage of feces which will happen, called as anal incontinence or a fecal incontinence in the patient. So therefore beta, can you let the patient pass the feces from the anal canal now? No. So what we should do in this condition after removing the rectum? We should close the anal canal beta, and we should bring out the descending colon on the anterior abdominal wall, and now permanently, yes, permanently the patient will pass feces via this opening bit over here, and that is called as a colostomy. So we have to do a permanent end colostomy beta in the patient after the surgery known as APR or abdominoperineal resection. Clear hai baat? Chalo. So that is important to be remembered. So yes, so if I talk about beta the rectum over here, so yaad rakhna, rectum mein definitely the margin status that is taken in rectum, the margin status that is usually taken beta, it is the proximal how much margin? So proximal margin which is there beta, it is 5 centimeters as I've told you, and distal how much margin? Distal margin is around 2 centimeters beta. Okay. Now important is, if I say if the cancer is more than 5 centimeters away from the anal verge, if it is more than 5 centimeters from the anal verge beta, obviously here we can save the sphincter, and therefore we can go for a sphincter saving surgery, and that is called as a low anterior resection beta. Barabar. But if the cancer is within the 5 centimeter range of the anal verge, if the cancer is within the 5 centimeter range of the anal verge, it is not possible beta to save the anal sphincters. The sphincters are going to get damaged. So we go for a surgery known as a APR, that is known as abdominoperineal resection. And after doing abdominoperineal resection, once the sphincters are damaged, we have to go for a permanent end colostomy in the patient, with a permanent end colostomy. Did all of you know? No issues with this, anybody? Hello. Now if they ask you beta radiotherapy, I hope all of you are quite aware beta. Please remember that the radiotherapy which is there, that radiotherapy is only given, only and only given for rectal cancer. I have told you the reason behind it. Reason beta, if you give radiotherapy for a colon cancer, that will cause a lot of fibrosis and strictures inside the colon. Okay, so radiotherapy is only and only given for a rectal cancer because the rectal mucosa is resistant somewhat. Okay, so that's the reason. Important is beta, if I talk about the chemotherapy, chemotherapy is given whenever the lymph nodes are positive, or it is also given beta in the advanced stages. Advanced stages matlab T3A beta, that T3 definitely, that is involvement of the pericolorectal tissues, or T4A, that is visceral peritoneum involvement, or T4B, that is the adjacent organ involvement. Okay, so in the stages T3 or T4 beta, or even in patients of distant metastasis when the cancer has spread to the liver, in all these conditions we have to give chemotherapy. In pharmacology, you might have discussed about the 3 chemotherapy regimes beta that we use for colorectal cancer. One of them has been asked in your exam prior, and that was about the FOLFIRI regime. अगर वो पूछते हैं बेटा, for example, FOL, basically what is FOL? FOL stands for folinic acid बच्चे. FOL basically stands for folinic acid. Stands for what beta? That F basically stands for 5-fluorouracil beta. That F stands for a 5-fluorouracil, and ERI stands for irinotecan. IRI stands for irinotecan. These are the three drugs beta which are used in the Folfiri regime. Next is the Folfox regime beta. If I talk about Folfox regime, Fol again stands for the same drug, folinic acid. F also again stands for the same drug, that is 5-fluorouracil beta. The ox which is there beta, here it stands for another drug known as oxaliplatin. Ox stands for oxaliplatin. Last chemotherapy regime that is used over here beta is going to be the Capiox regime. Now Capiox mein se two drugs are given. Cape stands for capecitabine and ox stands for oxaliplatin. Clear to all of you? These are the three chemotherapy regimes beta which could be used in the chemotherapy in a patient of colorectal cancer. Okay? This has been a previous year question of your exam. Yaad rakho. Done with this? Let's talk about anal cancer and then we can take a break. Anal cancer, if I talk about beta, okay, we know that anal canal which is there, it is usually lined by the stratified squamous epithelium. So obviously the anal cancer is going to be beta what? The anal cancer is going to be a squamous cell carcinoma beta. Is there a possibility that the patient may have a adenocarcinoma in the anal canal? Yes, there can be a possibility beta. Okay, but that's very, very rare. The anal cancer which is there beta, it is going to be a squamous cell carcinoma mainly. Very rare that the patient may develop a adenocarcinoma. Whenever the patient has a adenocarcinoma of anal canal, yaad rakhna hai, whenever the patient has a adenocarcinoma of anal canal beta, it is mandatory that the patient should be treated as a rectal cancer. Yes, yaad rakhna, adenocarcinoma of anal canal should be treated as rectal cancer beta. We have seen the management of rectal cancer just like that beta. You have to treat this patient, whichever person is having a adenocarcinoma of the anal canal. If they ask you what is the most common type, so please remember we have discussed beta, the most common type is SCC basically, that is a squamous cell carcinoma. If they ask you what are the risk factors beta, yaad rakhna, the risk factors in a patient of anal cancer beta, the risk factors in a patient of anal cancer. We know anal cancer is usually more common beta in the elderly patients basically. That means it is actually going to be more common beta in the immunocompromised patients. So it is going to be more common in the immunocompromised patients beta. Okay, that has to be remembered. And it is associated with the infection beta. That viral infection basically can cause a anogenital warts known as condyloma acuminata. So the low risk strains of this virus known as HPV, human papilloma virus, can definitely cause the condyloma acuminata beta or the anogenital warts. Those low risk strains which causes warts are known as 6 and 11. But the high risk strains which are there beta known as 16 and 18. Those are definitely associated beta with the anal cancer as well. Okay, so that is important. More common being 16, more dangerous being 18. They ask you beta what will be the symptoms of the patient. The patient may have bleeding, the patient may have mass, or the patient may have obstruction due to that cancer beta. As you are able to see, this is the picture of a anal cancer beta. Can you see this mass? This is the mass coming out of the anal canal. Investigation of choice, if they ask you beta, yaad rakhna hai, investigation of choice is nothing else but biopsy. You can easily take a biopsy from this mass. It is visible. If they ask you extent of disease, how to check definitely how deep the cancer is, how many structures it has involved. So extent of disease can be assessed with the help of MRI beta. Extent of disease can be assessed with the help of MRI. If they ask you what is the treatment of choice, so do remember beta, in anal cancer beta, we know that if we perform a surgery, we have to damage the anal sphincters. So here what we do beta, rather than performing a surgery beta, we actually go for a simultaneous chemotherapy as well as radiotherapy together. Yes, dono ek sath karte beta. Right, so the treatment of choice you have to remember beta is nothing else but chemoradiation. The treatment of choice that we do in patients of anal canal cancer beta is a chemoradiation, and this has been a previous year question, because you tend to mark some surgery. Okay, yaad rakhna, it is chemoradiation beta for anal canal cancer, and they have also asked the name of the regime. The regime with which you can give a chemotherapy beta in a patient of anal canal cancer is known as Negro's regime. Remember the name also. Okay, so chemoradiation beta, it is definitely the treatment of choice for anal cancer, and the regime which is there beta, it is known as the Negro's regime. Now, even after giving the chemoradiation or even after giving the Negro's regime beta, if the patient is having a residual tumor, okay, if the patient is having any kind of a residual tumor beta, then what we have to go for? Then definitely we have to go for a surgery itself beta, and that is called as the same surgery known as abdominoperineal resection with a permanent colostomy. You have to go for a abdominoperineal resection where we remove or resect that cancer beta. But after that, the anal sphincters are damaged and therefore we have to go for a permanent colostomy. You can also go for a loop colostomy. We'll discuss that. Abdominoperineal resection with permanent and colostomy. No issues with this, anybody? Chalo. Take a small break and after the break, we'll discuss further. Okay?